Good morning, everyone. Am I audible?
Yes, sir.
Am I audible to you all?
Yes, sir.
We're going to start with the day 2 of Endo Mastery Summit, Apex Ascent Mastering the Pinnacle of Endodontic Precision, starting with our first lecture by Dr. Sarita Bhandari. Ma'am, she is Chief Consultant at Apollo Vellore, and ma'am will be talking us about the technology, digital endo and practice growth, magnification mastery, loops, microscope, and 3D visualization. We welcome you, ma'am. Ma'am, we are good to go. Ma'am, is there any issue with the tech?
Hello, am I audible?
Yes, ma'am, you are audible. Ma'am, I also request you to kindly turn on your video so that student can interact with you. Yes, ma'am, you are audible. We can start.
First of all, a very, very good morning to all of you. Thank you so much for taking out some time on this Sunday morning and coming up here to listen to my lecture. 1 minute, I think my. Just give me a minute. I think my slideshow is not working. So once again, a very good morning to all of you. I think there is some technical glitches. I'm not able to show the entire screen, but okay, let's start it. So magnification. So why the hell this term magnification is there? Why do we actually need it in dentistry? So every other day, I'm basically an endodontist. So most of the time, you might have seen people boasting about it as a blindfolded procedure. There is nothing to see, but still these people are doing something, and they are just taking the teeth, and they are just doing something inside the teeth. But what exactly? Nobody knows. But no, these days it's not like that. We can see inside the canal. Yes, we can see inside the small restorations, and there is a lot more to see. What personally I feel after doing these many root canal treatments or being in dentistry from so many years, you can't treat a patient until and unless you can see the field. So magnification plays a very important role in dentistry, not just in endo or conservative, but also in prosto, in minor surgical procedures. And there's a lot more to do under magnification. It is actually a myth that only endo people use microscope or loupes. It is meant for each and everyone. It is actually meant for each and every case, and you should start doing your practice, or you should start implementing magnification in each and every case of yours. I will just try to give a small brief about what exactly is magnification. So first of all, why it is essential. See, our human eyes know they it is actually a gift from the mother nature. And just imagine we have two pair of eyes, but still with two pair of eyes, with one pair of eye and two eyes, and we can see the entire world around us. And even we have few properties of our eyes which most of the animals or most of the living creatures they don't even have. So the very first thing is something called as resolving power. So I was an academician before, so let's get into some theoretical aspects which are actually very much important when it comes to magnification and understanding the scientific fact that why we emphasize so much on magnification. The very first thing is resolving power. What is resolving power? Resolving power is nothing other than when you keep two objects together, there has to be a difference of zero point 0.2 mm, which is roughly around 200 micrometers, until unless there is a distance of zero point 0.2 mm or 200 micrometers, our human eyes will not be able to appreciate whether these two objects are kept separately or they both are all together. It is a single entity. I can give you a better example. Whenever we are doing a cementation or when we are doing our luting procedure, it is always said that it should be at least the thickness of that cement should be at least 20 to 30 micrometers. But the resolving power of our eyes is just 200 micrometers. So obviously, whenever you are doing a cementation or luting, that zero point 0.2 micrometer, obviously our eyes can't see it, but actually there is a difference. There is a small cement lining which is lying behind there of 20 micrometers, which obviously to go into that precision, it is humanly not possible. It is not our fault. It is not Mother Nature's fault. It is actually a marvelous gift of nature, but our eyes do have limitations. And to overcome this limitation, you need to go for some higher end of magnification or higher end of resolution. So I think my okay. So why it just let me just summarize why we need. I think there's some technical glitch. Just give me 1 minute. Okay. So why we need this magnification in our day-to-day practice. Obviously, I just told you there is something called as resolving power. So for better precision and accuracy, you can't treat any patient if you can't see. You can't see the field, you can't treat the patient. Then it's all about ergonomics. You might have seen people sitting in very bad postures and doing the entire treatment. It's right now you are all are young dentists, so maybe right now you are able to accommodate with that positions. But in a long run, your neck, your back, definitely they are going to pain. If you want, have you ever seen when in your with your colleagues also, and we are trying in order to see the position because our mouth, our oral cavity is already very small, and in order to just see the location, in order to just see the field, locate the field, we just try to change our position so that we can see the field more clearly. I will tell you in my further slides like why we need to do that. But we always try to change our postures in order to see the field properly, especially in indirect vision, in the maxillary arch. That is what is ergonomics. That is where the importance of magnification, our loupes and microscopes, even gets highlighted, and it becomes more important. Then, if you can see better, you can even go for the early detection of some issues. So, if there is some minor crack is there, which is obviously is not very much visible in with your naked eyes, with magnification, with higher version of when the same field it gets 10x, you will be able to detect the issues priorly and properly. Then for patient education, obviously when you are able to detect the issue at an early stage, you can educate your patient also better. Then you can even reduce the eye fatigue because you don't have to focus on the field again and again with your naked eyes. Your posture will be will be a better. Your eye fatigue will reduce, and then career longevity. So there is one of my professor who was actually very good in his work. He was somewhere around 55. He had a excellent practical hand. But after a while, at the age of 55, we finish our education itself by 27, 28. And at the age of 55, just after somewhere around 20, 22 years of practice, he had to leave dentistry just because he started getting a severe backache and neck ache. If you want to improve the longevity of your career, definitely you should go for some magnification so that you can improve your posture and you can even enhance your career life as well. So the next question is magnification is just there for endo or conservative? No, it's for magnification is not just for endo. We also use it in conservative dentistry. We also use it in orthodontics. We also use it in prosthodontics. For each and every minor marginal line, your finished lines, you can even see better when you are using magnification. So, and it is nothing new. It is something which actually came in 1860s in some other version. Initially, when we started with magnification, we started with microscope. It was basically from ENT people. ENT people used to have a microscope, which was later modified into a normal microscope, into a dental microscope, which these days we are using it. And the very first microscope, which was actually ergonomic for the dentist, was introduced in 1978. And later on, we even evolved with Loupes, which we are these days we use it with our common day-to-day practice. So here there is an article where you can even see naked eyes magnification is 0 and the resolution in is 0.2 with a low power loupes. You can even go for a magnification till 2x, and these days we have even more powerful loupes where you can even go till 6x also. So you can have even a better magnification with your loupes as well. And then microscope is boss of magnification. So here are a few terminologies that I want to discuss with you so that whenever you are jumping up in dentistry with magnification, it will be slightly helpful for you to choose your equipment. So the very first thing is field of view. Field of view is nothing but what all you can see at one vision. So right now you just try to just focus on your screen and just try to see what all things you can see. You might be able to see your screen. If you are using a phone, you might be able to see your phone surrounding things also. But all that thing at one side, what all things you are able to see is called field of vision. If with magnification, if I'll try to just zoom out my picture, the same picture of the fly. Now the picture is even more enhanced. Now I can just focus on the eyes of this fly, the wings, and the background is completely green. If I will increase it little more further, now my field of view is even shorter. Now I can just see the eyes and some tweaks of this fly. So that's how the field of this is what is meant by field of view. At one side, at one vision, what all things you can see. That is called as field of vision, field of view. In dentistry, see, this is an image that you might, the very first image, you might see a picture where what is seen by a naked eye. So with magnification, with Loupes, with 3.5x resolution, you can see a small black dot there. If you will even enhance your field of view or your magnification, you see the size of that black triangle is even more enhanced. And what if I increase my resolution little more? So with 8x, I can see it. It was not a small black dot, it is a black lining completely. Then even with 13.x, I can see it is even more better. The visibility is even more better. Now I can see the shape also. See, and under microscope, if I'm going to see the same thing, it is going in under 21x. Can you see? It is was not a small triangle, it is a very big line, and this is called as black triangle in conservative dentistry and prostho as well. But if you will get this much big vision, if the field of vision is this much enhanced and enlarged, obviously you can treat a patient better, especially in aesthetic dentistry. Then very next term is depth of field. Why this term depth of field is important? Let me show you in this picture. See, this is what we can see in a normal oral cavity, in a normal vision. Depth of field means the particular object where you want to focus, how clear it is. So in this picture, if you will see this molar, I just want to treat this molar with this amalgam restoration. I just want to re-restore this restoration. So once I will remove this amalgam properly, completely, then only I can do a good composite in this tooth. So this is called as depth of field. I'm not bothered about second molar. Sorry, this is a second molar. So I'm not bothered about this third molar. I'm not bothered about this first molar. My requirement is only this tooth. So depth of field. I'm not concerned about any other thing, any other surrounding structures. I'm just bothered about this. So this is the depth of field. Depth of field means the only object that you want to focus and the surrounding areas are irrelevant irrelevant, and this is called as depth of field. This is how you can talk in photography, in photography or in optical terminology is the area that you want to focus on and rest of the areas are irrelevant to you. So if you will just try to think it in terms of layers, the very first layer is these three teeth, this teeth, and rest everything is called as second image. So that is everything else is your second field. So in dentistry, in especially in endo and conservative, this part is their first field of vision. So that is called as depth of field. The very next term is your working distance. So here I will try to explain you all. I want to explain you what exactly is ergonomics and this working distance means. Have you seen people working like this? In order to get a better picture, we always try to bend our neck or back so that we can see the field more properly. and the enhanced image of the teeth. Because until unless you are able to see the teeth, you can't do the entire procedure just with the tactile sensation, especially when you are working for the small cavities, or especially when you are doing the tooth preparations where you need a finer margins. Dentistry is all about even micrometers, 20 micrometer, 30 micrometer. And being an endodontist, everything, the entire procedure, the entire treatment, it all depends on zero point 0.5 mm. If we are zero point 0.5 mm short, the case is gone. The prognosis, the entire prognosis of the treatment, everything is, it lies in millimeters, and that to micrometers. So it's not our fault. It's all about, we want a very clear and a very enhanced view of the field. That's why we try to always bend our neck or back, or we try for some kind of postures where we can see the teeth properly. So end of the day, we end up doing we end up in such kind of positions. And here comes magnification. With magnification, you can see how this dentist, now he has improved his posture with the help of loupes rather than getting inside the patient's mouth. Now with a certain distance, he can work properly. So this is called as working distance. The area from the loupes and from your eyes till your field. So this is called as working distance. The another term which is important for you when you're going for any sort of magnification devices like microscope or loupes, that is called as IPD, interpupillary distance. So what is interpupillary distance? It is the distance between, when you are looking straight, the distance between which can be measured from one pupilla to another pupilla, that is called as interpupillary distance. So in this case, from this pupilla, from this pupilla, and mind it, each and every person, this interpupillary distance can vary. So for whenever you are going for to buy a loupes or a microscope, you need to measure your interpupillary distance. In microscopes, mostly we have adjustable interpupillary distance, but for loupes, at times if you're going for ergonomic loupes, then the manufacturer is going to give you a loupes which where he has to measure your interpupillary distance, and he is going to provide you a loop which is only meant for you. It is customized just for you. So in that case, your interpupillary distance is very, very important. So let's see like what kind of magnifications are there in dentistry. So in dentistry, we have something called as microscopes and loupes. I think like you all must be familiar about these two terms, and you must have seen people using these microscopes and loupes. So first, let's just talk. I will just give you a brief about microscope. So, what are the parts of microscope? How we classify microscope? So, we classify microscope as a this is a mobile one. Okay, this is a mobile one, and the second picture, it is a wall mounted. So, this is the entire microscope, and it is mounted with the wall. So, it is wall mounted, and this is roof mounted microscope. The very first picture is your mobile microscope. So this microscope, you don't need to just mount it in the wall or floor or the roof. You can move it according to your clinical setup. You don't need to you can just shift it. If by chance you need to shift your clinic or anything, you can just shift it. If you want to shift it from one chair to another chair, this mobile microscopes are way more better than other two kind of microscopes. Other two kind of microscopes, your floor mount, your wall mounted or your roof mounted, mostly use it in clinical scenarios or in very big setups where you know like you are not going to change your clinic for a very long time. So let's talk about the body of the microscope. These are two types of microscopes. This is called as inclined microscope, and this is something called as inclined navel microscope. What are these two terms? Here, if you will see this piece, here there's a hinge. So if you are able, you can just adjust that hinge. These are the binoculars from where you are going. This is the eyepiece from where you are going to see your field. So you can just, with the help of this hinge, you can adjust your eyepieces. So this is called as inclinable microscope, and in this one it is fixed. So if at all you're going to go and buy for a microscope, you can just go for an inclinable one. It is slightly expensive, but yes, you can go about it. Then we have something called as eyepiece. So this is the eyepiece. Mostly this is a latex-free eyepieces. These are the rubber cups from where you can keep your eyes steady and you can see the field properly. So um, this is a binocular. This is the eyepiece. And here, somewhere here, you will see your lenses are fixed by the manufacturers. From here, your light will enter, and from your binoculars, it will get adjusted into some particular angles, and you can see your field. Then we have something called as magnification changer. So in Loupes, we have a fixed magnification, but in microscope, you can adjust your magnification. So it starts from 1x, from 0.5x to 1x, and it can, these days, microscopes even go for 20 to 30x as well. So 0.5, and then you can just rotate this magnification changer, and then you can enhance your magnification. And then we have something called as handles. So this handles, you can just use it for adjusting your microscope. This is the main part of this is the body of your microscope. And these are the handles from where with the help of these, we can just adjust the positioning of the entire microscope. Then we have something called as light source. So there are three types of lights which are there for the microscope: halogen, xenon, and LED, LED. So mm, these days we prefer the LED kind of lights. Till date we have xenon lights and halogen lights are also there, but the disadvantage of these lights are halogen lights are they will give you a yellowish hue. So LED lights are cheaper, and these days more and their even life is also their average lifespan is also quite good. So mostly in these days microscope we go for a LED one, and earlier days we used to have xenon and halogen, but it is slightly cheap, so even xenon and halogen lights are also available there. But you make sure whenever you are buying some microscope, go for the LED one. Then in composite restoration, the entire game is about your shade selection. So in microscope, if you are using a white light or an external light source, because whenever we study or whenever we are talking about composites, we always talk about the shade selection, and there should not be any external light source because it will get pre-cured. So how we do our composite restorations under microscope? So there is something called as filters. So composite microscope, whenever you are doing any restorations under microscope, there is something called as filters. So you can switch on the filter. We have different type of filters for natural light and for yellowish light and all. So you can just adjust your filter accordingly whenever you are doing a composite restoration. So under the microscope, the color of your composite is not going to change. You can just do a prior shade selection and do the entire restoration with the help of these filters under microscope. And we have even anti-glare mode or polarizing mode, because when you're working under microscope, there is a huge light source, and it's a kind of very enhanced with our systems, our laptops or our desktops. So same almost same kind of a thing which we have in our polarizing polarizing filter, which is there in your microscope as well. Then I will just skip this part. Okay, so how to adjust your IPD and how to, I will just, let me just be more clinical. So how to adjust your IPD? It is true for your loops as well and for your microscope as well. You have to orient your lenses and just try, close one eye and then just try to see your thumb. Just try to see your thumb whether there are two images or one. Then correct your IPD, interpupillary distance, in microscope and in loops, also in ergonomic loops or in flip up loops. At times we have adjustment for the interpupillary distance, IPR, and try to make it one. Once you are able to make it as one, it should be a single image. It should not be a double image. Once you are able to make it one, that is the correct position and we are good to go about it. Um, let's talk about the loops now. There is a lot more to talk about microscopes, but we have time limitation. So let's jump up for loops now. So for your loops, you might have heard a lot of terminologies: TTL loops, flip up loops, ergonomic loops, Galilean loops, prismatic loops, so many types of things. And there are certain brands which even come up with different short forms and all. But I will just try to give you some basics before you go and buy a loop for yourself. I'll just try to give you some basics how to select the loops that you actually want, you can use in your practice, day-to-day practice, and the terminologies, what that manufacturers or the uh, that reps will come and they will take in front of you and you will be like completely clueless about it, what these people are talking about, and they might make you fool out of it. So first of all, I would suggest, like, you might have seen these kind of loops in Amazon and in other websites. So these kinds of loops are completely waste of time. You might get such kind of loops maybe another 2000, 3000 rupees and all, but that 2000, 3000 rupees is actually a waste for such kind of loops. These loops are basically single lens loops, which is comparatively equal to our normal eyes or our naked eyes. So it is not going to enhance your vision. It is exactly same how you, whatever you can see with your naked eyes, the same kind of picture it is going to give. And if by chance you are starting your magnification journey with such kind of loops, it is completely waste of time and you will fail it, like it is completely waste of time. Loops doesn't work out. No, loops do work out, but please don't buy such kind of loops. Otherwise, you are going to have a false image about loops every other time. So what I would suggest is, please don't waste that 2000 rupees also for such kind of loops. Don't go for any cheap brands and all. If you are interested in magnification, if you want to follow dentistry even better, go for loops and go for some standard loops. Go for some good companies, good brands, and go for some better kind of loops. Then let me give you a brief about the types of loops which are there with us. There's something called as Galilean loops and prismatic loops. So because of the optical designing, these two terms are there. I will just give you a brief. Galilean loops means there are two types of two lenses which are in a sequence. They have, the manufacturers are going to keep them to give a better magnification. In Galilean loops, you have a range from about 2 to 3.5x magnification. And for prismatic loops, if you will see this picture, the lens size itself is too big. Here there's a prism which is kept inside it. There's one more term is there which we call as Keplerian loops. Keplerian loops and prismatic loops are nothing but same. Capillary loops or prismatic loops, why it is called as prismatic loops is because inside this lenses you have a prism inside. It's a prism of lenses inside it. That's why it is looking heavier and the lens size is also quite big. It provides you a better magnification. It might go from 3.5 to about 4.5 or about 6x also these days. So obviously these will be slightly heavy in comparison to Galilean loops, but it all depends upon the need of magnification that you have for your own clinical practice. So you can choose the loops according to your need. Then we come up with some term that is called as TTL lenses, TTL loops, and there is something called as flip up loops. So TTL means through the lens. So this kind of through the lens means these eyepieces are fixed in your glasses, and you can just you can't turn it on. Like this flip up, there is a hinge here, and you can just turn that eyepieces up and down. The good thing about this flip up is, if suppose I'm doing endo, by chance my assistant is not there that day, my assistant is on leave, I can just, while doing the procedure, if I need some other instrument, if I want to hold up some other instrument, I can just flip it off. I will just use my files or whatever small instruments I need. I can just pick it up and I can use it. With TTL, that is not possible. You have to entirely move. You have to, rather you remove it, or otherwise, you need an assistant with TTL loops to make your work simpler. But there are good things also about your TTL loops. One thing is, there is no hinge involved in your TTL loops, so it is lighter in weight. And but obviously the interpupillary distance is fixed for this one. Anytime you are going for TTL loops, it is kind of ergonomic loops. So your manufacturer or your company people are going to make these kind of just for you. Or there are some fixed IPDs what they already have, they are going to provide you with that. Your flip-up loops, they have a hinge. So obviously they are slightly heavy in weight, but in because of this hinge, they have a facility to change the IPR as well. So IPD as well. So you can change your IPD here in with this kind of hinge also. And here you can see a small light is also attached here. The good thing about flip up is they are slightly heavy, but they are cheaper in range. If you want to go for a cheaper version, it costs you around somewhere around 30 to 40,000. You can go for a flip up. TTL loops are slightly expensive, but obviously they are of premium quality. It might range you from somewhere around 70 to 80,000, but TTL loops are lighter in weight, so you are not going to feel any pressure over your nose. So it all depends upon your budget also and the kind of quality that you want to inculcate in your practice. Then how you can decide about about what kind of loops you should go for. So the very first thing that you need to consider is what kind of magnification you want, how much magnification you want. So the more magnification you need, the more weight it is going to have. So if you have just a requirement of 3.5x, so what, like for day to day normal journal practice, we require maybe around 2 to 3.5x magnification. You can even go for a TTL loops or a Galilean loops. So what kind of magnification, what kind of optics you opt for. And if you want a higher end magnification, you can even go, you have to go for a prismatic loop, and then it all depends, prismatic loop, but it is definitely more the magnification, it is going to be more heavy and it is going to have a more weight. So accordingly, you have to choose what kind of magnification is required in your own practice. Then there is something called as declination angle. So here comes the importance of your ergonomic loops. What is declination angle? From your eyesight, just make a when you are seeing straight forward, there is, if you will draw a and uh, horizontal line and your field of vision. When you're keeping your head straight and you want to see down, this is called as declination angle. So in order to improve our this declination angle, if we are not using magnification, any kind of magnification, loops or microscope, we try to bend our neck. So that is because we want to change the declination angle. But with your ergonomic loops, you can slightly you can improve it. How? This lady is wearing ergonomics loop right now, so the angulation of your lenses is going to be completely down. People might think like you are seeing the door, or your vision is completely towards the door, but actually you have improved your posture, and you can improve your declination angle like this. So whether you want to, if somebody is having already suffering from neck pain, back pain, like most of the endo people do, you can go for ergonomic loops, and you have to choose for your declination angle, what kind of declination angle you want, and you can choose accordingly. So the next thing, a very brief thing that I want to talk about loops is also the selection of lights. What kind of lights you want? So there are two types of lights which are available with the loops, and definitely these lights are at least going to enhance your vision up to, according to my experience in my own practice, it's like around 30%. You can say it is going to enhance the vision. So light is, if you are going for loops, definitely it is a must go for a, just invest in some good light also. The very first picture, this is a wireless light, and it comes with a battery. If you will see this hinge, it has a battery also, so you don't need to charge it. It is a wireless one, and but obviously because of this battery, it is going to be slightly heavy on your nose. Then the second picture, it is a one which with a wire. It is a wired one, so you just have a light here, and this is a wired one. So this wired one has a battery backup. That wire might be slightly uncomfortable for you, and it might cause slight discomfort when you are a beginner, but with time you will become habitual with this. With wireless one, it is slightly heavier on your nose, and the battery life is not that great. So according to your budget and your wish, you can go for whatever is whatever whatever loops you're comfortable with, you can go about it. So here comes my conclusion. You must either modify your dreams or magnify your skills. So it is just a brief about magnification, how you can enhance your field of view, and you can improve your uh, treatment. And again, I will tell you the same thing. You can only treat when you can see better. If you are able to see, you can treat it. Otherwise, there is no point of treating the patients blindfolded. So, this is the end of my presentation. Hope after this presentation, you might inculcate some sort of magnification in your day to day practice. If you have any doubts, you can just mail me also, or you can even text me also. And yeah, I'm open for the questions now.
Can you explain polarizing filter?
I request the participants to kindly write the question in the chat box.
Okay, so I got some question. What is polarizing filter? So this polarizing filters are nothing but it is there to reduce the external reflections whenever you are going for your composite restoration, especially. So the entire concept of composite restoration, it all lies behind your shade selection, and at that particular point you need to remove the extra light so that you can finish it, because composites is all about shades, your dentine shade, your enamel shade, and if you are using some external source, it is going to have a slight change of color when you are working with composite. So this polarizing filters, they are going to reduce that external reflections of that extra light and everything. and it is going to help you for your composite restorations. Another question. See, next question is when in clinical practice, which loop is best suited when patient's treatment involves root canal treatment and direct pulp capping? For endo, actually, the better if you can increase your magnification range, that is best. So you can even go for 6x also. But if you are a beginner, what I will suggest is first you just start with a Galilean loop at least for around 3.5x for initial maybe 6 months or a year. Start using it. Once you are used to it, then you can enhance your magnification. For your root canal treatments, if you are dealing with day-to-day practice, if you're dealing with some missed canal retreatment cases, if you want to, we can even do instrument retrieval with the help of loupes also. In such cases, you can even go for 6x loupes. That means prismatic loupes or Keplerian loupes. Such loupes also you can buy. So another question is every microscope we will get switch on filter and which we can you can present through where switch on see it all depends upon the budget of your microscope, what kind of microscope you are buying. In high end microscope you will get this option of filters, polarizing filters, normal filters. You will get all the options. But if you are going investing in some decent one, which is a decent one which is not meant for your composite restorations or your composite restorations or for your aesthetic parts, you might not get such facilities. But obviously you can talk to your dealer and you can ask up them about I want these filters also. These are all accessories that you need to buy or you can ask your dealer to provide you. But this is going to cost you a little extra, but yes, you can get it. Filters are present in your there's in it is there in your binocular, so you can't see it outside. It is everything is inculcated in your that microscope body. Using loops is better or microscope. See, if you are better, uh, if you are doing endo practice, microscope is like any day microscope is better. If you want to, if you have a budget, you can go for a microscope. You should go for a microscope. But if you are a endo consultant, you can't go with the microscope to each and every clinic. So in such cases, you can go for loops. If you have a good practice, you can afford assistants in your practice, then you should go for a microscope, because microscope is not a like two-handed dentistry. It is a four-handed dentistry. You need assistant, you need a nurse, and you yourself should be well oriented, well equipped with your microscope. So if you can afford all these things, you should go for a microscope. Loupes is for a mobile purpose. If you are going for some consultations, if you are going out to treat some people, then you can go for loupes. But loupes are something what I will call it is a minimum. If you want to start your magnification journey, loupes is something which is affordable. A very good loupes also it might cost you from 1.5 to 2, where in case of microscopes you have to invest from 8 to 10 lakhs. So it all depends upon your requirement and the need, whether it need of your practice, and whether you want to go up to like what kind of practice you want to follow. Best loupes and microscopes. So best loupes, if you want, see, there's a company called as Carlsys. It is like worldwide, it has a good name. So loupes or microscopes, you can go ahead with Carlsys. It is has a very good name in international market. For Indian market, loupes, I would suggest there is Admatec loupes are there. Then Argoptics is there. So these are some good loupes you can go about. And microscope, there are various brands are there. So these days I have like what I'm using is Lebomed. So Lebomed microscopes are good enough, you can go about it. according to Indian market and the kind of market, like the kind of budget and the kind of industry we follow. So you can even go for a Lebomid one. And then there are so many other brands which are coming with up with the microscope. But don't go for, if when you are investing in some microscope or loops, don't go for the cheaper one. It is once in a lifetime investment. So if you right now, if you are a student, if you don't have a budget right now, just wait for some time, do some savings. But whenever, whatever you want to buy, loops or microscope, go for a standard one. Don't just land up for some cheaper versions. In India market these days, there are so many companies which are coming up with this microscopes, loops and all. What I would suggest is just ask the dealer to give that microscope or loops for a trial basis. Just use it for some time, just get equipped with it, just see to it whether it is actually useful for you or not. And then and don't try one brand, try three, four brand at least, and then finalize like which brand you want to buy, which brand you want to go for. Can you tell me when to use microscope and when to use loops? Which was absolute indication for using microscope? See, microscope you can use for anything. It is not like microscope is just meant for endodontist. It is for everything. You can do restorations, you can do tooth prep, you can do endo, you can do diagnosis. There are n number of uses for microscope. And as I told, loops is something. One thing is budget friendly. Second thing is you can carry your loops to wherever you are going. If you are a consultant, prosto consultant, or endo consultant, loops is something that you can go about with wherever you are going for consultation. If at all you have a good budget, go for microscope. Microscope is something which will be there in your clinic, and microscope is something like you can do each and every case. Whatever case is there, you can do under microscope. There is nothing like you can't do this procedure under microscope or loops. It all depends upon the necessity. What is your requirement? Loops are only going to the highest quality loops also. They are only going to provide you a magnification of 6x, where microscope is going to provide you a magnification of 20x or 30x. So it all depends on your usage. Microscope, it starts from 0.5x to 20 to 30x. Loops, it starts from 2x and it can go about 6 to at times. I think these days some dealer is also some brand is also providing it for 8x. But the only thing is, if you are wearing a loops and you're going for a higher magnification, the weight of the loops will also increase. So you have to mind that also. So what I will suggest is, if you're going for loops, you have little less budget and your requirement is mostly for the consultations, or then at that moment you can just go for loops, ask the dealer to give it to you, use it for a few days. If you like it, then go ahead. If you have a budget for microscope, even for microscope also, dealers do give microscope for using for at least a week or 10 days. You take a microscope from them, just get oriented to the microscope. If you feel like it is good enough, then go and invest in your microscope also. Any more questions are there?
No, ma'am. Thank you so much, ma'am, for such a wonderful lecture.
Thank you so much. It was a great pleasure and being with all of you. And it is a wonderful experience for me. And I didn't actually expect I'm going to get these many questions. So have a good time. I hope like you people are going to have magnification. You are going to inculcate magnification in your day-to-day practice. If any doubts, anything is there in future, any doubts, any questions are there in future also, I'm there available there. And you can take my WhatsApp number from CynoDent, or you can even mail me, or I'm there in social media also, so you can follow me there also, and you can just leave a text there. I will reply for that. Thank you so much.
Thank you so much, ma'am. Moving on to our next lecture for the day, we have Dr. A. Jayasenthil with us. He is Professor and Head Department of Conservative Dentistry and Endodontics, Priyadarshini Dental College and Hospital, Tamil Nadu. Sir is going to give us the lecture on predicting and preventing post-op pain, evidence-based day one protocols. We welcome you, sir.
Thank you. Thank you for the introduction. Can I proceed with the lecture?
Yes, sir, you can start with the lecture, and I request you to turn on your video if possible, so that students.
Sure.
Yes.
Am I audible without any disturbance?
Yes, sir, you are audible and you are visible also. Your screen is also visible. We can start with the lecture.
Yeah. Very happy morning to everyone. Yeah. Today I'm going to discuss you about the post-op pain. The pain is the major thing where, just a minute. Major problem why the patients comes to the dentist. That too, as endodontists, we are mostly going to deal with the pain. Either it will be pre-operative pain, intraoperative pain, or post-operative pain. This the worst among is post-operative pain. That is why I'm going to take this lecture. And I am Jayasenthil. I am from Priyadarshini Dental College. So, as I gone with the topic, the pain is a major concern in the endodontics. So why it is a major concern? Because the tooth pain as it is one of the most severe pain in the entire body. Like wherever you are getting the pain, the dental pain is be very, very severe. The patient cannot uh, bear the pain when it is coming to endodontics. That too, if the pain is after the treatment, the patient will not be satisfied with the dentist. So that becomes a big problem with all the root canal treatments. Like you will be seeing like doing all the root canal fine, all the steps fine, then why the post-op pain? So today I'm going to discuss about the where and all you can predict the pain and how you are going to solve the pain issues after the treatment. So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Wherever tissue damage, like whenever you're doing a root canal treatment, definitely there will be a tissue damage. You will be extirpating the pulp. With that, there will be injury in the periapical area. So all this only is going to cause your post-operative pain. So post-operative pain is most common among the endodontic treatments. Like you cannot say it's very, very rare. It's very common. Minimum itself is 2.5%. It extends up to 60% in the studies which has been done previously. So why this is coming is mostly because of exacerbation of already existing inflammatory response. Like we are going to most of the time we are doing only the treatment where you have already periapical inflammation. So in that you are going to do the root canal treatment where this debris or any chemicals which you use can increase the inflammatory response, which is already rare, and that activates the inflammatory mediators. So when this post-op pain will be maximum 6 to 12 hours after the treatment. After you complete the treatment, 6 to 12 hours, you'll get the maximum post-operative pain. The factors that are related to the post-operative pain. Patient, when you compare gender, like when you have a women's, they have more common in the post-operative pain because they don't have a pain tolerance one. I cover that in the next slide. Tooth-related factors, you have pre-operative pulpal condition. What kind of treatment you are doing, whether it is a reversible pulpitis or necrosis of the pulp, that condition also affects the post-operative pain. And pre-operative type of microbial infection which was there in the tooth. And yeah, treatment procedure related factors also there. What type of instrument using, all those things matters when comes to the factors influencing. The post-operative pain after the endodontics is a multifactorial thing. So that means like presence of periapical pathosis, missed canals, inadequate cleaning and shaping, apical extrusion of debris, apical patency, during instrumentation, whatever the mistakes you are doing, irrigant or intracanal medicament extrusion, or post-operative restoration what you are giving, that if you are having high out of the occlusion, that also can cause the post-op pain. So first I told the woman experience more pain is because of the hormonal changes what happens in the women body than men. Like changes in serotonin and noradrenaline hormones will be different in the women's body, which provokes them more pain than men. And cortisol, which is the hormone which modulates the pain sensation, is secreted higher in qualities in the men. So the tolerance will be more. And patient age, some studies say older patients will have more pain, some have no relation. As it is, a systematic review which I have quoted below mentions that patient age was not that much related to the pain. So pulpal status also contributes some amount of pain. Like preoperatively, if you have more inflammation, definitely that will cause more pain than the non-inflamed pulpal status. That means like what I'm telling you, if you have an inflammation, already the patient will be having severe pain before you start the root canal treatment itself. So in those conditions, even after the treatment, the pain, you can expect a pain condition to continue after the treatment. Coming to the tooth, which type of tooth and where you get us, most commonly the post-operative pain is very high in mandibular molars. It's mandibular arch and molar teeth are the most common thing where you get the post-operative pain. So this is because of the dense trabecular pattern where there is blood circulation will be very less than the spongy bone of the maxilla. The mandibular bone is high cortical thick plate, that blood circulation and the regeneration of the periapical tissues will be very less, and infection healing also will be slow compared to the maxillary area. So mandibular arch, you get the infection and the pain more than the maxillary. And apical foramen enlargement. This is major thing what we think is working length maintenance is very, very important in root canal treatment. If you don't maintain that, the apical foramen may be transported or it's been enlarged more than the size. This is because of the over instrumentation. This will cause the post-operative pain definitely, because you will be violating the periodontal ligament rather than keeping yourself within the endodontic limit. And coming to the depends upon how many sittings you are going to do a root canal treatment. The single visit and multiple visit, many will be having some myth like single visit, definitely you are doing it fast, so you will be having more pain. So that is actually a myth. Factors like with the research, they have proved that whatever the treatment you are doing, how you are doing the meticulous cleaning and shaping, that only matters, whether it's a multiple sitting or single sitting. The post-operative pain condition is not going to be much different. And definitely one point will be helpful in the multiple visit, where if you properly select the intracanal medicament for the condition, like either calcium hydroxide or chlorhexidine or a triple antibiotic or double antibiotic base, all those things, if you select it properly and give, definitely there will be slight reduce in postoperative pain in the multiple visit. So coming to the management of postoperative pain, there are two types of management are there: pharmacological. Most of us do that only. There is some other part also is there, which is called non-pharmacological management of postoperative pain. First, I concentrate on that non-pharmacological part. Then I go for the pharmacology, which most of us definitely know. Like non-pharmacological, mainly you are not going to do any drugs. You're just going to modify some procedures or some places, or modify the patient's psychology. All those things only is going to help in thing. Mostly the pain is a fear factor, whether you are going to have a pain or not. But most of the patient, when they come to the dentist itself, they'll have the fear. Oh, I'm going to get some pain today because I'm going to do some dental treatment. That is the major thing. So that causes some psychological issue, which will be continuing even after treatment. Some will be thinking, oh, they would have heard from someone, root canal, if you do, definitely you're going to have pain for so many days. It's going to be a severe nightmare for you. Like that, some will sensitize some patients with that mentality. If they come to the treatment, definitely, even if you do a good treatment, they will be feeling pain because of the psychological issues. So what you are going to do for that patients? Psychological techniques, what you can follow, so mainly anxiety treatment. How we are going to do anxiety treatment? You are going to do some counseling, or you are going to just make the patient comfort with the proper explanation of procedure, what they will be feeling, what is the myth, what is the fact, something like not everyone is going to have the same pain. All those things you have to explain to the patient. Sometimes music therapy also helps. That's why you can see most of the dental practices will have a soothing music running in the background, which will cool down the patient psychologically. And nutritional support, definitely some nutrition's deficient patients will have a more inflammatory mediators, which will increase the pain. And cryotherapy, which is being followed very much nowadays. That I'll continue with the next slide. First, dental anxiety treatment. We can do music therapy. You can go for hypnosis if you have any psychologist with you, and cognitive behavioral therapy. Or you can, like what I told you, you can improve the informative procedure, like who can explain the patients about the treatment properly before going for the thing. These are helpful in the dental phobia patients, not for all the patients, where you diagnose the patient is having some dental phobia or some anxiety related issues. They won't even cooperate immediately after the root canal. They won't even allow for your local anesthesia. Those patients, you can follow these things. You can follow some strategies for relaxed patients should be feel relaxed in the dental environment. He or she should not have any stress or anxiety issues. So as I told, cryotherapy, it's very simple procedures. Like most in our college, we follow this very commonly, like cryotherapy. Very easy. Keep a saline, cool it to 2 degrees Celsius. It will be in liquid form only. You can use this for irrigation. So what happens is when you use a cold area in the inflammatory, like every other body where you have a cold compression for inflammation, the same thing works in the root canal treatment also. If you use that cold saline for irrigation, there will be tissue heat due to the inflammation. It always will have the other 5 signs of inflammation. It will be having higher temperature. When you have a lower the temperature, automatically there will be a vasoconstriction in the lower temperature, which will lower the cellular BMR. So that decreases the free radical generation, which causes the pain sensation. So automatically the post-operative pain will be very less, and you do a cryotherapy. Cryotherapy means name only will be very complicated, but it's a very simple thing where you can use a chilled saline, but it's not normal chilling. You should cool it up to 2 degrees Celsius. Because of the saline property, even at 2 degrees Celsius, it will be in liquid form only. Coming to the pharmacological, preoperative medication. Actually, this is being in the current research. Most of pain related research are going on for the reduction of post-op pain, because usually we are giving the post-operative medications of antibiotics and NSAIDs commonly. But even that, from the complete point, the completion of root canal treatment, if the patient should not feel the pain, you can try out with some pre-operative medication of pharmacological treatments. Like any NSAIDs administered 30 minutes before can reduce the post-operative pain very much. So whatever you can select the NSAID which is comfortable for the patient without any allergy or any other gastric issues, you can choose. That helps a lot in reduction of post-operative pain, because what it does is it block the COX pathway. You always know, because this pathway is the one which is going to conduct the pain signals. So when it blocks even before the pain starts, definitely the pain session will be very less compared to without the usage of this NSAIDs. And preoperatively, you can also try using a prednisolone 30 mg or dexamethasone 4 mg, which has been proved to reduce the post-operative pain very much. And if you are having very anxious patient and something the patient needs very much comfort post-operatively, you can give a long-acting anesthetics like bupivacaine, because what we use lignocaine wears off after 2 hours or something. That too after block. If you're going to go infiltration, hardly stays for 1 hour, but this stays very long. So patient will not feel the post-operative pain. And after some time, definitely they are going to start the medication that will reduce that post-operative pain sensation. So factors that can reduce the post-operative pain. Lasers. So laser irradiation after the cleaning and shaping, it's proved to reduce the post-operative pain very much. It's not going to do any cleaning and shaping, just it's going to sterilize the canal. What it does is it's make sure the root canal is completely free of microorganisms. So definitely when there is a free of microorganisms, the inflammatory response is going to reduce if the foreign body is not there, and healing will be better. And coming to the root canal sealers, many type of root canal sealers are available. And the proven factor is if the patient is having acute pain and you are going to use a bioceramic sealer, in that case, it's going to reduce the pain. Bioceramic sealers is proven to have a less postoperative pain compared to the epoxy and eugenol based sealers. Apical patency, which was already I was discussing about, you have to maintain the apical patency. You should not violate the apical foramen. If you violate, definitely the post-operative pain will be more. Instruments used for the root canal treatment also have a indirect effect on the post-operative pain. Like if you are going to use a rotary instruments with the proper design where it won't allow the debris extrusion periapically, definitely it's going to reduce the pain. And also rotary instruments, mostly it will have a guided tip. It will not have a cutting tip. So it will not violate the apex also. The chances of apical violation or transportation also less if you use a proper instrumentation technique. And type of irrigation and irrigants used, concentration also have a direct effect on postoperative pain. Like if you are using a hypochlorite and if it's going beyond the apex during the periapical area, definitely the patient is going to have a severe pain postoperative, because whenever the hypochlorite goes beyond the apex, it causes the necrosis of the tissue. So definitely patient will have a pain. And concentration. Don't always go for 5.25% sodium hypochlorite. Even 3% is efficient. Only thing you have to use some amount of activation of the irrigant. That was irrigation technique. I told irrigation activators are there, but very carefully you have to use activator when you're using, and you are going to take the activator tip till the apex. That also cause you more pain because the extrusion will be more. So you should not go very deep with the activators. And if possible, if you have a endovac system that keeps the irrigation within the canal, and also circulation of irrigation will be very much good inside the canal. Occlusal reduction. So this is a some trick, like not for all the patients you need occlusal reduction. When you are expecting a periapical inflammation, the occlusal reduction helps a lot in postoperative pain management, because whenever that too in the posterior area, compressive stress is going to come when the masticatory forces are acting on the tooth. So that is going to reduce when you are going to do a occlusal reduction. And intracanal medicament, as I said earlier, like chlorhexidine and calcium hydroxide has proven for reduction of postoperative pain when used in multiple setting root canal treatment. So these, I think everyone are very well versed with this, because from our UG days, we follow these things after the root canal treatment. Analgesics, either NSAIDs, steroidal or opioid analgesics, whichever it is. Let's first start with the NSAIDs, that is the basic drug. If that is not going, then you can go for the steroidal or opioid analgesics. You can select whichever better for you, you can go for that. Moving on to the emergency pain needs during the root canal treatment. So endodontic emergencies are conditions associated with the pain or swelling that require immediate diagnosis treatment. So emergency, some patient is going to come. It's not a planned schedule. That is the endodontic emergency. As I told, pain or swelling caused by inflammation or infection of the pulp or periradicular tissue necessitating an emergency visit to the dentist for immediate treatment. Like it's not already given, you would have given some 10 days after the appointment, but after 2 days, the patient is coming to you for an pain or swelling. That is, we call it as a emergency. These are the classification according to Grossman: acute condition, reversible pulpitis, irreversible pulpitis, alveolar abscess, periodontal abscess, emergencies during the treatment, fracture of the crown or root, Owl's tooth, or referred pain. According to the Gutman, treatment of the vital pulp, treatment of the non-vital pulp. Those have different types of emergencies. In the vital pulp, you have acute reversible pulpitis, hypersensitive dentin, recurrent decay, recent restoration, cracked tooth syndrome. Non-vital pulp, you have acute apical periodontitis, necrotic pulp, acute alveolar abscess, phoenix abscess, and acute irreversible pulpitis, or sometimes even you can get a aesthetic emergency like fracture of tooth, crown, or root. According to the Walton, this is very simple. Pre-treatment. Before the treatment, what emergencies the patient can come? Inter-appointmentally, what emergencies can patient come? Or post-obturation. That is what we were seeing now. Post-operative pain or swelling. These are the things usually you get as pre-treatment. You have cracked tooth syndrome, acute reversible pulpitis, acute irreversible pulpitis, acute apical periodontitis, acute alveolar abscess, acute periodontal abscess, crown fracture, root fracture, or tooth totally avulse. That's not traumatic injuries. Then you have an inter-appointment. That means after starting the treatment, you may get mid-treatment flare-ups, hot tooth, exposure of the pulp, fracture of the tooth, recently placed restoration pain, and periodontal treatment pain. And you have post-treatment, you have vertical fracture, over-obturation or under-obturation. Pre-treatment emergencies. So first, cracked tooth syndrome, where the pain will be very severe psych hypersensitive dentin, but the pain will be more sharp than the hypersensitivity. It's first introduced, discovered by Cameron in the year 1964. Incomplete fracture of dentin in a vital posterior tooth that involves the dentin and occasionally extends to the pulp. Sharp pain on biting experience. Like whenever the patient bites, the pain will be there. When they open, the pain will reduce because the mechanism is when they bite, the cracks will open. There will be movement of fluid inside the crack area, and when they close, that will be reduced. So that's the concept. So how you can diagnose? Best method is transillumination. You can apply the light over the tooth and you can see incomplete crack running through the enamel and dentin to the pulp, not on the other side. And you can also use the bite test, that is a tooth slot or a cotton pellet, cotton roll. You can ask the patient to bite. When they bite, they will be relieved, and when they open, they will have the pain. Management. Symptoms of reversible pulpitis, you can stabilize the crack. And if it is the symptoms of irreversible pulpitis, it requires the root canal treatment and stabilization of the cracks. And if the cracks are more severe, better. If it is unrestorable, go for extraction. Hypersensitivity is also almost similar to the cracking, but it is because of the exposed dentin, not of the sharp pain arising from exposed dentin. Most commonly explained by the hydrodynamic mechanism. There is a fluid movements inside the dentin. Treatment protocol, you can have either starting with the dentist prescribed home care technique with the dentifrices, or you can use a chemical or physical blocking agent in the clinic itself, like resin blocking agents like or glutaraldehyde in a gluma form, or also you can use a oxalate based dentin desensitizing agents, or best is laser, which can clog all the dentin with the heat, open dentin. Acute reversible pulpitis, this also causes severe pain, but it is reversible. Quick pain, sharp pain, but it's momentary. When you remove the stimulus, the pain will be gone. The pain will be most commonly associated with cold than a hot. So checking, you can check with the cold test more than the heat test for the acute reversible pulpitis. Acute reversibilities, as the name suggests, is the reversible condition. No need to do any root canal treatment. You can just remove the underlying condition, etiology of the thing. It will reverse on its own. So, but this is a different one. This is totally going to be controversial to this. So opposite to the reversible is the pain will be lasting longer than the thing. You can have a spontaneous pain, night pain, postural pain, all those things. When the pain starts, it's be lasting for hours to minutes, whatever it is. This you have to go for emergency root canal treatment in the acute irreversible pulpitis. Acute apical periodontitis, it's a painful inflammation of the periodontial. This is the one of the severe pain condition what you're going to face as endodontist. Like patient will be having severe pain in apical periodontitis. Patient cannot even close the mouth fully. When the teeth touch also, there will be having a severe pain. The most emergency difficult emergency condition to treat is acute apical periodontitis that is caused by the acute pulpitis because pain from the pulp and pain from the apical area also. There will be severe pain will be the tooth. The patient will be feeling elevated in the socket or they cannot even close the mouth. So if it is a pulpal condition, you are going to manage it with the root canal treatment. If it is because of some recent restoration which causes the apical periodontitis, the occlusion should be relieved. Acute periapical abscess, you have a severe throbbing pain with swelling overlying soft tissues with or without mobility. The swelling will be very extensive in acute periapical abscess because chronic there will be a bone resorption, but in acute there won't be any bone resorption. The swelling will be similar to the space infection or cellulitis. Management, if the swelling is slight and localized, no need for any incision and drainage. Advise warm saline rinses plus root canal therapy, which will be sufficient for the patient relief. If there's a diffuse swelling and generalized tissue edema and cellulitis, you have to start antibiotic coverage and aggressive removal of any necrotic tissue in the pulp canal system. That itself is sufficient. If swelling is soft and extensive and swelling is fluctuant, see the thing, it should be fluctuant enough. Then only you can go for the incision drainage. Otherwise, the IND won't work. The tissue swelling is non-fluctuant. You can do a incision and drainage, antibiotics, and hot saline rinses only you can prescribe. Again comes the phoenix abscess. It's acute inflammatory reaction superimposed on a existing asymptomatic apical periodontitis. Here also tooth will be gets elevated from the sockets because of the huge periapical lesion. There will be well-defined periradicular radiolucency will be there in phoenix abscess, not like a acute periapical abscess. You can do draining and antibiotic coverage. Traumatic injuries also cause your pre-treatment emergencies like fracture of the tooth or alveolar bone or avulsion. I think that will be covered as a separate chapter as it is. And emergencies during the treatment. The most difficult one, hot tooth. Many of you already would have experienced this, that too, especially when it comes to the mandibular molar, which is the most common area for this hot tooth. The acute irreversible pulpitis area, the tetrodotoxin resistant channels are found. Like these are the channels which the anesthesia will be thing and the pain will be blocked. But in this area, this will from susceptible to resistant channels, it will be modified. So that causes stoppage of this anesthetic effect. In that area alone, patient will be having severe pain. If you're giving anesthesia, you check for the symptoms. The patient will take lip anesthesia, tongue anesthesia, other teeth will be anesthesia, but that tooth alone, pain will be there. When you touch the DHA, patient will be having severe pain. So these are the best, very, very difficult thing where we have to do something because during the root canal treatment, you tell painless procedure, all those things, and do the anesthesia and patient's telling pain, you cannot proceed with that treatment. So what you can do is you can go for some supplementary injections, not the same block. This is the many of us make mistake. If anesthesia block is working, no need to give another block at all. It's very waste if giving 2 or 3 blocks because you check If the block is working properly, no need to give a second IANP block or mandibular block. You can just go for some supplementary injections like intra-ligamentary, intra-osseous injection, or best is use a Articaine. Articaine helps a lot in the case of hard tooth. That will reduce the intraoperative pain and the postoperative pain very much if you use this Articaine as a supplementary injection for the hard tooth. And you can also have some mid-treatment flare-up pains, which has to be managed. So acute exacerbation or periorbital pathosis after initiation of the root canal, pain, swelling, or both can be there. Causative factors mechanically, like if the instruments goes beyond chemical irrigants or intercanal medicaments, microbial, new flora going on from the already infected periapical area can cause. So what you have to do the re-instrumentation. If the swelling is there, go for the cortical trephination to drain, incision and drainage also some works. If swelling is fluctuant enough, then intracanal medicaments helps a lot. Occlusal reduction, as I told, periapical inflammation, compressive stress has to be reduced so that it's not getting injured again and again. Hypochlorite accident, this also is like during irrigation, and this picture what I showed is because of the hypochlorite accident, like accidentally injecting a hypochlorite instead of LD, like passive placement of needle, which reduces the hypochlorite going beyond the apex, and attempt should be made to avoid the needle forcefully going beyond apically. Like passive needle placement is always helpful. Needle should not be wedged into the canal. When you wedge, the force of delivery will be more. Always use side vented needles. Correction. Have to go for antibiotics, analgesics, and antihistamines to reduce the allergic thing. Ice packs to reduce the hematoma or swelling areas. And IM steroids can be used. And more severe case, better go for hospitalization. And this also can cause some emergencies. This is actually beyond the pain part, but as I started with the emergencies, I'm just including this also in my presentation. I think this will be included in the other thing. Instrument aspiration and ingestion, like slipping of the instruments. If you work without a rubber dam, this can happen. Better to use a floss with the file if you're not using the rubber dam, so that it will be tied onto a finger. Remove the objects. If it is an aspiration or throat readily accessible, you can remove it. High volume suctions in the pharyngeal tip can be used. Hemostats also can be used. If the aspiration has taken, definitely medical support. If it is an ingestion, you have to follow it up, whether it stays or causing any GET issues or it's coming out as it is. The pain after the thing I already discussed. And one more problem which you can face after the treatment is the vertical fracture. The vertical fracture can happen after treatment, like if you don't follow proper protocols, especially if you are going to do a post and core restorations. The post-space preparation can cause a uh, perforation, which can lead to a vertical fracture, or vertical root fracture can happen due to the insufficient adhesive reinforcement of the tooth structure. The longitudinal fracture that originates inside the root, diagnosis is very, very difficult because very severely progressed vertical fracture you can see in the radiograph. Initially, you cannot find anything because of this dimension, longitudinal thing. You can find only in CBCT. You cannot see it in the thing. Radiographs, tooth slot or cotton applicator can be used as you do the bite test in cracked tooth syndrome. In severe cases, the radiograph which I put, the halo appearance can be seen. Prognosis is hopeless. Actually, it goes for the extraction. So conclusion, with this I'm concluding, like pain is not most common and unavoidable thing during the root canal treatment, but the strict protocols which you are going to follow and the preventive measures which you are going to take before the treatment, during the treatment, and after the treatment is going to reduce the postoperative pain experience for the patient. The patient needs the most comfortable root canal treatment, then only they'll have, because most of the people will come with the sensitized part, that is endodontic is going to be painful. That root canal treatment, severe pain will be there. So you should avoid that thing so that that should not be followed to the next patient also. So with this, I conclude and thanks the organizers to give me the opportunity in the big stage to take a lecture. Thank you. Any questions?
Thank you so much, sir, for such wonderful lecture. Sir, we have some questions in the chat box. The
I'll
student is asking, can you tell some desensitizing agents?
just a minute. I'll go to the chat box. So desensitizing agents, like as I told, first line of desensitizing treatment will be always using a dentifrices like potassium nitrate or stannous fluoride based or arginine based toothpaste, which is be a first line of treatment. If that doesn't works out, then you have to go for the next line of treatment like professional blocking like fluoride iontophoresis, or you can use simple potassium oxalate based desensitizers which is available in the market itself. Or also you can use gluma. Gluma is a glutaraldehyde based bonding agent which is available readily. You can use that also because this gluma is having dual effect. Glutaraldehyde is going to precipitate the dentinal fluid protein, that is going to help. Same way, the resin also is going to flow into the open dentinal tubules. It will block the entire system. Some resin-based sealers also is there. That is not like your bonding agent, just fluid-based resins, which can go and block the dentinal tubules very well.
Is there any more questions? Any participants? You may please ask.
Gluma, just like what you are going to place like a bonding agent, mostly there won't be in many types because I told you Gluma is going to have a dual effect. Glutaraldehyde is going to precipitate the protein and block it. The resin is going to just act as a superficial blocking agent. But anyway, if the tooth is going to have a more non-cavitated defect, if needs a restoration, definitely you have to do the restoration above that. If it is a severe untreated patient, Gluma is not going to help for a longer time. It's going to just reduce the pain for some time. When the again, because attrition patient is the physiology thing where the wear of is be again happening, again some amount of dental tubules will get open. So underlying treatment condition if severe, you have to go for the restorative treatment only.
Thank you so much, sir, for such wonderful and insightful lecture.
Thank you. Thank you.
So there is one more question, but
Yeah, I agree. NOCL, if you use a routine process, there are chances it can go to the apex if you use a normal irrigating needle. If you use a proper side venter, one or two side venter needles, which don't have a proper apical delivery, and also if you don't wedge the needle, chance of going NOCL can be reduced a lot. But normal irrigation, if you are going beyond the middle third of the root canal and you are using a regular normal needle for irrigation, chance of hypochlorite beyond that going beyond apex is very high. And if a patient has aspirated a file, what we can do? Yeah, aspiration is very, very critical thing. That means it's gone into the respiratory area. You have to definitely hospitalize the patient. You have to do some endoscopy and remove the file as soon as possible because it can injure any respiratory tissue. There is going to be severe issue because the bleeding happens in the respiratory area and block the respiration. That's a very fatal thing. So the patient aspirates the file immediately. Emergency hospitalization should be done and removed from the ENT expert. And if the ingestion happens, you have some leverage. You can observe the patient. Frequent radiographs or scanning should be done and keep the tracking of the file till where it is going till it comes out of the GAT. You have to track it. That should be done. Even in our college, one of the student accidentally slipped the burr, not a file. His hair didn't have a thing that went inside GAT. Luckily, in 2 days it came out. We observed and only we left the patient. Patient was there in the hospital for 2 days. And hard tooth symptoms. Hard tooth as it is not as symptoms, like it is actually, as I told, it's a irreversible, severe acute irreversible pulpitis condition only. It's related to the hard tooth. Patient will be having very severe preoperative pain itself. That means high inflammation will be there. The patient will be having severe inflammatory symptoms. And especially if you can suspect this kind of things in the mandibular irreversible pulpitis patient, you can always have this onto. You give a very good block, patient will be having nice effect of anesthesia, like they'll tell half of the lip is anesthetized, your jaw, bone area will be anesthetized, tongue also will be anesthetized. The tooth, when you enter the tooth, patient will be having severe pain. That is the symptom that tooth is hard tooth. And as I told, in those conditions, it's giving another block is not going to help in any way. Because already the block is working, you have to go for either supplementary injection or always you can have a orticaine if you can possible. That helps you a lot in reducing the pain in hard tooth. Immediately the patient will all you can have a pressurized syringes, intraligamentary reduces this thing. Also, you can use some bicarbonate buffers with the anesthetic solution, because if the pH is increased also sometimes this will be there. That also sometimes help in reducing the pain in hard tooth. Hope you got the answer.
Yes, sir. There are no more further questions. Thank you so much, sir, for such wonderful presentation.
And thank you, organizing committee, for giving me the opportunity. Thank you.
Thank you, sir. Moving on to the next lecture of the day, we have Dr. Astha Arya with us. She is professor in Department of Conservative Dentistry and Endodontics, SGT Dental College, Gurugram. Today, ma'am will be sharing the insights about endo emergencies, fractured instruments, ledges, and perforations, immediate decision making. We welcome you, ma'am.
Hello, sir. I will just share my screen.
Yes, ma'am, surely.
So, is the screen visible, sir?
Ma'am, it's visible, but we have a two dialog box seen here.
Now, sir, is it visible?
If we can have the slideshow view of the full in the full screen,
Okay, okay. I'll
because the screen is divided into two parts. One is showing your video and another is showing the presentation. So we
Oh,
want the presentation to be presented in the full screen because we
oh,
already having a video in the upper dialog box.
okay. I will just check.
We also shared you the image for the same.
Now is it visible, sir?
Ma'am, we
Has
can only see your video. There is no screen or the slide present in the screen. I have shared you the image in the WhatsApp.
I'm sharing the whole screen actually. So I don't know how to go ahead with this.
Ma'am, you can tap on the share screen option and you can just share that particular window only.
Hmm. That is actually disabled somehow.
I'll suggest you can rejoin the meeting. Maybe there
Okay,
must be the glitch in the Zoom.
okay, okay.
Yes, ma'am. Now it's visible. We can have the slideshow view.
Okay, now it is fine.
Yes, ma'am. It's perfectly fine. We can start with the lecture.
Okay. A very good morning to all. I am Dr. Astha Arya. I am professor in SGT Dental College, Hospital and Research Institute. It is indeed a privilege and honor to be invited as a keynote speaker at this conference. I sincerely thank the organizing committee for giving me the opportunity to share my thoughts with all of you. I would like to begin with the situation that every dentist dreads. You have finished your whole day's work, sitting in your clinic relaxing. It's 8 in the evening, and suddenly the phone rings. A worried patient calls, Doctor, since the time I have returned from your clinic, I'm having unbearable pain and there is a swelling on my face. What should I do next? Or maybe some other patient says, Doctor, you told me that there is a file broken inside my tooth. Would I be able to save my tooth? And then you get worried. You think, what should I do next? So the truth is that endodontic emergencies, they don't wait us to be experienced. They come unexpectedly. They test not only our knowledge, but they test our judgment, our decision making, and our ability to remain calm under pressure. So in today's lecture, we'll discuss not about how to manage the complications. But the first decision that you make after a complication, it often determines the final outcome. So during the next hour, we'll discuss some of the most common challenging situations which are encountered in our routine endodontic practice. The swellings, flare-ups, hemorrhage, separated instrument, ledges, perforations. But more importantly, we'll answer 3 practical questions for each of these situations. Why did this happen? How can we prevent it? And if it happens today in our clinic, what should we do immediately? See, because clinical excellence is not about never encountering any complications, but in fact, it is recognizing them early, making the right decisions confidently, and managing them systematically. So let's begin our journey from pain to protocol, from complication to confidence, and explore and transform the endodontic care through evidence, precision, and compassion. How many of you are confident if your patient lands up in your clinic today with any of these endodontic emergencies? So don't panic. By the end of this lecture, my goal is that each one of you leave with a clear and systematic approach to these challenging situations. So we'll start with flare-up. What is a flare-up? You have done a root canal treatment and then you have scheduled the patient's visit after 3 to 4 days or after a week. But suddenly the next day, the patient turns to the clinic with swelling and severe pain. So this unscheduled visit because of severe pain and swelling, which occurs after you have initiated your RCT, this is known as a flare-up. So the first thing what you would do is, first thing is to relieve the patient of the pain. The first and most important thing at this point is that you must relieve the patient of the pain. And generally these flare-ups, they occur in 2 to 20% of the cases. And most commonly, these are seen in cases of retreatment in patients with periapical lesion. If the patient has come to the clinic with a history of preoperative pain, then there are more chances of the flare-ups to occur. And also in cases of symptomatic apical periodontitis, there are more chances that the flare-up may occur. So why does this flare-up occurs? What is the etiology behind the flare-up? We have done everything nicely. You think that you have done everything nicely. So why it is this happening? So it may be because of the occlusal trauma, that is both the maxillary and the mandibular teeth, they are in contact. And whenever during mastication they are in contact, it causes inflammation in the periradicular area and hence there is a flare-up. It may be because of the missed canal. Like you might have located only 1 or 2 canals and one of the canal might be missed. So because of the missed canal, there may be severe pain. The pain or the swelling may also be because of the exclusion of debris or the irrigant exclusion. So when you are doing root canal treatment, if you go beyond the apex, then in those cases, there are chances that you may have extruded the debris out of the canal. Or if you have done irrigation, then if the irrigation is used in a forceful manner, then the irrigant might have extruded beyond the canal. There may be apical exclusion of bacteria because of the over instrumentation. So if you go beyond the apex, then there are chances of debris exclusion, bacterial exclusion, and this may have led to the development of the flare-up. So when these etiological factors are there, then the inflammatory cascade, it is initiated. The inflammatory mediators are released, which they cause increase in the tissue pressure, then there is pain, there is edema, and the end result is a flare-up. So we should always take care that while doing root canal treatment, the working length needs to be determined appropriately, and we should maintain our instrumentation till the apical constriction. We should not go beyond the apical constriction. The patient may complain of pain, tenderness, swelling, difficulty in biting, and sometimes there may be systemic involvement. And the patient may also complain of fever. So how to manage now? What precautions should you care? How to manage it? So first of all, diagnosis is very important. You should diagnose what has happened. You should determine the cause, why this thing has happened. Have you gone beyond the apex, or you have forced the irrigant beyond the apex, or there is a missed canal? So diagnosis has to be done why the flare-up has occurred. And then reopen the axis, establish the drainage through the root canal. If there is a swelling intraorally, we can go for incision and drainage. Then establish patency. Use a small number of K5 and slightly 0.5 mm go beyond the apex so as to establish the drainage. Maybe abscess is developing, and then when we establish the drainage, the discharge will come out of the root canal. Then complete cleaning and shaping has to be done. The BMP has to be done properly. Occlusal reduction needs to be done so that when the maxillary and mandibular teeth, they are in contact, so it does not they are not in contact and they do not inflame the periradicular area. Then medication needs to be prescribed to the patient, and then the patient can be called for a follow-up visit. The question arises, should antibiotics be prescribed? We all know that excessive use of antibiotics, it contributes significantly to the development of antimicrobial resistance. And therefore, antibiotics should be prescribed only when there are clear clinical indications. Pain does not mean that you need to prescribe antibiotics. Okay, so unless there is diffuse swelling, unless there is fever, cellulitis, lymphadenopathy, unless there is systemic involvement, do not prescribe antibiotics. There is no need to prescribe antibiotics in case of root canal treatment. For pain, we can prescribe non-steroidal inflammatory drugs. We can give COX-2 inhibitors. So, and also, see, you can also give corticosteroids. If there is a flare-up, then corticosteroids may be given as an adjunct to, but it is not a replacement for appropriate endodontic treatment. It just helps in the, it just helps to, it just helps to suppress the inflammatory reaction. So it can be given as an adjunct, but the most important thing is meticulous endodontic treatment needs to be performed so that there is no flare-up. Now, how to prevent? What precautions should be taken so that there is no flare-up? First of all, working length has to be determined accurately. The working length is very important. The working length should be the instrumentation. It should be confined to the apical constriction. We should not go beyond the apical constriction in any case. The irrigants, the medicaments, all should be confined to the working length. All should be confined to the apical constriction. Apical patency has to be maintained. Irrigation has to be done copiously. In one root canal treatment, in one sitting, approximately 20 ml of sodium hypochlorite has to be used. Then only it will be able to disinfect the canal properly. See, there are so many isthmus and apical ramifications are there where the instrument cannot reach. So in these areas, irrigant is the only thing, or the medicament is the only thing that will reach these areas and disinfect these areas. Because if the debris is there, the microbes, organisms, they remain, then they will lead to reinfection of the reinfection, and hence the prognosis of the treatment may be hindered. And yes, recapitulation. So after each successive file size, recapitulation has to be done with a smaller file so that there is no clogging of debris in the apical area and we not deviate with the working length. Always avoid over-instrumentation. Never push the debris apically. Avoid forcing irrigants through the canal. Use the irrigants passively. You should not force it because if it goes into the periapical area, then there will be inflammatory beginning of the inflammatory cascade and the flare-up. And always use rubber dam. Proper isolation has to be used so as to avoid contamination of the operating field. Now, next complication that we most commonly encounter is swelling. The swelling may be localized or it may be diffuse. The diffuse swellings may be because of cellulitis or maybe because of the space infection. So if it is a localized swelling, maybe intraoral, so we can drain through the canal, reopen the excess, drainage has to be established. And if it is in the vestibular area, then we can go for incision and drainage, and we have to do the root canal treatment appropriately. Complete disinfection has to be there, complete debridement has to be there, and then the swelling will subside. But if it is a diffuse swelling, then we must evaluate the airway. We must check if the patient is having fever or the patient is able to is having any difficulty in swallowing, if there is trismus, and if we see that the patient is having difficulty in swallowing, there is rapid spread of bilateral swelling, high fever, and difficulty in breathing, then this is an emergency condition. immediately the patient needs to be referred to the hospital, because if we do not take emergency care, then it may be life-threatening for the patient. So in such cases, we must always refer the patient to the hospital. These are the pictures which are showing how the incision and drainage has to be performed. We can see that there is a periapical swelling in the vestibular area associated with the tooth. We take a 11 number blade and the incision is given in the most fluctuant area. The abscess is drained. So once the abscess is drained, then you can continue with the root canal treatment. The patient will be relieved. Antibiotics need to be prescribed in such cases. We may give amoxicillin, we may give amoxicillin clavulanate. We can also give metronidazole for the anaerobic infection. If the patient is allergic to penicillin, then we may go for clindamycin. CBCT can also be done to evaluate the extent of swelling, to evaluate if there is any cortical perforation. So here we can see in the picture that this CBCT, there is a swelling associated with 2-1, and we can see this swelling in the CBCT. Okay, see here. So we can evaluate that there is no the buccal cortical plate is involved, but the nasal floor, but the swelling has not extended up to the nasal floor. Here, see, we can see the swelling in this case. But we must always remember that prevention is better than cure. So how will we prevent? Proper diagnosis is the key. Whenever the patient comes to you, diagnose it properly. What is the cause? What has to be done? Okay, and adequate drainage has to be established. If there is periapical abscess, then adequate drainage needs to be done. Now, we can take a small number of files, slightly pass it beyond the apex 0.5 mm, so as to establish the drainage. Complete debridement of the canal has to be done. Irrigation has to be done copiously, taking care it does not go into the periapical area. Intracanal medicament has to be placed, but it should be confined to the apical constriction. And the most important thing is coronal seal. Once you have done the root canal treatment, like the first sitting, then a temporary restoration is given, but we should ensure that there is no leakage, because if there is marginal flaw, then the microbes or the saliva, they may percolate into the canal and then lead to infection. So coronal seal is very important. Okay. And while doing root canal treatment, sometimes we see that the that the pulp chamber, it is filled with the blood, and then we panic why this has happened. So the reason maybe it may happen because of that still some vital pulp is there in the canal or in the pulp chamber, or we might have over instrumented. We might have gone beyond the apex, and because of this, there is bleeding from the periradicular area, or the pulp may be hyperemic. There might be pulp polyp, hyperemic pulp, or there may be perforation. We have done a perforation, either laterally we have done the perforation, or we have gone for an apical perforation. So these are the causes why the hemorrhage is seen during an endodontic treatment, or the patient may be on anticoagulant. So first we should determine where is the bleeding coming from. That is most important, because unless we know what is the etiology, we can't go ahead with the proper treatment. So we take a small cotton pellet, we dry the canal, we dry the pulp chamber, and thus assess where the bleeding is coming from. Whether it is coming from a perforation, whether there is a perforation either apical or lateral, or whether it is coming from the pulp chamber. Maybe there is an interproximal gingival tissue that is cut and the bleeding is coming out from there, or maybe there was a pulp polyp, or maybe you have over instrumented and the bleeding is there from the periradicular area. So first assess where the blood is coming from, and then we have to manage it appropriately. So we can rinse the tooth with sodium hypochlorite so that the bleeding stops temporarily. And then we can take a small cotton pellet and dry the canal, to find the bleeding spot. If there is a perforation, then what can we do? We have to seal the perforation immediately. As we can see in this picture, this is the canal and here the perforation was there. So with the help of MTA, we have sealed the perforation. So perforation needs to be sealed as soon as it is detected. Then after cleaning and shaping has to completed, then we can place calcium hydroxide as an intracanal medicament into the canal. If the bleeding is from a pulp polyp or the bleeding is from an interproximal tissue, then we can place a small cotton pellet soaked with hemostatic gel in that area to control the bleeding. So once we control the bleeding, then we can go ahead with the root canal treatment. Controlling the bleeding is very important because if there is pool of blood in the canal, if the pool of blood in the chamber, we'll not be able to see anything. And when we are not able to see anything, definitely we cannot perform the root canal treatment. So one clinical tip that I would like to give is that if there is persistent bright red bleeding, here we can see this persistent bright red bleeding, then just think about the perforation. Maybe there is a perforation. And if there is perforation, recognize it early, control the bleeding, seal it immediately using the perforation repair materials, and avoid contamination of the operating field. Okay. And now, see, till now we have seen about the endodontic emergencies. But now we'll discuss about the procedural mishap. And here comes what many clinicians call the boss level of endodontic complications. That is instrument separation. It's the moment when the file stops moving and your heart starts beating a little faster. But remember, a separated instrument, it is not a catastrophe. It is a clinical challenge, and like many other clinical complications that we face in regular endodontics, it can also be managed systematically. So let's see how it can be managed. We know that it is frustrating for both the clinicians as well as for the patient because it prolongs your treatment, it is very cumbersome, and it may also hinder the prognosis of the root canal treatment. But there is no need to worry, it can be managed. Okay. So first we'll understand why it happens, why the instrument separation occurs. Generally the incidence of instrument separation is 0.5 to 7%. Okay, and mostly it occurs in cases of curved canals. If the canal is curved, here we can see that the canal is curved. So what happens because of the canal curvature? If we have not prepared a glide path properly, then the instrument separation may occur in the curved area. Or in cases of narrow and calcified canals, if the canal is narrow, if it is calcified, and we use a larger size instrument, then there are chances of instrument separation. See, this instrument has separated here. And it may also be instrument related with whether the instrument is that we are using is stainless steel instrument or the endodontic instrument that we are using is NITA instrument. That also determines the chances of separation. See, the stainless steel instrument, they are hard, they have got less ductility. So when they are subjected to repeated compressive and tensile stresses while doing the cleaning and shaping, this initiates micro cracks in the instrument, and because of these micro cracks, they tend to fracture. And with NITA instruments, the thing is that they are made out of machine milling. They are not twisted. Okay, they are not twisted. They are machine milled. So because of the machine milling, some imperfections may be there, and because of these imperfections in the instrument, the instruments may fracture. You might be aware of the two terms, that is cyclic fatigue and torsional fatigue. Okay, what is cyclic fatigue? Cyclic fatigue is basically the repeated compressive and tensile stresses that the instrument endures while we are doing cleaning and shaping. So because of these repeated compressive and tensile stresses, the instruments, uh, they tend to fracture. Okay. And torsional failure is what happens when the instrument it lodges within the canal while it continues to rotate. So it is basically got stuck into the canal while it continues to rotate, and this leads to torsional failure. So the instrument fractures. So the instrument generally fracture because of cyclic and the torsional failure. And then there are iatrogenic causes. If we have not prepared a glide path before using a rotary file. So glide path preparation is very important with a smaller number of file, and then only we have to use a larger file or we have to shift to rotary. So first the glide path has to prepare with 10 number, 15 number and 20 number K file, and then we should start using rotary files. Okay. And we should also take care that the instrument should not be used with excessive pressure into the canal. The instrument should be used very passively. We should not force them. If it is not going to the working length, don't force the instrument, don't push the instrument. Okay, do the coronal flaring, prepare a glide path with the small size instruments, and then use the instrument. Okay, it will go to the working length. Even if it is a curved canal, if you have used a straight line axis, then if you have prepared a glide path, the instrument will definitely glide to the working length. Okay, and clinical expertise, this is also very important. Endodontic treatment requires a learning curve. With the experience, the chances of instrument separation will reduce. Okay. And the most important thing is reuse. See, manufacturers, they generally recommend single use of the endodontic files. But but in developing nations like India, because of the economic constraints, because of the resource constraints, it is actually not practically feasible to follow this recommendation. Okay, so we do reuse the files, but we should take care. What is it that if we have used a file in a curved canal, in a difficult case, in a complex case, if you have used a file in a narrow and calcified canal, then better to use it as a single use file. Okay. But if it is a moderate case, if it's a simpler case, then what we can do is we can use it for 2 molars and then we can use for 3 premolars. So there's no definitive number of times a endodontic file may be used. It depends upon the case. Okay. If it is simpler case, then we can use for 3 molars. If it's moderate case, then 3 molars and 2 molars and three premolars we can use. And if it is a complex case, then like if it's a severely curved canal or calcified canal, then we must use single use. Then we must take care that the files are to be used. The files are to be discarded after every use because इसमें कंजूसी नहीं करनी चाहिए because if the file separates then it is very frustrating. Okay, the treatment time, it hinders the prognosis of the treatment and also it prolongs the treatment, very frustrating. So it's better to judge uh, every time what type of case it is, use pre-operative radiographs and then we can go ahead. While using the files, how will we know that we have used the files how many times? How will we determine it? So one tip I would like to give you is that in case of rotary files, we can use a burr to draw a mark on the shank, a line on the shank every time we use the file. So every time we use the file with the help of a burr, we can draw a line on the shank to determine how many times it is used. So we don't use it multiple times and avoid the instrument fracture. The most important thing is regularly examine the cutting edges for signs of wear and strain. If you see that there is dulling of the fluids, there is unwinding of the fluids, there is loss of luster, then it should immediately be discarded. Okay, these files should be discarded, not to be used even one time into the canal. Immediately discard them, take the next. Okay, so this precaution is very important. And even if after taking all the precaution, if the separation occurs, don't panic. Stay calm, stop the instrumentation at that stage, take a radiograph, determine the location of the separated instrument, and then plan what has to be done next. So before starting managing this instrument separation, some factors have to be taken care of. We need to assess the situation first. So what factors are those? First, we have to take a pre-operative radiograph and then determine the location of the separated instrument. We need to determine the size of the separated instrument, whether it is a smaller fragment or if it is a bigger fragment. We need to assess the material of the separated instrument, whether it is a stainless steel or if it is a NITA instrument. We also need to assess the presence of infection, whether there is any periapical infection or the patient is asymptomatic. We need to determine the stage of cleaning also. So all these factors need to be assessed before we start with the management of instrument separation. So first we'll discuss the location of separated instrument. If the instrument is separated in the coronal 1/3 or in the middle 1/3, like we have seen in this radiograph, it is separated in the middle 1/3. So what? We can retrieve it. The retrieval is easier in these cases. But if it's in the apical third and if it's beyond the curvature, then it becomes slightly challenging. Or instrument retrieval becomes slightly challenging in such cases. And then, so we should think whether we should go for retrieval or we must try to bypass the instrument or it may be retained as it is and then obturated. We must also assess the thickness of the remaining dentine. If we see that in this case, the dentine thickness is adequate, we can see the dentine thickness is adequate around the separated instrument, so we can definitely attempt the retrieval. But if the dentine thickness is less and then we are trying to retrieve it, then that would further compromise the dentine thickness and there would be chances of fracture of the tooth. If dentin thickness is less, don't attempt the instrument separation. We can bypass the instrument, or the instrument may be retained depending upon the condition. Now, how the size of separated instrument affects? See, if it is a smaller instrument, then it affects the technique with which we retrieve the instrument. If it is a smaller instrument, then it needs a different technique. If it's a larger instrument, then different technique, which we'll discuss it later. Then the material also needs to be taken care of, because if it is a night eye file, what happens? The night eye, when we use ultrasonics for instrument separation, some heat buildup is there, and because of this heat buildup, the NITA instrument may again separate. Okay, so it may fracture inside the tooth again. So secondary instrument separation may be there. So we should always take care if it is a NITA instrument. Then the next factor that we should take care is presence of infection. If there is a periapical infection, then we must try to retrieve the instrument, or at least bypass it, so that we reach the working length, we reach the periapical area, and the infection and the tooth is disinfected. But if the patient is totally asymptomatic, there is no periapical infection, PDL is intact, then in those cases, we may leave the instrument as it is in the canal if the patient is asymptomatic, definitely. And another factor that needs to be assessed is the stage of cleaning. If the instrument is separated uh, after the cleaning and shaping is completed, then even the absence of retrieval of the separated instrument would not hinder the prognosis of the treatment. Okay, but if the instrument gets separated before we have in the initial stages of cleaning and shaping, so you have not reached the working length, the cleaning and shaping is not done completely, and the instrument has separated before the cleaning and shaping is completed. So definitely, because of the infection present, it may hinder the treatment prognosis. So we must try to retrieve the instrument, and if the instrument retrieval is not possible, then at least try to bypass. Okay, so all these factors, they need to be assessed before we go ahead with the management of instrument separation. The armamentarium that is required is most important, magnification. Without magnification, we can't even think of removing a separated instrument, okay, especially in the middle third and the apical third. So dental operating microscopes are a must if you want to go for instrument, if you want to go for removing the instrument separation. In fact, on the whole endodontic treatment, or many procedures in dentistry, they need to be done under magnification, which will improve the treatment prognosis, which will go with the clinical excellence and also ergonomics. So magnification is very important in endodont. Okay, and the different tips that are required for removing the separated instrument. These are the ultrasonic tips. Okay, CPR tips can be used. KISS tips are there. Satellite tips are there, and many companies uh, uh, are now manufacturing the tips for separated instrument retrieval. So these one are titanium ones. These are stainless steel ones. Okay, this is the satellite kit. And then this is a Vault-End Endo Rescue File Retrieval System kit. So along with the ultrasonic, other systems are also required to remove the separated instrument. So in this kit, we can see these are the rotary files which are used for coronal flaring to prepare the staging platform. And then these are the trephine burrs. These are micro tubes, okay? And this is a plunger. This is a BTR pen. This has got a loop. Okay, this is used to engage. This loop is used to engage the separated instrument. So this is the armamentarium. This is armamentarium that is required to go for instrument separation. Now we'll discuss the technique of retrieval of separated instrument. The most important thing after we have assessed the preoperative radiograph, we have taken all the factors into consideration, and now we are going to start with the retrieval of separated instrument. The first thing is establish a straight line axis to the coronal end of the separated instrument. This is a separated instrument, so establish a straight line axis to the coronal end so that the coronal end of the separated instrument is visible. So this is the staging platform that is prepared with the help of a gauge slit and drill. This is the staging platform you see that we have prepared with the gauge slit and drill. The coronal end of the separated instrument has now become visible. Okay. Now next we have to use a ultrasonics. So after the staging platform is prepared, ultrasonics can be used to engage the separated instrument, to trough around the separated instrument. It is wedged between the separate. Here we can see it is wedged between the separated instrument and the wall of the root canal, and then troughing is done around the coronal end of the separated instrument. So see here we can see that the troughing is done, and then the instrument, while we are ultrasonically activating it, the instrument, it suddenly pops out of the canal orifice. The instrument is removed. We can see here that the instrument is removed. It is suddenly popped out. Okay. Uh, when we are using the ultrasonics, we should always take care that this instrument that has come out, it may then get lodged into the other canals. It may get through the canal orifices, it may get lodged into the other canal orifices. So we must block the canal orifices before we are using ultrasonics to retrieve the separated instrument. We can use small cotton pellet to block the orifices, or we can use gutta percha to block the orifices. And then only we must retrieve the instrument. These ultrasonic tips, they may be either diamond coated abrasive diamond coated. So they are used in the coronal portion, only in the coronal portion if it is abrasive ones. And then when we reach the separated instrument to the level of separated instrument, we have to use the plain ultrasonic tips. Okay, because if we are using abrasive ones here, then they will lead to excessive removal of dentin. We can see here they are leading to excessive removal of dentin, which will weaken the strength of the tooth structure. So we have to use plain ones here, activate it ultrasonically, and the instrument will pop out of the canal. That is a very nice feeling when the instrument pops out of the canal, right? One other technique is Trefeinberg technique. So when we have prepared the staging platform, and we can also use ultrasonic, small amount of the coronal part of the separated instrument is now troughing has been done around the separated instrument, then we can use a Trefeinberg. So with the help of this Trefeinberg, we place the Trefeinberg through the canal orifice, and we engage the separated instrument. Here we can see we have engaged the separated instrument. So it will create a trough around the separated instrument. It will engage it, and then we pull it out. So this is the Trefeinberg. Different sizes are available. Okay. And then we pull out. So with the debris and the separated instrument, it gets pulled out. So here we can see the separated instrument is being pulled out. One more technique is there, microtube and loop technique. We have seen in this see, these are the microtubes. They have got a side window here. They have got a side window. Okay. So these microtubes are used in this case. So once the coronal end of the separated instrument is visible, here we can see that the coronal end is visible. Side trough is prepared around it. So we place a microtube between the separated instrument and the outer wall of the canal. Okay, the bevel of the microtube is placed between the separated instrument and the outer wall of the canal. So this will guide the separated instrument into the microtube. Then what we'll do, we'll place a wedge, a small file or a small wedge is placed through this microtube. When we place a wedge, what happens? This instrument, it will come out through the side window. When we place a wedge, the instrument will come out through the side window, and then we can pull it out. So this is again a technique to remove the separated instrument. This is generally done when the fragment is of larger size. Okay, if the fragment is of smaller size, then ultrasonic is enough in itself. But if the fragment is of larger size, then we can go for microtube and loop technique. And also one more technique, that is BTA pen. It is very useful for removing the separated instrument, especially if it's large in size. Sometimes what happens when we use ultrasonics, the instrument gets loosened, okay, but it does not pop out. It does not come out of the canal. It is loosened. We can see that वो हिल रहा है. It is moving inside the canal, but it is not coming out. So in such cases, the microtube method is important. Microtube method plays a role, and this BTA pen is very important. Is very useful in removing the separated instrument. In this case, see here we can see this loop. This loop. So this loop, it engages the separated instrument, and then that can be retrieved. Okay. So here's a small video that I would like to play where we have removed the separated instrument. It is done under magnification and using ultrasonics. And this is one of the case that we have done where the instrument was separated in the middle third of the canal. We can see the instrument has been retrieved. This is a separated instrument that we have retrieved. This is done using ultrasonics. Okay. This is one more case where the instrument was retrieved. The instrument got separated in the middle third. In case of upper premolar, maxillary premolar, the instrument is retrieved. See, the instrument is retrieved, and then obturation has been done later on. So here also again we have used ultrasonics to retrieve the separated instrument. This is SAT-like kit, okay, and this is the scaler P5 SAT-like scaler that we have used for the retrieval. This is one more case where the instrument, where here we can see that where the instrument was separated by us only, and see, this is a separated instrument. In this picture we can see the instrument separated. This is a larger fragment, okay, and that's why we can't use ultrasonic alone. Okay, ultrasonic was used. Here we can see the separated instrument. So ultrasonics was used, and then a microtube method was used to retrieve the instrument. See, this is we don't have that kit, so we have prepared हमने जुगाड़ किया है. This is a needle, 18 gauge needle, and with this we have prepared a slide window in this, and then as a wedge we have used a K5, 15 number K5. We have used a wedge, and then this instrument, it get lodged in this side window, and then we removed it. Okay, we remove this. See this. Okay, and then the obturation was done. So this separation was done using ultrasonic followed by a microtube method. We know how to retrieve the separated instrument, but at the same time, we must also know when not to retrieve. This is equally important, when not to retrieve. So when we should not attempt retrieval, if the roots are thin, we have already discussed, if the roots are thin, then further attempt to retrieve the separated instrument will further weaken the roots, and the chances of the root fracture will be there. If this patient is asymptomatic, if there is a healed lesion, then we may bypass the instrument, or we may, if we are not able to bypass, then we can retain the instrument where it is rather than attempting to retrieve the instrument. And we must also assess whether is there risk of perforation. जब हम use कर रहे हैं ultrasonic files, we should not perforate the dentine. Okay, if we think that we may end up with a perforation, then it's better not to attempt the retrieval. Just try for the bypassing the separated instrument, or leave the instrument, retain the instrument as it is in the canal, and just use copious irrigation with sodium hypochlorite, use copious irrigation with EDTA, and then obturated till that level. Okay. So here is a case of where we have bypassed the separated instrument. We can see this separated instrument in the mesolingual canal of the mandibular molar. We have bypassed it using a file, and then this is post-obturation. The instrument is then in the obturating material. The instrument gets lodged in the obturating material. We bypassed it. So the case was successful. The patient is asymptomatic, and there is no lesion also periapic. Okay, so bypass is equally effective for managing the separated instrument. Now this is another case where the instrument has gone beyond the apex. Okay, this instrument has gone beyond the apex. So what will we do in such case? If we attempt to retrieve the instrument, if we attempt to bypass the instrument, then there are chances that this instrument may further push into the periapical area, into the alveolar bone. So what we do in such cases, we can go for apical surgery. Okay, we can raise a flap in this apical area and then remove the instrument in a retrograde manner. We can just pull out this instrument through the window that we have prepared. Okay, or in rare case, we can also think about reimplantation. We can extract the tooth, we can remove the separated instrument, and then reimplant the tooth, and then go for endodontic procedure. Okay, but we can't guarantee about the treatment prognosis with reimplantation. So apical surgery is the preferred method in such cases. Okay, but most important thing is prevention. We must take every precaution, we must take every care that the instrument does not separate. Because if it separates, then definitely it is cumbersome for the dentist, it is frustrating for the dentist, and also we can't guarantee that we'll remove it, we'll be able to remove it, we'll be able to bypass it. Sometimes even after trying, it is not removed and we are not able to bypass it. So at that time we have to retain it. Okay, then it is frustrating. So prevention matters. Prevention is always better than cure. So what precautions do we need to take care? The first precaution is prepare a glide path. Always prepare a glide path using a small size file. Use 10 number file, use 15 number file. Before we use rotary files into the canal, always prepare the glide path. Then straight line access. We can see here straight line access. Straight line access very important so that the instrument automatically glides into the canal curvature. Okay. And don't skip file sizes. Use the file sequentially. Okay. ऐसे नहीं कि अभी चलो ठीक है वाइड कैनाल है तो अभी हमने 15 यूज कर लिया देन सडनली वी शिफ्ट टू 25 or 30. Never do this. Always use files sequentially. And then recapitulation is very important. After each successive file size, recapitulate with a small file size so that there is no clogging of the debris and the curvature is not blocked and the canal curvature is not blocked. And always lubricate the canal. Okay, the canal should be always lubricated. It should not be dry. We need to use sodium hypochlorite. We need to use EDTA so that the debris, whatever the debris is there, it's getting removed from the canal. With irrigation, the debris is always getting removed from the canal. Okay, and the instrument should be used in gentle pecking motion. We should not forcefully insert the instrument into the canal. If we feel that there is some blockage, okay, don't force it. It may end up in perforation or it may end up in instrument separation. So the instrument should always be used passively. We should never apply pressure while we are using the instrument. Okay. And the most important thing, discard the fatigue files. Always check whether the unwinding of the fluids is there, whether the loss of luster or the whether there is loss of luster, unwinding of the fluid. So always discard the fatigue file. This is very important. Okay, यहाँ पे हमें थोड़ा सा भी hesitate नहीं करना है. We need to discard it. Okay, and uh, always perform endodontic treatment under magnification because we can't treat what we can't see, right? So magnification is very important. All these things, if we follow all these clinical principles and perform our endodontic treatment meticulously, then there are very less chances that any mishap will occur or any emergency will be there. Okay, so it has to be done very systematically. Now, next is ledges. The separated instrument, they judge our patience, but the ledges, they test our judgment. Okay. So what is a ledge? It is basically an artificial irregularity that prevents the instrument from reaching the working length. Here we can see. Here we can see in this picture. So this ledge has been formed. The instrument is not able to follow the canal curvature. It is not reaching the working length. Okay. And this is called as a ledge. Okay. This is an artificial irregularity that prevents the instrument from reaching the working length. So whenever a ledge occurs, don't worry. Just bypass the ledge. Okay. And why it happens? Why the ledge formation is there? It occurs because the axis preparation was not done properly. Straight line access was not established. It occurs in cases of curved canals. If the straight line access is not there, if glide path was not prepared, then there are more chances that the ledge may occur. If we are forcing the files into the canal, if there is a blockage, if we are not able to glide the file into the curvature and we force it, हम उसको push करते हैं file को, then there are chances that we may end up with ledge formation. And also due to skipping of the file sizes, the ledge formation may also occur due to skipping file. 15 number यूज की फिर suddenly हम 25 पे jump कर गए, 35 पे jump करके ठीक है 15 number चली गई, now 25 पे चली जाएगी, but no, never skip the file sizes. Okay, it may end up in ledge formation. So what happens when there is a ledge formation? There is loss of working length. The files, they deviate. Now this file has deviated. It will go like this. It will not follow the canal anatomy. And also it can be determined radiographically. So how will you manage it? How the ledge has to be managed? So take a small stainless steel file, 10 number stainless steel file, or we can also use a 8 number stainless steel file. Recurve it. Okay, recurve the stainless steel file. The direction of the curvature, as we can see in this picture, the direction of the curvature should be towards the inner wall of the curve. Okay, it should be towards the inner wall, towards the curvature. So this, and then use EDTA to lubricate the canal. gently insert the file into the canal, trying to bypass the ledge. Okay, don't force it, very gently using a pecking up and down motion, slight up and down pecking motion. It has to be eliminated. The ledge has to be eliminated. Use magnification, and remember, patience is one of the virtue of an endodontic procedure. Okay, we need to have patience. Without patience, it's very difficult that endodontic procedure can be like. And patience is a must for every endodontist. Okay, it is a virtue, and do not rush the procedure. Prevention is better than cure. If prevention takes small amount of time, then the cure, it will take it takes multiple efforts. Okay, prevention takes small efforts, cure takes multiple efforts. What precautions have to be taken care of? Straight line access has to be established, proper glide path needs to be established, always lubricate the canal, proper recapitulation has to be done, and do not skip file sizes. So if we follow all these clinical principles, if we do the root canal treatment meticulously, then there are very rare chances that the ledges may occur or any endodontic mishap may occur. Now next is perforation. What is meant by perforation? Perforation is basically a mechanical or a pathological communication between the root canal system and the external tooth surface. Here we can see this is the perforation. So the perforations, they may be pre-operative. Even before you start with the root canal treatment, the patient comes to you, you assess the tooth. So perforation is already there, which may be because of the resorption, or it may be because of the caries. Okay, because of the caries, the floor is already perforated, as you can see in the picture. Or the perforation may occur hydrogenically. During the excess opening, there may be perforation, you may end up with perforation, or during or during cleaning and shaping, during instrumentation, we may end up in perforation. So what is important? Okay, why the perforation is occurring? It may occur because of the incorrect angulation of the burr. Okay, you can see we don't know the anatomy and end up in perforating in the furcation area. Because of the crown root angulations, it may be there. So how to prevent it? So before starting with the treatment, just have a look at the preoperative radiograph for 30 seconds. Determine the crown root angulation. Determine the depth of the pulp chamber. Determine the angulation of the, determine the long axis of the tooth, so that you know how the burr has to be placed. The burr has to be placed along the long axis of the tooth. The angulation of the burr should be along the long axis of the tooth. Then only the perforations can be prevented. Okay. And during instrumentation also, we must assess the crown root angulation. If we are inserting the file straight, okay, it may end up in the periapical area, because this crown, you can see it is slightly tilted. So if we use the burr in a straight manner, it may end up in perforation. So we have to assess the crown root angulation also. Then it may also, perforations may also occur because of the during post-space preparations. Okay, perforations may also occur during the preparation of the post space. So here you can see the perforation has occurred during the post space preparation. The perforations, they may be there in the coronal tooth. The perforations may occur in the radicular area. Okay. So if they occur in the coronal tooth structure, why do the perforations occur in the coronal tooth structure? They may occur because of the calcifications. Maybe the tooth is calcified. So while locating the root canal or orifices, the perforation may occur, or because of the incorrect because of the crown root angulations. If you have not determined the crown root angulation properly, then there are chances of perforating the tooth. Or the perforations may be radicular. So if they are in the root, they may be in the cervical third, they may be in the middle root, or they may be in the apical third of the root. So why do the perforations occur in the coronal third or the middle third of the root? So these generally occur because of the overzealous instrumentation. So if we don't determine the root curvature, if we don't prepare a straight line axis, we don't follow the canal anatomy, then we may end up in perforation because of overzealous instrumentation. We may end up in strip perforation along the lateral aspect of the root. Or And why do the perforations commonly occur in the apical root? They may occur if the canal was curved, so because of the root curvatures, the perforations may occur, or because there was a ledge, and while we are trying to bypass the ledge, and we are using the instrument forcefully, so we may end up perforating the root in the apical third, or because of the blockages, if some debris has got blocked, we have not recapitulated the canal, we have not used adequate irrigant, then we may end up with perforation. So how will we diagnose now? How will we diagnose a perforation? There will be sudden pain. जैसे ही perforation होता है, the patient will complain of sudden pain and they will be bleeding from the defect. So even a paper point can be used to determine the location of the perforation. Here we can see the bleeding spot. It will determine the level of the perforation. Electronic apex locator, they are very helpful to determine whether it's a perforation or whether it is a canal. Okay, and then evaluate the tooth under magnification. We can use loupes, we can use dental operating microscopes to see whether perforation is there, whether if it's a perforation or a canal, and then we can treat it accordingly. And CBCT may also be helpful in determining the perforation. Now, how to manage the perforation? Okay, perforation, as soon as we detect that there is a perforation, it has to be managed at the same time. Don't delay the sealing of the perforation site. Okay, it should be done as soon as possible so that there is the treatment prognosis is successful. And it depends upon the ability to seal the perforation to re-establish a healthy periodontal ligament. Because once we seal the perforation, then we can re-establish a healthy periodontal ligament. So what has to be done? As soon as we detect that there is a perforation, just stop the instrumentation. Okay, उसी time instrumentation को आप बंद कर दीजिए. Control the bleeding, assess the site of perforation, seal it immediately. And different materials are available in the market. MTA is there, bioceramic is there. So this is MTA. Okay, all might be aware what is MTA. So it is available in powder liquid form. It is very useful for sealing the perforation. The advantages being it sets in the presence of tissue fluid. So whenever there is perforation, slight amount of tissue fluid is also always there. So we must use some hydrophilic material so that the material sets in the presence of tissue fluid. So MTA is very good at it. It is biocompatible. It is osteoinductive, that it causes regeneration of the cementum and the periodontal apparatus. And research has concluded that the success rate after the perforation repair is 81% and even more. Okay, so don't panic if there is a perforation. You can repair it and the treatment will be successful. But MT has got some disadvantages, like we can't because this MTA they may cause discoloration of the tooth and it has got a longer setting time. Okay, uh, so other repair materials can be used like biodenting, which has got a shorter setting time and it has got a lower potential for discoloration. And other root repair materials are bioceramic endosequence root repair material, which is available in two form, fast set paste and also as an BC endosequence RRM, but as we can see in the picture. So these materials can be used to repair the perforation. So here we can see it is a case of perforation repair that we have done. You can see the perforation in the coronal aspect of the tooth because of the improper angulation of the burr, and then it is healed with the help of MTA and the tooth was successfully treated. The patient is fine. So here's a small video I would like to share with you while we have repaired the perforation. So this was done under magnification. Now this is when the perforation is in the coronal part of the tooth. Now what has to be done if the perforation is in the middle third or the apical third of the root? So how it needs to be managed? So if the perforation is in the middle third of the root, what you can do is after cleaning and shaping, what you can do is like you can first do the obturation of the canal which is apical to the perforation. First, obturate the canal which is apical to the perforation, okay? And then the defect is sealed with the MTA. There are two aspects now. You can seal the defect and obturate the rest of the canal with MTA. And one aspect is that you can seal the defect with MTA and then place a small wet cotton pellet, moist cotton pellet into the canal. See, with MTA, after we have sealed the perforation, whenever using MTA, because it has got a long setting time. So after using MTA, the canal, it has to be packed with a moist cotton pellet for 24 hours, and the next day the patient has to be called by the time the MTA sets, and then you can further proceed with the treatment. So if it is in the middle third of the canal, either you can go for an obturation of the canal apical to the perforation, then seal the defect and the rest of the canal with MTA. Or the second thing is you can seal the defect with MTA and use a paper point to adapt the MTA to the canal wall. Okay, you can use a paper point, you can use a GP to adapt the canal with to adapt the MTA with the canal wall. Then place a small cotton pellet, moisten cotton pellet, and then ask the patient seal the canal, and then ask the patient to return after a day or two, and then you can obturate it with a thermoplastic guttapage. Okay, but in some cases, even after these things, if we find that we are not able to reach the location perforation site, and if it is not manageable, then what can we do is reflect the flap, and then surgically we can repair the perforation site with MTA. And one more thing we need to take care while using MTA is that if there is association between the communication, if there is communication between the site of perforation and the oral cavity, then the MTA will be flushed out. Okay, it will be flushed out. So what to do in such cases? In such cases, we can use resin bonded GIs. Jerry store we can use to seal the perforation in such cases. The best way to manage perforations is to prevent them. Okay, this was said by Gutman that the best way to manage perforations is to prevent them, because every endodontic complication prevention is always better. The efforts that we need to prevent is always less than the efforts that we need to manage it, because multiple times efforts have to be taken to manage any endodontic complication. Okay, so have patience. We must always have patience while doing any endodontic procedure. We should not rush the procedure. Do it calmly and take all the precautions to manage. Take all the precautions to prevent the to prevent any endodontic complication from happening. So how would we prevent a perforation from happening? We know that in case of mesobuccal root of the mandibular canal and in case of maxillary premolars, the inner wall of the dentine, it is thin, and the outer wall, the dentine, is thicker. Okay, so this inner wall, it is known as a danger zone, and this outer wall is known as the safety zone. So while we are instrumenting these canals, anti-curvature filing can be done. What is there in this anti-curvature filing? We direct the instrument. The instrument is directed when we do the biomechanical preparation. The instrument is directed towards the outer wall. Here we can see the instrument is directed towards the outer wall of the canal. This will prevent excessive dentine removal from the inner canal wall where the dentine is less, and the chances of perforation, the strip perforation, will be minimized. Okay, and always use magnification, because what we see, we treat. What we can't see, we can't treat. So always use magnification, and controlled instrumentation is the key to prevent the perforation. So these are the 10 golden rules for safe endodontic practice. So brushing up with them, know the anatomy. We must be aware of the anatomy of the tooth, the anatomy of the canal before we start with the access opening. Evaluate the preoperative radiograph, know the anatomy, and then only initiate the access opening. Give time for access opening. Access opening is a very important step. We should not rush it. Okay, if we have done the access opening appropriately, then just relax. We have done 90% of the treatment. Okay, establish straight line access. Always determine the working length accurately. If you have determined the working length accurately, then we won't go beyond the apical constriction. Okay, never instrument beyond the apical constriction. The irrigant, the medicament, they should never go beyond the apex. Copious irrigation should be done to disinfect the canal, because we can't instrument each and every part of the pulp space. Okay, pulp is a very complex anatomy. There are isthmus, there are ramifications, there are so many lateral canals. It's not possible to instrument all those. So copious irrigation is very important so as to disinfect the canal. The irrigant will disinfect the entire pulp space. The medicament will disinfect the pulp space. So copious irrigation is very, very important. And next is never force the files. The files, they need to be used passively. We should not force them beyond the apex, okay? And create glide path. Always create glide path with a smaller file size, with the 10 number file size, with 15, with 20, before using the larger file size. Always create glide path so that the file glides into the curvature, okay? Then use magnification. Already I've emphasized that magnification is important. It has become, now it has become compulsory basically. It has become it has become compulsory to use magnification nowadays. Okay, it's not कि ठीक है नहीं use किया तो चलता है. We should use magnification. Okay, recognize the complications early. As soon as you think that there is a complication कि perforation हुआ है क्या शायद, या कहीं instrument तो नहीं separate हो गया है शायद, तो recognize them early. As the earlier you recognize it, the better prognosis it would be. Okay, it would be easier to manage and the prognosis would be better. And और सब कुछ करने के बाद भी, even after doing all those things, still there is any mishap, then it can be managed systematically. And still, if you are not able to manage, then refer. Don't hesitate in referring the patient to the specialist. Refer whenever there is necessary. You can always refer the patient to endodontist. Okay. So take home messages: complications are not failures. Failure occurs only when we fail to recognize and manage them appropriately. The best management of an endodontic emergency begins long before the emergency occurs. So whenever there is an emergency, don't panic, stay calm, stay confident, and manage systematically. These are the references, and thank you all for a patient listening. Now I'm open to questions.
Thank you so much, ma'am, for such wonderful and insightful lecture. Ma'am, there are some few questions in the chat box.
Yeah.
The first one is how to know coronal seal is good in inter appointments, like it's not leaking.
See if we must see, we use generally zinc oxide eugenol, okay, the cavet for coronal sealing. But we must try to use GIC for temporary sealing also, if possible. Because if we use cavet, then still there are chances that because it is porous, so there are chances that the micro leakage may be there. Or instead of using the zinc oxide, which we mix it in over, we should use cavet. So that is, and it should be sealed properly. Okay. And in cases of class 2 access, if there is a class 2 access, then pre-endo buildup has to be done. Okay. If there is a pre-endo buildup, then only the occlusal portion needs to be sealed. The coronal sealing has to be done only from occlusal. The temporary material has to be used only occlusally, not interproximally. So that also ensures that we have sealed the canal properly, we have sealed the pulp chamber properly. Okay. And next, question that I can see is minimum concentration of sodium hypochlorite per canal to be used. See, the concentration of sodium hypochlorite that is advocated is 5.25%, but it has to be used with rubber dam. If you are using rubber dam, then we can use 5.25% sodium hypochlorite, because if you are not using a rubber dam and if it goes into the patient's throat, then there are chances that the patient may have injury in the throat, and there may be some mishaps associated with the sodium hypochlorite. So always use rubber dam if you are using 5.25% sodium hypochlorite, and then we can. But if you are not using rubber dam, always use isolation using cotton rolls on buccally as well as on the lingual side, and use suction properly while irrigating the canal. You might have seen some self-made suction tips where we can attach where we can attach the needle, 18 gauge needle at the end of the suction tube, and then that needle goes into the pulp chamber, and then hypochlorite will be hypochlorite can be removed by the suction. Okay. So any other question? There was a case, a patient had severe abfraction with history of pain, and radiographically apical abscess was seen. So we initiated root canal treatment. Canal was visible from buccal region in excavation. So we still need to make the access opening from occlusal surface. So which tooth was this one, ma'am? Was it premolar or was it anterior? See, even if it is molar, then definitely it has to be done from the occlusal side, because without initiating access from the occlusal aspect, we won't be able to reach the we won't be able to establish straight line access for the palatal canal or for the distobuccal canal. Okay, but if it's an anterior thing, if it's a incisor, then no need to establish routine access from the routine area, that is palatally. We can go from the buccally also. We can go from there. So it depends which tooth it is.
Ma'am, it is written in the chat box that it was a mandibular first
Mandibular
premolar.
first premolar. If it is
Yes, ma'am.
mandibular first premolar, uh, mandibular first premolar, then we can go from that area. But see, again, there is chances that one more canal may be there. Sometimes there are two canals. Okay, so we must assess the preoperative radiograph. If there is single canal, then we can access from the buccal area. But if there are two canals, then occlusal access has to be done. Okay, so we have to assess the preoperative radiograph. And minimum volume of sodium hypochlorite during one root canal treatment, approximately 20 ml of sodium hypochlorite has to be used. Okay, if you are not using rubber dam, then 1.3% sodium hypochlorite has to be used. If you are using 5.25% sodium hypochlorite, then rubber dam is a must. Okay, and proper evacuation of the suction of the sodium hypochlorite is to be there using the suction tips.
Thank you, ma'am. I think so that's all. Oh, there is one more question. Can you explain instrument-related factors in instrument retrieval?
Yeah, see, the instrument related factors are, first, the material of the instrument is made up of, whether it is stainless steel instrument or whether it is made up of nitrile. If it is made up of stainless steel, then uh, while retrieving, there are less chances that the instrument will fracture again. If it is made up of nitrile, then I've already told that if it is nitrile, then because of the heat that is generated by using ultrasonics, it may again fracture. Okay, so this factor has to be taken care of while we are retrieving the separated instrument, and also the size of the instrument. If the instrument is smaller in size, then ultrasonics is enough. But if the instrument is larger in size, then in those cases, along with the ultrasonics, we have to use the microtube method, or we have to use the loop technique to retrieve the separated instrument. That will be beneficial. Otherwise, the instrument, it gets loosened, but it does not come out of the canal. It just keeps moving inside the canal. And
Ma'am, there is one last question, that how to know bleeding is coming from pulp chamber or canal?
yes, see, whenever you are doing a root canal treatment and suddenly the pulp chamber is flooded with the blood, so what you can do is you can first rinse the pulp chamber with the sodium hypochlorite, because rinse it with sodium hypochlorite, and then dry it with the cotton pellet. Dry the chamber, dry the canal with the cotton pellet, and then assess it under magnification. You can use loupes, or if microscope is available, then it's very nice. So and then you can evaluate whether it is coming from the pulp chamber or the canal. If it is from the pulp chamber, you can see you will see the bleeding spot. Okay, whether it's the bleeding spot is in the pulp chamber or the canal. And next question is, which ultrasonic is good to buy? See, ultrasonics, there are many ultrasonics available in the market. Initially, they used to initially like pro ultra tips from dense ply were there, and even titanium tips are there from Kiss titanium tips are there, and CTR tips are there. But nowadays in the market, many low budget tips are also available. You can go for woodpecker, you can go for satellite, or you can go for Walden. These are stainless steel tips, and they are relatively budget friendly. So even though are equally good, those are equally good. So no need to go for high end ones. And which loops to buy? Uh, See, I would recommend that instead of purchasing uh, budget friendly, we should go for little high end ones, because with the loops, see, the purpose is magnification. And if we go for some budget friendly ones, so they don't have that much field of view, and the depth of view is also not that good. And so, since it's a single time investment, so better to go for good ones. And nowadays, even ergo loops are there. Initially, ergo loops were not there. Now, there ergo loops are there. So, it will help in ergonomics. So, the neck will be entirely straight, the back will be entirely straight. So, if one can afford, then preferably go for TTL ergo loops. Okay, you can go for any magnification between 3.5 to 5.5x. Generally, 3.5 is recommended. Okay, because it's one-time investment, it's costly. So better to invest one time in 3.5, or you may also go for 5 times magnification. And nowadays, ergo loops are the best ones that you can go ahead, because it's one-time investment. So थोड़ा सा एक बार invest कर लें तो लाइफ लॉन्ग वो काम आएगा, अच्छे आपके ergonomics के लिए अच्छा रहता है. And which is good to buy, piezo scaler or Ultra X? See, scaler, it depends. Like you can go for piezo scalers also, and you must remember that you should purchase the tips that is compatible with your scaler. Okay, there are two types of attachment. EMS attachment is there, and there is satellite attachment. So you should know what type of scaler you have, and then purchase the ultrasonic tips which is compatible with that, because the satellite ones they don't fit with EMS, and EMS ones they don't fit with satellite ones. Okay, so that you should be aware of. So any further questions? Coronal use abrasive. Why not in apical? Because we need to remove dentin. See, the abrasive ultrasonic tips, they would remove the dentin. Okay, and in the coronal portion we have some amount of dentin available. Okay, so if we use abrasive, we can establish a straight line axis so that the coronal portion of the separated instrument is visible. But we can't use it in the apical portion because already the amount of dentin available is thin. You can see the circumference in the of the apical root. Okay, it is less. So if you use abrasive ones in the apical portion, it will remove excessive dentin, which may end up in perforation. You may end up in perforation, or you may end up in removing excess dentin, which will lead to fracture of the root. Okay, so in such cases, we can use plain ultrasonic tips in the apical area, and instrument gets retrieved. We have to you prepare a trough around the separated instrument, ultrasonically activated, and the instrument is retrieved. Okay, only thing is it takes a bit time, but it is always safer. Abrasive can be used in the coronal portion because the dentin thickness is more there.
Thank you, ma'am. I think there are no more questions.
Okay, thank you so much.
Thank you,
And
ma'am.
I really thank the organizing committee for giving me this opportunity. Thank you all.
Thank you, ma'am. Thank you so much. Moving on to our next lecture of the day. We have Dr. Devyanangi M. Ma'am with us. Ma'am is Professor and Head Department of Oral Medicine and Radiology, Adi Parashakti Dental College and Hospital. Ma'am will be discussing about CBCT-guided endo from diagnosis to surgical plan in real cases. Ma'am, we welcome you.
Yeah, thank you so much, CynoDent. It'd be a pleasure meeting you all in this online conference. Thank you so much for inviting me for this wonderful session. Am I audible?
Yes, ma'am, you are audible and visible.
Okay, thank you. Shall I share the screen now? The screen is visible.
Yes, ma'am, it's visible. We can start with the lecture.
Yes. So, very good morning, all of you present here in this online conference, Endo Mastery Summit. So, my topic is on basically about cone beam computed tomography. For the past 2 days, you must have been revised your basic knowledge or advanced knowledge about the complete endodontics, like starting from the basics and how we can proceed with whatever the emergencies. Previous topic, ma'am, have discussed beautifully, like. All the emergencies, and yesterday also it was a wonderful session from various authors and speakers. Today we'll discuss about CBCT guided endo from diagnosis to surgical planning or real planning in real cases. Okay, today we'll discuss about the basics of how we can proceed with the cases in complicated scenarios, right, with the help of cone beam computed tomography, because I am basically a radiologist with CBCT reporting specialist. So I can definitely help you with the basic instructions and tips how to proceed with the complicated cases when it comes to endodontic practices. Okay, these are all the contents we can go through today. Why CBCT and how we can use the guided surgery in apart from, I mean, we obviously know implants can use, we can guide the surgical guides, but how we can proceed endodontic guides in our complicated cases, right? So first we should know what is cone beam computed tomography. As we all know, this has been dramatically changed the diagnosis in dental diagnosis due to three-dimensional imaging and high resolution multiplanar imaging, right? So it allows clinicians to visualize the tooth and surrounding structures. It permits to do with the much overlapping images, right? So it allows, especially when it comes to endodontic practice, it allows the clinicians to see the pulp chamber morphology, canal orientation, and even pericervical dentin thickness, and all the anatomical variation we can see clearly in three-dimensional cone beam computed tomographic imaging, right? So these are all the learning objectives we are going to see today. Understand indications of CBCT in endodontics, recognize the limitations of conventional radiographs, and interpret CBCT findings systematically, and how we can apply in real cases, and how to plan non-surgical and surgical endodontic treatments, right? So basically, the success of endodontics. So you must have heard of this kind of terminology like MIE. What is MIE? Minimally invasive endodontics, right? So MIAC stands for minimally invasive access cavity preparation. So another one term we should keep it in mind for the successful endodontic practices: pericervical dentin thickness. We should protect the dentin thickness. So pulpal canal obliteration is also keeping an important vital role in deciding the success of the endodontics. So these are the main factors we should keep before starting practice. So overall, the prevalence of this pulpal canal obliteration after traumatic injury in permanent teeth, it comes around 27.6%. So that is the main reason for majority of the failure cases. So overall prevalence in primary teeth, it is around 21.9%. So according to the trauma literature, the reported incidence in permanent teeth, it ranges from 4 to 24%, depending on the type of the injury and follow period. So why conventional? We are obviously choosing conventional radiology in endodontics like everyday practice, but why we have to choose CBCT, and what are all the scenarios we have to recommend the patient to go for CBCT? Okay, so two-dimensional radiographs gives you a superimposition, we all know, and geometric distortion, and some mystic canals most of the times, and underestimated lesions. We might have seen it's a periapical simple radiolucency, right? But sometimes it goes beyond the boundaries. So that kind of compromise can happen in two-dimensional radiographs. So CBCT provides true 3D anatomy, and accurate lesion size and cortical plate involvement and canal morphology. It gives accurate canal morphology and relationship with the vital structures. How can we proceed without damaging the vital structure? These are all the points we can look into this CBCT. So as per AE and AAMR position statement, they are recommending CBCT only, especially in this endodontic practice. Whenever conventional imaging is insufficient, if we are not getting enough information in 2D IOPA and complex anatomy suspected, if you are seeing the additional canals, accessory canals, obviously we should go for the CBCT. And resorption, we might think it is an internal resorption, so sometimes it goes external resorption as well, an inflammatory resorption. So these kind of resorption we cannot predict through 2D image. Obviously trauma cases, we might miss the small trauma lines in 2D imaging. And surgical planning and failed root canal treatment, multiple repeated failure, obviously we should go for CBCT. So these are all the scenarios you should keep it in mind, that better we can refer CBCT. So parameters, obviously will recommend small FOV because it gives you a excellent resolution. Vocal size is also very small, but exposure is also small, but resolution will be a really good in small field of view. So whenever you are referring the patient to CBCT for endodontic practice, always write small FOV measuring, particularly pertaining to the tooth, or 1.6 or 2.6 like that. And we are definitely following this Alade principle, as low as diagnostically acceptable, being indication oriented and patient specific. This is the important point, because we all know ALARA, it came into the action in 1977 by ICRP. It gives a minimum radiation dose, but then we practice to the ALADA as low as diagnostically acceptable. That is more than enough, proposed by Dr. Gerald. It gives the lowest radiation dose to the patient. Then we move on to now by Oprah initiative, it's ALADA. It's a patient specific and indication oriented. This is the concept we are following right now. It's initiated from the 2017. So it gives you obviously a 3D advantage. CBCT gives you accurate diagnosis. In 2D, as we discussed, we can see extra canals in CBCT and root fracture and periapical lesions extent underestimated sometimes, and perforation difficult to localize in the IOPA. Obviously here we can use where we can see clearly the perforation. So it gives you a precise planning and improved outcomes. Patient benefits is also important because it gives a less invasive procedure. It's not a high-end CT or that kind of radiation will not be happen. So obviously patient is also benefited when we are going to precision-oriented treatment, right? And it's evidence-based practice. So as a radiologist or endodontist, whoever seeing CBCT before starting any endodontic treatment in a complicated cases, you should keep this checklist. You can note it down in a paper or whatever. You can just note it down, the checklist before starting interpreting any CBCT before starting case. So whether it's a lesion present or not, you can confirm the presence of the lesion or pathology. Then coming to the size. So you can measure with the scale present in the CBCT software, obviously height, width, depth. We can record the largest dimension, not with the smallest. You can go slice by slice, sagittal, axial, and coronal slices. Record the largest dimension of the particular lesion. You should keep that in mind. Then borders, whether it is well-defined border or ill-defined border, whether it is a corticated or non-corticated. These are all the points very, very important before starting the case. Then cortical perforation, assess the integrity of the cortical plate. You should assess whether the buccal plate integrity is maintained, and lingual plate, palatal plate. So all the sides of the thing, you should check the integrity of the cortical plates. Then coming to the root morphology, you should check shape, length and curvature, a number of roots, even dilation, fusion, taurodontism, all these kind of root morphology we should be assessing before starting. That gives you 100% success rate in endodontics. And accessory canals, MB2, radix, all the canals you can assess. And fracture, just check the J-shaped lesion or C-shaped canal. So those things are it could be overlap with the fracture line. So we should identify whether it's a vertical fracture or horizontal fracture or oblique fracture, right? Then we move on to resorption. As I said, internal resorption, external resorption, replacement resorption, all inflammatory resorption. So this kind of resorption must be noted down. Then adjacent vital structures, coming to the floor of the sinus and inferior alveolar canal, nasal floor, everything must be assessed. Then coming to the incidental findings, obviously as a radiologist, we can point out and tell the endodontist before starting the procedure, you should be monitored the incidental findings also, right? We'll recommend the endodontist. So now we'll see the real cases with the CBCT guidance. So we got a patient, a 28-year-old female. They have the upper left back tooth pain even after the root canal treatment in 6 months. So it shows the deep restoration in 2/6, mild tenderness and percussion, no swelling, nothing, no sinus involvement. The conventional radiograph shows the obturation is perfect, pakka, nothing, no evidence of swellings or sinus opening, no obvious missed canals. But when we are obviously patients keep on getting the consistent pain for the past 6 months, so we have recommended a small FOV of 2/6. So obviously we identified the one more canal, that is MB2 canal. You can see in the 3D occlusal view clearly MB2 canal. We identified the canal and informed the endodontist, and they have navigated the canals and did the obturation. Obviously after that the patient is completely fine. The post-operative image also can show you not much of a PDL space widening and inflammation has been subsided. And this is the case, a 35-year-old male patient. He came with the complaint of pain on biting with the intermittent swelling on the lower first premolar. And clinical examination shows a mild swelling in the buccal vestibule. A deep periodontal pocket can be visible on the distal aspect. The patient had pain while biting, but it's released normal at rest. So in conventional image, to IOPA shows that no fracture line, normal periodontal ligament space, and even periapical area also appears normal, right? So this case we have obviously suggested to the CBCT and the axial view. So this is the main point. You can see in the axial view, you can see J-shaped radiolucency. If you see J-shaped radiolucency, obviously it might suggest the vertical fracture line. In sagittal view, you can clearly identify this kind of vertical fracture line with the J-shaped radiolucency. So obviously with the fracture, it cannot be treatable or restorable. Tooth has been extracted and we have placed the implant, and socket preservation also has been done. So this is one of the cases. You can definitely suggest CBCT for root fracture cases. If patient, the IOPS was completely fine, everything is good, then we can proceed with the CBCT. The another case, dense invaginatus, this is a rare case. Most of the time, this CBCT shows that extent of the morphology of the invagination. So you can identify careful access to the invagination, identification of the separate canal system. You can choose selective instrumentation for that particular canal. See, you can identify this enamel invaginatus and creating the separate canal system. So you can seal the invagination with the MTA to prevent micro leakage and reinfection. So this is a treatment you can suggest if you identify dental invagination into the pulpal chamber. The next scenario we commonly encounter in the practice is external cervical resorption. So obviously CBCT changes the diagnosis and treatment plan. The conventional radiograph shows irregular radiolucency at cervical region. It appears to be internal resorption extending to the canal. But what CBCT shows? Well-defined external cervical defect on the labial surface. Well-defined cervical resorptive defect. So lesion confined to cervical third, no communication with the pulp space, intact palatal plate, no periapical pathology. So this is how you can see in axial, coronal view and sagittal view. The defect is called as external root resorption. In conventional radiograph, even repeated root canal treatment also, you cannot solve the problem, right? If you treat the external resorption only, you can through the restoration of the defect with MTA, it complete the restoration. So regular follow-up needed for this kind of cases. So you can classify this resorption as class 2. So these are all the cases. You can see internal resorption. Hope the image is clear. I can zoom it on. Right? Internal resorption, external resorption, and replacement resorption, inflammatory resorption, and cervical resorption. So these 5 kind of different resorption endodontists keep in mind before starting treatment. So here you can see the difference. Internal resorption shows well-defined radiolucency within pulp chamber. It may perforate dentin, but external resorption, irregular radiolucency on root surface, loss of root contour with the variable depth. And replacement resorption, loss of pedial space, root borders blend with the bone. It shows the replacement of the tooth can be replaced with the bone. So it can merge with each other. And inflammatory resorption, obviously because of the pulpal necrosis or periapical periodontal infection, it shows irregular root surface and associated periapical pathology. So cervical resorption, it may be due to trauma. Well-defined radiolucency at the cervical area may involve external or internal aspects. Okay. So this is the key differentiating point. Internal and external resorption within the pulp space on the root surface. The spadial space is preserved in both internal and external. The spadial space is lost in the replacement resorption. In internal and external resorption, there is no pedial space changes. Only in the cervical resorption, you can see the pedial space lost. So this kind of yearly identification, what type of resorption helps you the successful endodontic treatment. This is the overall combined slide, shows you how the CBCT helps the limitations. It overcomes the limitations of 2D radiograph. It detects the hidden anatomy and pathology like missed canals, ledges. You can see the separated instruments here. See, in the sagittal canal, you can see the separated instruments, and you can see the perforation in the sagittal slices and persistent infections, root fractures, and sometimes overfillings. Sorry. So you can identify, understand, manage, and succeed the root canal treatment by following all these steps. So as per the survey, 62% of success rate with the 2D radiography, 84% of success rate, higher completion of the healing rate with the CBCT. As per the clinical studies, it shows 84%. Now we see that what is guided endodontics. Because most of the cases with the pulpal obliteration, we definitely ask the endodontist to go for the guides that will help them to identify and the path of entry path. So what is guided endodontics? So it is also known as TET, that is called targeted endodontic treatment. The guided approach can be static or dynamic. So it's a way to use CBCT merged with optical imprints. So far in all the slides we have discussed about the common cases, how we can encounter the problems, how we can treat with the help of CBCT. Now in the guided endodontics, if you have seen the severe compromised pulpal obliteration cases, how we can proceed with the template. Okay, that is what we are going to discuss. So static guide is made by using a combination of CBCT scan and surface scan. So surface scan is otherwise known as optical scan or intraoral scanning. Okay, so intraoral scanning is nowadays common everywhere in clinical practice. So if you have CBCT scan and intraoral scan with a third-party software, we can merge the data and prepare the particular surgical guide, and you can place it on the patient's mouth and do the drilling of the pulpal space to remove all kind of obliteration from the canal, right? So this 3D endodontic guide or endo guide is a template fabricated to guide the drills into pre-planned position for localization and exploration of the root canal orifices or bone trephination. Even bone trephination also we can do with the guide. So indications or uses of guided endodontic therapy is pulpal canal obliteration or complete calcified canals cases, and it can be used to remove or retrieve the broken part of the endodontic instruments such as file from the root canal, and it can be also indicated for removal of adhesive fiber post. So advantage, it's chair time is greatly reduced if you have pre-planned. If you are not planned in the prior way, sometimes we end up taking hours and hours to remove the broken parts and to remove the calcified canals. Whatever you do with the regular K files, it definitely we cannot negotiate the calcified canals, right? So if you identify the calcified canals in prior hand, obviously we can do the template or guide. So with the help of the guide, we can easily glide the pathway and reach the apical foramen. So for the management of pulpal canal obliteration following trauma, guided endodontic therapy can be a better option, and it reduces the risk of ledge formation also. So disadvantages are there because it's time consuming, because it's before that we should do a preparation, right? It's not on the chair time, it's a preparation time. Like we have to do CBCT of the particular patient. Sometimes patient thinks that the radiation dose might be harmful for me, so that kind of thing might happen. And we have to do intraoral scanning, we have to do merging with the commercially available software. A lot of softwares are in the market. You can choose a Blue Sky Bio. This kind of software helps you to prepare the guide, but it takes time to get the guide in our hand. So it cannot be done in a curved part of root canals, right? CBCT helps you to identify how the canals appears, how many accessory canals, MB2, everything can be identified with the CBCT. But for the guided surgery or surgical endo guide, we cannot do in a curved canal. It's really difficult. And it's costlier. Obviously, we have multiple things to do, scan, CBCT, and all. And it's a required procedure in a guided therapy because radiation exposure is one of the major drawback. But still, we are following ALADIP. This is a sample case of 3D meshwork in endodontic guide in a software. The left side image shows software image. The right side shows is a printed 3D guide. So types of guide as the implant surgical guide, we are also having here non-surgical and surgical guide. And with the support, we can say it's a tooth supported guide or mucosa supported guide and bone supported guide. Once you start using these kind of guides in your practice for complicated case in endodontics, you never go back. You will always ask for the guide because its chair time will be reduced. Patient feels comfortable. Even though it is a little bit expensive side, you feel really relaxed on the table and do the surgeries with the comfortable way. So that kind of advantages are there in endodontic guides. So tooth supported guide, if patient is completely dentulous, you can place the guide over the tooth and tooth can give you support. It will not fall back. If patient is edentulous, completely or partially edentulous, and there is no tooth to support the guide in particular area, obviously we can take the support from the mucosa. And bone supported guide, we can do the trephination or root removal, those kind of surgery we can do with the bone supported guide. As I said, the basic steps we need, first thing is a CBCT scan. Then we can do optical scan or surface scan or intraoral scanning of the patient, or else we can do we can take the direct impression from the patient and pour the model and give it to the lab, and they can do the indirect scanning. That is also another way of optical scanning. Either directly you can do a patient mouth, or indirectly through the stone model also. So merge the CBCT scan with this intraoral scan, and we can plan the endodontic guides. So the superimposition is really crucial point. The radiologists, we do effectively, and we know how to mark all those things, or else even endodontists also, if they have enough practice, they can do easily. You can mark at least minimum 6 tooth on the each side, and if you merge with the software, see, this is the image, and this yellow line shows you the guide, whatever the guide you are going to prepare, this surface you need, and this is the sagittal view. Here you can see the access path, right, this yellow line, and this orange line gives you a sleeve, the metal sleeve, where you are going to place the drill here, and this is the access opening till whatever the space you need. If for example, out of 19 mm, the 10 mm only calcified canal is there, or 9 mm is with the if you can see the canal orifice means, with the 10 mm alone you can do drilling. The rest of the thing you can do the manual dynamic the system. So designing endodontic guide, you should trace the canal step by step from the entrance point till the target point. Target point means the complete obliterated space. So creating the virtual drill path, and you have to select the sleeve also, metal sleeve, where you are going to place the drill system, to remove the calcified canals. So other parameters also to be considered for endo guide planning, because the sleeve diameter should be at least 1 mm above the diameter of the drill, whatever the drill we are going to place. N number of commercially available system, SS White or Muller system is available for this guided drill system, right? So tracing the canal, locate the calcified canals and scan slowly, and mostly we always can see the trace of the pulpal radiolucency present, which helps to guide in tracing the entire canals. It creates the virtual path here, you can see, right? So the drill path should extend from the entrance point at the incisal or occlusal surface. You can do anterior tooth also and posterior tooth also, it heading to the target point where the complete pulpal obliteration exists. So target point and angle of the drill path in 3-dimensional. In 3-dimensional, you should assess the angle of the drill path, right? In sagittal, coronal, axial slices. In all 3 multiplanar MPR slices only, you have to assess you have to decide the drill path. And diameter of the drill also, you should keep it in mind. So this is the target point, right? This is the virtual drill path. This line is called as virtual drill path, and yellow part is the virtual sleeve. Okay. So this image give you a clear picture of how it will be there. This gliding area, target point to the entrance point. That the drilling thereby reaches the root canal space and short of the target point. So diameter of the drill has to be big enough to avoid bending of the drill during usage. For non-surgical endodontics treatment, recommended diameter of the drill is 1 mm. Some endodontists prefer 0.8 or 0.85 mm also, but 1 mm is the maximum drill diameter we should recommend to the endodontist. So this is the sleeve we are talking here. Either hand hold with the hand. So once you got the 3D printed guide from the laboratory, you can place it inside the mouth and you can hand hold the sleeve inside and place the drilling. Or else drill hold sleeve inside. We can place this sleeve inside the guide itself. You can fix inside the guide itself, or else you can use the hand hold sleeve inserts also. So static guided non-surgical approach for calcified canals of anterior teeth. The same principles and same protocols only in both anterior and posterior teeth. The only thing in the posterior teeth, you should keep it in mind that patient should be having enough mouth opening or interocclusal distance, so that the guide can be placed freely inside the mouth, and you can keep the drill, and you can do the drill with the enough space. Otherwise it's difficult to position the guide along with the drill. Even drill head of the drill, again it comes around 1 to 1.5 mm. So we should keep that in mind and think about the posterior tooth, right? So this image will give you a clear picture. So you can check the stability and marking pen with the blue composite. Okay, you can mark it in the incisional area where you are going to place the guide. And initially you can do access drill or pilot drill opening without the guide itself. After that, you can place the guide and do the drilling. Limitation, obviously it works for the straight parts of the canal, and tooth must be able to stay in a fixed position, because we cannot change. Once we have taken the CBCT scan and intraoral scan, we prepare the guide, it should be the exact way, it should fix in the patient mouth. Otherwise the guide will not be fit. And sometimes presence of the metallic restoration or fillings also can give the artifacts in the CBCT that gives inaccuracies in the treatment planning. And limitation of the availability of the armamentarium. Sometimes the burr system cannot be available, but most of the times nowadays many systems has come into the market for endo guide. And posterior teeth is also the only point is interocclusal distance is optimum to accommodate endodontic guide, burr and handpiece. Handpiece head, burr, guide, all this should be fit into the posterior teeth. So you should keep that in mind. The other steps are all the same like anterior and posterior teeth. Check the stability, evaluate the dimensional accuracy of the guide burr. With the help of the guide, mark the entry point of the axis, remove the enamel or existing restoration of the free hand without a guide. After removing enamel, you can place the guide and secure it with the fingers or fixation screw. Then you can start negotiating the calcified canals. Right? Insert the guide burr in the sleeve drill and drill cautiously into the dentin. With this approach, we can achieve directed dentin conservation. To avoid overheating, you should use the copious amount of water coolant and irrigation system. Start drilling with the short burr first. After reaching the coronal third of the root, use long burr to reach the target point. So once you place the guide, you should start drilling with the short burr. After reaching the coronal third of the root, use the long burr to reach the middle third or till the end of the apex, depends upon the obliteration of the canals. For multi-rooted teeth, usually one guide is not enough, as we have to plan and design drill guide for each root canal. Okay, so it depends upon the 3 canals or 2 canals. We should be having a different guides. In the implant system, we use stackable guides for bone supported implant guide, surgical guide. Likewise, we have multiple guide can be used for multi-rooted teeth, depends upon the canal length. So static drill guides do not allow any changes in treatment plan. To overcome this limitation, dynamic navigation using endodontics can be used. Dynamic navigation is another a big concept. Maybe in future, if we have get the opportunity to discuss with you all, we can discuss that dynamic navigation. So this is the overall point of preparation for surgical template. We need simple CBCT with impression, or stone model scan, or intraoral scan, or scanned impression. That is also another method. You can take the scan with the alginate impression also. We can do scanning. A non-guiding 3D printed template to help access for the surgery. We can retract the soft tissue to ensure access to the surgical surgical site. Such surgical aids do not localize the root apex, neither do they guide a drill nor bone trophine. I'll explain this in upcoming slides. So this guide helps to define the exact site where the cortical bone should be penetrated for root end resection. If you are going to remove the root tips, if you are going to do the periapical surgery, so you don't know where to place exactly, where to open. So in that case, obviously, CBCT helps you to identify which side you are going to penetrate, and to take the root root resection or remove the root. In that area, you can place the template, and short drill or cortical trophine can be applied it to mark the cortical bone. Can be used for repeated reorientation. You can remove it, and obviously you can place it again in the same place to do the surgical procedure. Because sometimes the navigation is little difficult with this kind of guide, but still it helps you to remove the root, exactly the particular palatal root or mesial root, or this will really help you. So this is an image you can see right here. You can place this guide, put the trophine, put the resection area. So once you have find out the exact area, then you can remove the guide and complete the surgery manually. So this is called pilot guide. So with the pilot drill, you can initiate the surgery. The rest of the things you can do without the template itself. This is a full guide for a bone trephination. So you can take the bone from the particular area wherever you want to take the harvest bone. See, full guide for a bone trephination. So right after the penetration, removing the bone at the apex with the periotome, locating the root canals. Even retro preparation with the piezoelectrical instruments also can be done with this help. So this image will give you the complete collaboration. So first you are taking, first step is CBCT acquisition. Then you are doing data analysis. You can identify the calcification extent. One second. Yes. You can identify the calcification extent, canal path, an ideal entry point, angulation and depth. Then plan the guide path. Then you can do the surgical guide designation. Then 3D printing with the guide. The resin should be biocompatible resin. You cannot do the regular resins. It should be FDA approved biocompatible resin. And stabilize the guide in the mouth using the stable reference. Then you can use the short or long shank burr through the sleeve to reach the plant depth. Right? This is how it appears. So it minimizes the tooth structure removal, high precision accuracy, and it reduces the risk of the perforation and ledging. Better visualization and control can be happened with this guided endo guide system, and it improves the treatment outcomes, mainly for the calcified canals. Sorry. Yes. This is one of the case. You can see the patient came with the repeated or consistent pain over the lateral incisors. So this is how we have taken the CBCT and identified the calcified canals. See here. You can do the digital casting and tooth segmentation We have placed virtually we have planned the virtually access path and guide preview and surgical guide placed with a metal sleeve of 1 mm. This is a guide drill can be used. So here the same concept whatever I have already discussed here. And finally 6 months follow-up shows asymptomatic and normal periapical healing. Okay, so that concludes our presentation today. Thank you so much for joining. If you have any questions, it's open.
Thank you so much, ma'am.
Yes, doctor, once again.
Participants, if we have any questions or queries, you may please ask in the chat box.
Someone have asked how to learn to read CBCT, any course or something. Yes, doctor. We are regularly conducting CBCT course, especially for reading endodontics related thing, because implant reading is it's easy. Endodontics is quite tough because we have to see slice by slice, and as I said, C-shaped canals and J-shaped lines and perforations. Really difficult. You must attend course. Maybe in Chennai we are conducting CBCT, and everywhere you can see endodontic CBCT reading course. Maybe you can contact. I'll share number. CBCT best suited for surgical endo treatments, ma'am. Yes, that is what I meant. You are asking about surgical endo treatment. Yeah, that is what endo guide, right? So whenever you are seeing complicated cases, if you are seeing repeated failure, okay, in IOPA shows a complete perfect obturation, everything is fine, no PDL space widening, no periapical swelling, nothing. In that case, patient keep on coming with the pain. In that case, obviously CBCT helps you to identify what is the hidden pathology is there inside the canal. Sometimes MP2, sometimes perforation, sometimes minimal fracture line. So all those things can identify with the CBCT. It will help you really for those kind of cases. Online courses also available. Maybe you can contact me, Dr. Deva16@gmail.com. I'll suggest you better online courses for endodontics. How to interpret, how to systematically read the CBCT, right?
I think so. That's all, ma'am. Thank you so much.
Thank you. Thank
It
you so much.
was such a wonderful lecture.
Thank
They
you.
have all understood.
Hope you all understood the basic concepts, because it's a big area, huge area that you cannot cover within 1 hour. But I have given the glimpse of the how CBCT helps, how the guide helps.
Yes, ma'am.
Thank you, CynoDent, for giving me this opportunity. Um, I really appreciate Madam and other colleagues for organizing this, and especially on Sundays. I am glad the students also have been participated. Mine is Dr. DRDIVA16@gmail.com. Maybe I can. Shall I
Thank you,
send the
ma'am.
mail?
Yes, ma'am. You can write the mail ID in the chat box.
Yes. Yes. Whatever the doubts related to CBCT in endodontics, you can ask me anytime. I'll help you to identify a hidden pathologies what we cannot see in the naked eye or 2D images. Okay, thank you. Thank you so much. Anything else? Any doubts? No. Okay.
Thank you so much, ma'am.
Thank you.
Moving on to our next lecture of the day. We have Dr. Dhanashri Dalal ma'am with us. She's Associate Professor in Department of Pediatric and Preventive Dentistry at D.Y. Patil Dental College and Hospital. Ma'am will be sharing her insights about Apexification versus Apexogenesis, long-term outcomes and clinical decisions. Ma'am, we welcome you.
Am I audible?
Yes, ma'am, you are audible.
Great. Thank you. Thank you so much for inviting me. And we'll start with the session, sir.
Yes, ma'am, you can share your screen.
Yeah, just give me a moment. Is it visible now?
Oh, ma'am, your screen is not visible. Your video is
Oh,
visible only.
just a moment.
Sharing your video screen, I think so.
Hmm. Give me a minute.
Yeah, sure, ma'am. It's visible now, ma'am.
I'll just start
Yeah.
with that.
Yes, ma'am, we can start.
Sorry for the delay. And
Ma'am, actually, it's in the presenter view. We need the slideshow view.
just a minute, sir.
Yeah. Yes, ma'am, this is good. This is fine.
Yeah. So, very good afternoon to one and all. And I can see the Endo Summit being wonderfully taken and organized very nicely. I would like to thank Ashish sir and Anmol ma'am and the organizing team for inviting me on this summit. Uh, Starting with what is here, as of now, we'll be talking about apexogenesis versus apexification. What are the long-term outcomes and how our clinical decision can impact on the evidence-based research, or in other words to say how our clinical decision would impact the future of the potential tooth that has been hampered. So what we'll be learning under this is we'll try to understand root development in immature permanent teeth, differentiate between apexogenesis from apexification, know indications and contraindications, understand biological principles on what level, how they differ, and what are the scenario that takes place when we are actually treating a particular immature permanent tooth. Compare the treatment materials since there are advances right from calcium hydroxide to biodentine. We'll be talking about all of that. Evaluate any kind of long-term outcomes and apply any evidence-based clinical decision trees. Okay, so to start with, if you see the case scenario 1 and case scenario 2, both are actually similar. Um, this is just for our understanding. So the similarity here is that the patient is a 9 years old patient uh, and has reported with pain with respect to 3-6. Now the key differences here is on the history. Let's go to case scenario 1 first. So here the pain is sharp shooting in nature with a sudden onset, intermittent in duration. Pain occurs only on having food or on mastication. Now this thing is very important here. It aggravates only on having any kind of sweet food and is relieved immediately once the patient gargles or cleans the oral cavity. Now, what idea is this history giving us? So basically, to understand apexogenesis and apexification, it's very important that you understand that the diagnosis, the clinical diagnosis based on the symptoms of the patient is very, very important here. So in this case, what we get to know or what we get to understand that it is a kind of a reversible pulpitis case that can be seen in case scenario 1. Now let's go to case scenario 2. Again, same patient, 9 years old. The same case, same scenario, 9 years old with pain with respect to 3-6. But the difference here is the pain is throbbing in nature. It increases gradually throughout the day. It is continuous in duration. Patient gives a history of spontaneous pain. It aggravates on having food and gets relieved only on taking medication. Here it is clearly giving us an idea that it's a case of a symptomatic irreversible pulpitis. Now, if in short, if I could tell you the crux of the whole presentation, apexogenesis we can do in reversible cases where we know the pulp is actually vital. And in case scenario 2, where we are very confident that the case is somewhat symptomatic irreversible pulpitis, here the other treatment modalities such as apexification or any non-vital pulp therapy comes into the picture. Right now, just understanding this concept is very important. So the whole point in taking these two case scenarios are that patient, whenever enters your dental clinic, it is very important that you hear the history of the patient. The history of the patient, especially in endodontic therapy, gives you a lot picture before you go to your investigation procedure or before any other thing. If you just hear the symptoms of the patient, it gives us a clear idea what is the case and what treatment modalities we need to go to. So these are the two case scenarios that gives us clear indication that it is very important that we take symptoms of the patient into picture, which generally sometimes we tend to avoid and directly go to the x-ray. So we need to be taking the case history of the patient to understand what diagnosis we need to come through, to understand what treatment modalities are there. So in this case, scenario 1, it is vital pulp therapies that we need to go to. It could be IPC, indirect pulp capping, direct pulp capping, partial or complete pulpotomy. And in case scenario 2, it could be root canal therapy or regenerative endodontics or apexification as well. Okay, now why apexogenesis and apexification has been given a certain importance is because this kind of treatment, it takes place in immature permanent teeth. That is the problem. And why immature permanent teeth is a unique challenge. First of all, whenever a tooth is developing, there are thin dentinal walls. Okay, so less dentin thickness makes the tooth weaker and then it would be more prone to fracture. The other thing is short roots. It is yet to be developed completely. So short roots, that gives reduced surface area for support. The third thing is open apex. Blunderbuss apices, wide apical opening communicates with periapical tissues, which compromises the whole seal. Okay, and then if you add the combination of all of these three, that is thin dentinal wall, short roots, open apex, it results in risk of increased vertical fracture. So it is very important that in such cases, if it's an immature permanent tooth which present with such challenges, if it gets inflamed or if it gets infected, the challenge for a practitioner becomes on how we can preserve the development of the root overall. So here, what is extreme important is preserving vitality and continuing the root formation that would lead to stronger teeth, better long-term prognosis, and reduced risk of failure. So here, at the end of the story, I would try to maintain the pulp vitality. That goes one. Promote continued root development to achieve apical closure. I need to close, we have a big challenge of apical closure, increased root length, and thickening of dentinal walls. If all of these three, four factors are taken into consideration, the prognosis of the tooth is good, and then we can actually say that it is a very successful case of apexogenesis. Or the other treatment aspects also. We'll come across that. Okay, so management of immature permanent teeth, like we said, can be divided. Like the case scenario one we took was of case of vital pulp, that is reversible pulpitis. Other case scenario, that is case scenario 2, was of irreversible or necrotic pulpitis. So vital pulp results, what treatment therapies we can give? We can give IPC, DPC, partial or complete pulpotomy. Non-vital, if it is closed, it's a no-brainer. It's a root canal therapy. But if it is open effects, we have treatments such as apexification and regenerative endodontic therapy or procedures. So this has to be taken well into the mind. First of all, whenever an immature permanent tooth comes to you and it is inflamed or infected, first of all, you need to take the history of the patient. That is very important. History will give you some idea whether the tooth is reversible or irreversible. Investigations will let you know whether the tooth has the inflammation of the pulp is restricted to coronal or it has gone to radicular pulp as well. And the third thing is vitality. Vitality, if it's vital, yes, then we have vital pulp therapy procedures. If no, then root canal therapy with closed apex, apexification or regenerative endodontic therapy, depending upon the case evaluation. So it's based individually. We'll be learning about the vital and the non-vital pulp therapies. Okay, before we go towards that, biological basis of the tooth is very important, because at the end it is sometimes you tell the patient that I have tried saving the tooth, but it depends on how it is being healed. Is it by primary intention or secondary intention, and outcome basis? So this all is dependent upon your biological status of the pulp. For example, in case of apexogenesis, we see, like I said, apexogenesis, vital pulp. There is nothing else that should come to your mind. Vital pulp, you will go to the apexogenesis therapy. So vital pulp remains alive and healthy. Stem cells survive. Okay, so stem cells survive as in SCAP. That is pulpal stem cells in the apical papilla and pulp tissue. They remain viable. Just because they remain viable, odontoblasts, that is the tissue forming cells, continue functioning. They continue to deposit dentin along the root walls, making the dentinal walls thicker, which will actually aid in support to the overall tooth structure, and the root development continues. So what we all obtain here, we obtain the root length, dentinal walls thicken, and apex closes naturally. That is, we are trying to somehow allow the tooth to grow and strengthen. Okay, and outcome here would be physiological root maturation with natural apex closure. Okay, now we go towards apexification. What happens in cases, what biologically status of the pulp differs in these cases, which we need to know. The first thing is necrotic pulp. Pulp is non-vital due to infection or trauma, could be anything. Now, because of that, there is stem cells that are lost, loss of vital pulp and apical papilla stem cells. Then a barrier is induced, that we learn that we create a barrier, we try to give a apical closure to the tooth. A hard tissue barrier is induced at the open apex. No significant root maturation. So here it does not increase the root length, does not thicken the dentinal walls. But here we are actually optionless. For example, we give the artificial apical barrier, but the moral of the story here would be, even if we give artificial apical barrier, there won't be any kind of root development, there won't be any kind of root lengthening, there won't be dentinal wall thickness, and the apex, it won't be closing naturally as we are giving the artificial apical barrier. Okay. Okay. Coming in short, what is apexogenesis? I just thought to add 2-3 basic slides just to understand the concept here. So apexogenesis is a term used to describe the continued physiologic development and formation of the root apex. So generally what happens, whenever a tooth erupts into the oral cavity, it takes almost 3 years for the root formation, for the complete apical closure of the root. Okay, so and in between this process, if the tooth gets decayed, if the tooth gets infected, then we have to go to these therapies, that is the apexogenesis or apexification. Okay, so formation of the apex in vital young permanent tooth can be accomplished by implementing the appropriate vital pulp therapy. Now we go towards the tree. Now vital pulp is inflamed. We are going to some procedure called as apexogenesis. Now in this apexogenesis, as we saw in the diagram before, there are 3 columns. Okay, so there are 3 columns. Before we go towards the therapies, I'll just complete the indications where apexogenesis can be done and contraindications. So indicated in vital immature permanent tooth, as we discussed, reversible pulpitis, yes. Traumatic pulp exposure, mechanical pulp exposure, open apex with incomplete root formation. Hemostasis achieved after pulp amputation, very important point. Even the color of the blood is also taken into consideration. Significance of tooth color will matter, whether the case is whether the pulp is inflamed acutely or chronically. Adequate coronal seal can be established. So the success of apexogenesis depends on preserving a healthy vital tooth and inducing physiological root development and apical closure. Contraindicated, exactly the contraindications where necrotic pulp won't be allowed, irreversible, no. Periapical pathology, big no. The inflammation has to be to the extent of coronal and not radicular pulp at all. Okay, this is the basic of whole. Still, I'll just read out once. Persistent uncontrolled pulpal bleeding, no. Extensive internal or external root resorption, non-restorable tooth, and inability to achieve adequate isolation. So these are basic indications and contraindications of apexogenesis we need to remember. More than contraindications, if your indications you're very clear with that the inflammation has not reached the radicular pulp and the tooth is vital, we can go for apexogenesis anytime. So in this, what are the therapies we need to go to is first IPC, indirect pulp capping. Now in IPC, what happens is that now here the concept of infected dentin and affected dentin comes into the picture. Affected dentin is something you will be keeping and removing the infected dentin. Now here many practitioners, what they do, this is just a hack which I would like to share, that they keep the affected dentin on the walls also. It is not required. You can remove the affected dentin on the walls. It has to be only on the floor, the affected dentin, because because it is close to the pulp. So you need to keep the affected dentin. Okay, and now here if the case is caries involving enamel, dentin, and approaching pulp, what you can do is you can just keep the affected dentin at the floor, and on top of that you can put a suitable medicament. It could be calcium hydroxide. It could be, we'll be learning about materials as well. But what are the materials we put in IPC cases? We'll be putting calcium hydroxide, the very old material, followed by MTA, or you can put MTA as well, biodentin as well, and there is a new material in the market, Theracal PT or Theracal LC. It's a light cured tricalcium silicate cement. Now the liner kind of cement. The best part about this is whenever you're putting MTA on the affected dentin, which is restricted to the coronal pulp, you need to put a layer of GIC in between, and on top of that composite restoration, as we usually do. Now the layer of GIC is required because MTA does not bond to the composite restoration completely. So this could become a hassle. So for this, there is Theracal that has been introduced. So Theracal bonds with composite directly, and because of this, you can skip the mid part, skip the GIC part, and directly put Theracal on the affected dentin, and on top of that, you can put the composite restoration. It has given very good results in cases of apexogenesis, in cases of mature teeth as well. I mean, not just apexogenesis, even in normal IPC cases where the tooth development is complete, it has given wonderful results. Okay, so here outcome would be pulp remains vital, continued root development. Okay, The other one is DPC. What is DPC? Direct pulp capping. It is a pinpoint exposure manually or because of caries exposure. If the isolation has been maintained very properly, similar to what we saw in IPC, we will be giving a layer of calcium hydroxide or MTA or biodentine, and again the same process. The only thing that is different from indirect to direct is here there is minimal or pinpoint pulp exposure, and that is seen. Okay, here the outcome is again, once that has been taken care of, pulp remains vital, there is continued. So everywhere here the pulp is vital. Vitality of the pulp is very important for the success of apexogenesis procedure. Okay, the third we come towards is the pulpotomy. Pulpotomy, it could be partial or complete partial Schweck's pulpotomy. The coronal portion of the pulp is removed and the remaining, so basically even the definition says amputation of the coronal pulp, and the remaining radicular pulp is covered with a biocompatible material. And basically here for pulpotomy, as I said, vitality for apexogenesis, overall vitality of the pulp is important. Also, the caries should be involving enamel, dentin, and approaching pulp. That's how it will lead to the success of all these vital pulp therapies. Okay. So this is one case that we have that I liked how the success of the case has been done. Now this is done apexogenesis of an immature permanent molar with irreversible pulpitis using MTA pulpotomy. It has been taken. So periapical radiograph. So in the figure 1, you will be able to appreciate that caries lesion is extending to the pulp in young permanent molar. Now there is Schweck's classification. This is stage 4. So they have stages of root development. This is stage 4 root development. Again, they performed pulpotomy. That is, they removed the coronal pulp. They put MTA, they put GIC, they put composite on top of that, and gave a stainless steel crown. And after that, after 12 months follow-up, there was continued root development. That means the case was going successful. That is Schweck's stage 5. And after that, after 6 months more, that is 18-month radiograph, there was stainless steel crown that was given that showed complete root development. So this is very beautiful case that has been shown. That has been shown for apexogenesis because the case was right. Because everything, if you, I hope you are able to appreciate how beautifully the dentinal wall thickness has been maintained. The length of the root has been maintained, and the third figure that the last figure that shows the apical closure of the tooth and the success of the whole treatment. So this is one of the beautiful case I found by Muhammad et al. Coming to apexification. Apexification is root end closure. So just again to differentiate between apexogenesis and apexification, we try that the tooth development occurs naturally in case of apexogenesis that has been observed. Okay, so here so in apexogenesis we induce certain medicaments so that there is natural root development occurring. Cut to apexification, it's defined as a method to induce a calcified barrier in the root with an open apex or the continued apical development of an incomplete root. So here we introduce artificial apical barrier, okay, at the root end, allowing for so that we can have a good obturation and long-term retention of the tooth. Here it is cut off at the in layman terms, if to tell it. In apexogenesis, we are trying to kind of motivate the tooth, with the certain materials to have a apical closure, to have good certain a good length and good dentinal thickness, whereas cut to apexification, till where the tooth has been formed already, we induce artificial apical barrier so that we can do obturation and retention of the tooth because it is already a non-vital tooth. So here the disadvantages, we cannot say it as a disadvantage because we are optionless here. But here again, like I had told previously also, that the root development is stopped at a certain place, and because of the because we introduced artificial apical barrier. So that's the basic difference between both of them. Indicated for restorable immature tooth with pulp necrosis. Contraindicated in any kind of root fractures, replacement, resorption, very short roots. Okay, the roots have to be like at least one third of the root remaining to develop. We can do apexification, not less than that. Periodontal breakdown, vital pulse, not I mean it's contraindicated. Now the materials which we saw overall here is calcium hydroxide, which we just discussed, MTA, and biodentine. Okay. Going towards how can we do apexification now. So I have compared the materials differently, since there are, so the first thing is we classified a case came to you. You classified it into two things, whether the case with the patient symptoms, what it is showing, with investigation, what it is showing, if it is showing in if it is a case of a vital tooth or it's a case of non-vital tooth. After that, we came to more, series of treatment modalities. If it is vital, it could go to apexogenesis, resulting in other therapies such as IPC, DPC, or pulpotomy. In apexification, we are going to apexification or regenerative endodontic therapies. Now, here comes the role of the materials. Which cases we should be using certain materials, and how it can aid in the prognosis of the tooth in the long term. Now, since we are talking about the non-vital tooth, the materials that we are using is calcium hydroxide, MT, and biodentine. Now, in which cases we should be actually using apexification using calcium hydroxide. So let us go to a case. There is the first visit of the patient. Access cavity is prepared, working length is determined, minimal canal instrumentation, irrigation, everything is done. You dry the canals with paper points. You place calcium hydroxide paste through, like an, intracanal medication. You have to put it, extending close to the radiographic apex, and you seal it with temporary restoration. So for follow-up, recall every 3 months, you replace the calcium hydroxide if required. Monitor radiographically for hard tissue apical barrier formation. Okay. Final visit would be removing the calcium hydroxide. You perform BMP, you obturate, and the same process go as a re-RCT. But the biggest disadvantage here is that the treatment duration is 6 to 24 months. Okay. I will say you can do it it should be avoided in those cases where you are not going to get patients support in the follow-up. It has to be taken in certain follow-up. So if you're not sure the patient will be coming for your every follow-up, you have to avoid this. Or if there is, a very less apical closure that needs to be achieved, you can go for apexification using calcium hydroxide. Okay, the next we come towards is the apexification using MTA. First visit, again, we'll go through the same process. You do access cavity, you determine the working length, canal disinfection, placement of calcium hydroxide, dressing will do. Then you remove the calcium hydroxide and irrigate thoroughly, dry the canal. Here, now the whole process is you have to place MTA apical plug. The one which we were talking of achieving artificial apical barrier, we'll be doing it with the help of MTA. 3 to 5 mm of MTA apical plug is to be placed, condensed gently using pluggers. Verify apical plug radiographically. Place moist cotton pellet, seal with temporary. Now, I won't call it a disadvantage. MTA, we need to wait 24 hours for it to harden, basically. So the setting time, the second visit has to be in 24 to 48 hours only. Okay, so you confirm, many of the practitioners, they do it on that day. I would suggest it has to be avoided, because MTA is not set at that period of time. It needs to harden for you to, obturate with GP. Okay, so you see, confirm the MTA set, obturate remaining canal with GP, and then you place definitive coronal restoration. Clinical and radiographic follow-up has to be taken 3-6-12. So here, the treatment duration, we generally do say that it's a one visit apexification, but it's not one. It takes 2 visits, and generally the second visit can be between 24 to 48 hours. Okay, so that is still better than the calcium hydroxide which we discussed. The third thing is apexification using biodentine. Now, biodentine has slightly better advantage as compared. Here, again, we'll just go through the visits. Access cavity preparation is done and working length is determined. Canal debridement and irrigation is done. Calcium hydroxide dressing. You remove dressing and dry canals. Place 4 to 5 mm of biodentine apical plug. Now, see, they say 3 to 5 mm and 4 to 5. It is all dependent on individual case selection. Okay, so it is all dependent on what kind of case you are getting and the apical plug is selected. This is the average. Generally, we will be requiring apical plug in cases of biodentine. So verify placement radiographically, allow biodentine to set. Here, the biodentine sets between 12 to 15 minutes. So you can ask the patient to wait there and then get, obturate it on the same visit, or it depends on you. Second visit also can be taken. So you obturate remaining canal with GP. Place permanent coronal restoration. Now, in immature cases, stainless steel crown is the best material that can, best semi-permanent restoration that can be given to these cases. Okay, so the treatment duration here would be single visit or 2 visits, depending upon the patient's comfort. So again, summarizing, this was a huge slide. Summarizing in short, you are getting patient good compliance. The patient is not paying much, is ready to come. And in those cases, you can go for calcium and depending upon the individual tooth also. If not much apical closure needs to be obtained, you can go for calcium hydroxide best. If the patient, you are confident that the patient won't be coming multiple times, or that you can go for MTA or biodentine, whichever material. The radiographic success and the clinical success of biodentine is slightly they say statistically insignificant. So you can use both the materials. They are beautiful. And MTA needs to be completed. Apexification with MTA needs to be completed in 2 visits. That's compulsory. That is what my clinical judgment also tells me, that it's not a one day procedure. It has to be taken twice. There has to be 2 appointments. Biodentine can be completed in 1 appointment, depends on the patient's comfort, as I said. Okay, so I just discussed in previously. Again, we need to consider what factors we need to consider before I choose any kind of material. The first thing is periapical status. Calcium hydroxide effective in vital or infected cases with proper dressing. MTA effective in vital or infected cases. And biodentine effective in vital or infected cases after disinfection. So both they are good in those cases. So what happens in case there are infected cases also, if you would have observed, we have given calcium hydroxide as an intracanal medicament even in case of MTA and this thing. So treatment time here, it's long, 6 to 20. The one which we discussed, the basic advantage of biodentine is that it can be completed in a single visit. MTA, 2 visits, 1 to 2 I have mentioned, but 2 visits is what I recommend. And calcium hydroxide 6 to 24 months till the apical closure has been obtained. Number of visits, like calcium hydroxide multiple, MTA 2, and biodentine 1 visit more than enough. Disinfection ability because of alkaline pH, excellent antimicrobial effect of calcium hydroxide. MTA good sealing ability, and the same for biodentine. Seal and hard tissue formation, forms hard tissue barrier, slowly induces hard tissue. So here it's low in cases of calcium hydroxide. MTA okay. Biodentine best, that it promotes rapid hard tissue formation. Okay. Cost wise, it's low in calcium hydroxide, high cost for MTA. And moderate less than MTA biodentine. So biodentine is available in form of capsules. Generally 5 capsules you get in around 5,800. So it's a good deal. Clinically suitable when long-term follow-up is possible. Like I said, if the patient is ready to come and you have got a very good patient compliance, please go for calcium hydroxide. MTA preferred when faster results are needed and follow-up is difficult. Biodentine the same, ideal for faster therapy. operators preference and experience, so preferred for conventional approach. So here what I've found that I mean many practitioners use calcium hydroxide because so it has to be this is a bit off topic, it has to a bit off topic I'll be talking, that patient has to be explained very thoroughly that apexogenesis and apexification is not like a root canal therapy. So generally I do not know the prices outside, but we charge more than root canal therapy for apexogenesis and not apexogenesis. I'll be sticking to apexification. We charge a good amount for apexification because MTA, because biodentine, because even if you're using calcium hydroxide, there are multiple appointments and we need to. So you have to actually explain the patient about the immature permanent tooth. Okay, what are the challenges that we face and what are we actually doing and how it is difficult. So the charges has to be better than your root canal therapy, and that has to be communicated, because you can say we are at the end doing root canal therapy, but there are 1 or 2 steps extra to achieve the apical closure which we take. Okay, so here moral of the story: if time and compliance allow calcium hydroxide, if you need proven seal and reliable results, MTA, faster treatment, biodentine. So MTA, biodentine, they both go hand in hand. So you can use any of them for this. Okay, so this is one case where if you would be able to appreciate, and there is trauma to the maxillary central incisor, a bit of discoloration can be observed that gives me an indication that it could be a non-vital case only by seeing the tooth. Okay, then once the x-ray is taken, tooth is isolated with rubber dam. Now this has been done in my department, and so here the determination of working length has we need to take. Now, if you would be able to appreciate here, MTA is placed in the apical third of the canal to form the apical barrier. So this is the case. So this was done in one visit, and after 48 hours, obturation was done with the same tooth. Okay, so this is we do call it one visit apexification, but it is something that should be done. The second visit has to be taken for proper obturation with GP, because MTA sets I mean it takes time to set MTA, cannot be done in the same appointment, but still literature calls it one visit apexification, because the term got popular after calcium hydroxide was there for so long years, giving multiple appointments. Then MTA was bought in the market with a statement of one visit apexification that can be completed immediately or something like that. But my suggestion would be take a second visit and complete the MTA procedure. I mean, complete the apexification procedure. So here the tooth preparation was done for zirconia, and this is the final results that was seen. Okay, now apexification, there are several studies that have been taken place trying to, trying to do with other materials also. So this was a case by Chabra et al., where a successful apexification you will be able to appreciate for the premolar has been done with, they have used MTA and demineralized freeze dried bone allograft that has been used, and it has given good results. The follow-up was done, I guess, after 12 months. There was one more endodontic management of non-vital permanent teeth having immature roots with one-step apexification using MTA apical plug and PRF membrane that was used as an internal matrix. So in this cases, apexification has been proven to be successful. A novel approach for apexification, 2 years follow-up. Now here, what they use as a novel approach was white Portland cement was being used here. Now white Portland cement, the thing, it was not continued further. So first of all, about white Portland cement, it is a good material, but it has not got the dental gradation that has been received for MTA biodentine to be used in the teeth. So a 2-year follow-up was taken, which was good, but just because it did not, so it is economical as compared to MTA and biodentine, but still due to sterilization protocol, or the dental approval, White Portland did not receive. So because of this reason, we do not use it in the market. But since there was a case report, I thought of mentioning by Bansode et al. There is one more man. Now we all saw MTA being done alone or MTA with some or the other materials. Management of non-vital permanent incisor with open apex using apexification using biodentine. Now this was a case for biodentine. Here you would be able to appreciate the preoperative intraoral radiograph. Then placement of biodentine was done with respect to 2-1. Working length determination has been done, and here the obturation with 2-1 has been done. There was no follow-up for this particular case. Okay. Generally we discussed on all the other factors, which material to be used, which material not to be used. So even in the studies, it has been mentioned that the calcium hydroxide therapy, when compared with MTA plug, also, if you would be able to appreciate every et al., where two of calcium hydroxide teeth had become reinfected, but then when they were again treated with MTA plug, remained successful. So there was a study. So there was one case of, I'll just tell you in short, one case of apexification, two cases of two teeth of apexification was done using calcium hydroxide, and they again became reinfected. And then after they had got reinfected, they were again treated with MTA, and then there was 18 to 24 months of follow-up that was taken, and it was still and the apical plug that was given using MTA, that remained successful. So you can say that MTA has got a bit of better. So all in this whole chart, the moral or the to summarize here, if you have got a choice between calcium hydroxide and MTA, you can use MTA, because the radiographic and clinical success of MTA is slightly better than as compared to that of the calcium hydroxide. Okay. So that ends my presentation. These are my references. Thank you. Over to you, sir.
Thank you so much, ma'am.
Yes, sir.
I hope everyone understand the topic. Any of the participants have any doubt, you may please write it in the chat box.
Okay. So, ma'am, protocol for irrigation in open apex. A very good question. So here it's very important that you introduce saline of, okay, so there are certain washes that needs to be taken. Here, the usage of sodium hypochlorite has to be used either very minimally, or kind of drop by drop only. So the first thing is, whenever you open a case, or whenever there is access cavity prepared, whenever working length has been determined, whenever there is working length that has been determined, you start the first wash with saline, or you could use saline and 2.5% of sodium hypochlorite as well. In cases of if there is any kind of periapical pathology that can be appreciated, it's better that the final wash you give is of a chlorhexidine and not hypochlorite. So you can start with a combination of saline and sodium hypo. Then in between saline, and the final wash has to be of chlorhexidine. Okay. Which material is best for apexogenesis treatment, MTA or biodentine? Okay, so before there was gray MTA, white MTA, which of BioAngelis brand. Better than that, there is MTA putty given by Kitsy Dental, which I've mentioned in my material slide also. I found its results better than biodentine. MTA putty. It is hassle free. It is good. So MTA putty, if you're using, between MT and biodentine, if you're using MTA putty, it has better results. But if you're using BioAngelis brand, between both of them, biodentine is supposed to be better. Ma'am, that's what I'm telling. Either you use 2.5% with, so basically what it happens is you need to, there is removal of smear lead that needs to be taken place. Okay. So NaOCl alone cannot do, chlorhexidine alone cannot. We need to remove the smear lead that is on the dentinal walls also. It has to be used very cautiously, or you can go with a combination of saline and chlorhexidine 2%, chlorhexidine gluconate 2% as well. But NaOCl can be used, but as I said, it should not be, even it should not be nearing the radiographic, not radiographic, it should not be nearing the apex. But the best part about using sodium hypochlorite here is that the it will help you in arrest of the bleeding, initial bleeding phase that comes after you have prepared access cavity, or in those cases it would be useful. After that you can go for saline and chlorhexidine 2%. The protocol that has been provided into the literature says that the last wash has to be given of chlorhexidine gluconate 2%.
Any other questions? Anyone? Thank you so much, ma'am, for
Thank
such
you.
wonderful lecture.
Thank you so much.
Moving on to our next lecture, we have Dr. Soumya Parashar ma'am with us. Dr. Soumya is MDS, former assistant professor, associate editor, and fellow of PFA. Ma'am will be sharing insights about the topic calcified canals and blocked orifice, negotiation, bypass, and bioceramic management. We welcome you, ma'am.
Thank you. Just give me 2 minutes. I'm just adjusting just 2 minutes.
Surely, ma'am. Ma'am, I request you to turn on your video so that student can interact with you.
I just need some help with the presenter view. Can someone please help me? Then I can share.
Ma'am, there will be a share option. Then in that share option, you can select to share only the PPT, because right now your video
That is
and
what I
PPT
did.
both are being shared.
No, I need to get off 1 second. Hi, can you please help me with this? I'm not able to do Hi, can everybody see me?
Yes, ma'am, we are good to go.
All right. Good afternoon, everyone. Today's topic is on calcified pulp chambers and orifices and their negotiation, bypass, and biomimetic bioceramic management. So I'm very fascinated with this topic because I've done quite a few studies, a review, a case series, and we've also done a meta-analysis on this topic. So I would really like to thank the organization committee for giving me an opportunity today to present. So moving on to the topic, I'm so sorry, I'm just having a little bit of a glitch. What is a calcified canal? It is nothing but it is the deposition of mineralized tissue within the pulp space, resulting in partial or complete narrowing, which is also known as an obliteration, usually for anterior teeth of the pulp chamber and root canal. So you wouldn't really call it a disease in itself, all right? And true complete obliteration is very, very rare because that can only be determined either histologically or within micro CT studies. And even they have demonstrated that there are still fine residual canals that still persist even when radiographically or in the CBCT they are invisible. So, what is the etiology of calcified canals? All the etiologic factors share a common pathway. That is, in this, the pulp basically gets injured, or there is some irritation that stimulates hard tissue deposition within the pulp space. Now, this could usually be because of aging. So, this is more of a physiological calcification. It could be because of caries or a heavy restoration or a heavy irritation which is chronically present. So it could obliterate or calcify as a defense response. Dental trauma is one of the most common factors which specifically happens in anterior teeth when you see discoloration, and it is getting more common right now. Orthodontic tooth movement is another factor, but it is usually mild only if the force is very high and the movement is very fast that is done, then you usually see it happening. Genetically and developmental disorders are also associated to it. And you can see this in dentinodysplasia like diseases. And there are also systemic conditions. It's rare, but it's definitely related. I had the opportunity of two of my patients who had this Marfan syndrome, and their pulp chambers are completely calcified. And again, with dentine dysplasia, also I saw the same. So it does happen, and I have been fortunate to come across such cases. Coming to the pathophysiology of calcification, again, I repeat, it is not a disease, it's basically a defense mechanism. Initially, you have a trigger, which we already discussed. It could be any of the triggers that could happen, caries, trauma, occlusal wear, etc. And basically, what this causes, it causes a cellular response. And this response will lead to the surviving odontoblasts, they become hyperactive. And at the same time, at a cellular level, even the fibroblasts increase their collagen. All of this leads to an increased mineral deposition. It could be in the form of secondary dentine, tertiary dentine, osteodentine, or a diffuse calcification in the radicular area, or pulp stones mainly in the coronal area. Now, these deposits progressively reduce the size of the pulp chamber, the canal lumen, and the canal orifices. So basically, you don't have your regular dentine map and the anatomical features that could guide you and take you to the orifices, whether in the pulp chamber or in the root canal. So you definitely also see a reduced pulp vascularity, and slowly they do lose their vitality, but it takes a long time. And the pulp basically becomes less vascular, less cellular, and less metabolically active. However, they will still be white. Usually, when it's because of trauma, you will see within 10 to 15 years, it does turn out to be non vital. But if it has happened more because of the other stimulus that are made by us, then it stays a little more vital. And progressively in the radiographs, you will see narrowing of the pulp chamber, the canal, even the anatomy will disappear. It looks like there is no root canal, but most of the times it is, because histologically that's been proved. So to summarize the sequence, basically if there is an insult, there is a cellular response, there's increased mineral content, reduced pulp vascularity, progressive narrowing, and then a pulp stone or calcification in the roots are formed. When we come and talk about the types of calcifications based on the radiograph, you can very clearly see if a distinction between partial and complete based on anterior teeth. Okay, it could be partially or completely obliterated, especially the pulp chambers. When you talk about the pattern of calcification, it could be irregular or a diffused linear pattern, which you usually see in the radicular pulp like it is shown, or it could be like a pulp stone, which is mostly on the coronal portion. Based on histological findings, you also have a true denticle or a false denticle. A true denticle basically resembles the dentine with dentinal tubules, and the false denticles, they have concentric calcifying layers around the central nidus. According to the location, again histologically, you have free, attached, and embedded. And clinically, these are all my cases. Whatever I'll be sharing today are all the cases that I've come across and I've treated. You have a free pulp stone wherein once you open the access, it is not attached to the dentine walls. And attached or partially or fully adherent is the second picture, where it could be either attached and it could be formed at the level of the pulp horns or at the floor. And the last is the embedded type, which is one of the most challenging types because you lose any distinction of the interface between the dentine and the stone. So this is a very common scenario when people actually perforate or they're not able to find the canals and they miss the canals in this scenario. All right. So why calcified canals remain challenging even for experienced clinicians? This is because the canal is not absent. Its pathway is biologically concealed. So this is a very important line. It's biologically concealed. So it's not a disease in itself. All right. So it is challenging. If you see on the left side is what you have a normal pulp chamber. And on the right side is what we will frequently encounter at different levels, right? So obviously here we are missing all the anatomy, the developmental grooves, all the laws of pulp chamber anatomy. There are no clues to how do you get to the orifice and at what level are they, right? So that is one of the reasons the anatomy is obscured. Next reason is if you see the canal lumens compared to the left side, they are really, really tiny. And I could capture this because I work microscopically. So even under Loupes, you might miss the MB2, which is now more towards the palatal in my picture. I hope it is audible and visually clear for all of you.
Yes, ma'am.
All right. So the canal lumen is extremely narrow. So again, there are more chances of missing the anatomy. And when you see radiographically, especially a 2D image does not do justification to the level of how difficult this case is. Sometimes, this is from my experience, the 2D and even the 3D might look like it's absolutely sclerosed, but when you open up and do the treatment under the microscope, you find it otherwise. You can actually see a lot more. So you cannot just rely on radiographs, even CBCT, to find calcified canals or a pulp chamber. So obviously, because of none of the anatomy being very clear, there is more higher chance for a high anatomical variability and to have more iatrogenic errors. Like you can see in this picture, this is one of our cases which we had published. This is when there wasn't any guided endodontics published. So you can see it is more of a lot of radiographs are taken. It takes longer. It's more of guesswork, even if you're working under the microscope. So there are more chances of error. This is another case of mine, which is very interesting, which will be one of my last cases, which I'll be explaining. So here, if you notice, the challenge is not about cleaning the canal. In calcified canals, the biggest challenge is you have to prove that a canal actually exists. All right. And here, because of all of this, in search of this canal that exists, you do a lot of damage at the CEJ level, which you can see at the right side. So this is one of my referred cases. If you can actually appreciate, they have not only gorged the CEJ, which is the white portion, in order to find another canal. They've missed an MB2, and there is actually a separated file towards the left corner here, which has been done by the referring clinician, and he has also perforated. So that is why it is very challenging. So you have to prove that a canal still exists. So when I talk clinically about calcified canals, personally in my clinical practice, I have 3 triads which I cannot work without. Number 1 is CBCT, because I need to understand the anatomy before I begin. I need to anticipate the challenges that I'm going to go in, because sometimes the patient might not want to save such a tooth, even though I would love to take in the most difficult cases and save the case. So it's always good to have a dialogue with the patient. You can show them the CBCT. Sometimes they don't understand what you're saying. So it's very good to plan and discuss with the patient for documenting if the case is referred to you. Probably you haven't perforated, but when you open, you see a perforation. So for those legal matters also. The next is microscope for visualization. I have to see, and that matters a lot. And that gives me a different kind of clarity. And I can preserve the tooth structure with a lot of confidence. And the last is the right armamentarium. There are so many times where you could see the canal, but you're not able to open them because you're still using 6% files, or a thicker explorer. So armamentarium is very important. All right. And also the sequence. So today I'm going to take you through an entire sequence which I rapidly follow for every patient of mine when I have such cases. And it's just drilled in me that this is the first step, second step, third step. So we're going to be going through the same thing. Now, when I talk about clarity between 2D and 3D, we know that 2D only gives you a mesiodistal view. So it's already established in all our minds that we may miss anatomy, and there is a lot of risk of misinterpretation. Sorry. So that is why now I feel there is already AAE statements proving that CBCT is becoming more of a necessity, especially in endodontics, because the anatomy cannot be touched. Even if you are the best endodontist, you really cannot do justice to what the tooth holds. So 3D clarity is without fail one of the most important armamentariums. It not only shows you the angle, radius, and length, it shows you the location of the tooth in total. So when I talk to my patient, this is a very important factor. For those dentists who are a little reluctant in telling their patients, sorry, I don't know what is ringing. 1 minute. For those dentists who are a little hesitant, to get in CBCT in their daily practice, I think today probably I might change your mind regarding CBCT, but for me it is absolutely important. Now, when I talk about CBCT, according to my experience, on the rightmost is a summary of what parameters I like to keep when I am taking a CBCT or limited FOB CBCT for my patients in any type of a complexity. So I want a small FOV, 4x4 or 5x5. Here in Dubai, you actually don't have such a smaller FOV. So we usually do get 6x8 or 8x8. You want a high resolution, you want the KVP to be between 70-90 and the ampere to be between 8 and 20. And few of the machines have something known as MAR, which is metal artifact reduction, which is very helpful when you're trying to get a pre-op CBCT when you have a crown and you have a post. So a lot of times there is a lot of artifact that makes you think that there is a canal or there's a crack or there is caries there, but it isn't. So this is another good feature. So you need to know your CBCT. You need to know all your armamentariums very well in order to put them to good use when you're dealing with such cases. So CBCT has a lot of clinical benefits. You can see missed canals, you can see deep splits, which are sclerosed, which otherwise you wouldn't see, fractures, perforations, resorptions, the extent of a resorption, broken files, exactly where are they situated, the thickness of the dentine around it, obliteration, which is the most important in today's presentation. So the takeaway message is 2Ds just have an inherent limitation, and low FOV CBCTs provides an accurate 3D assessment. And if you're worried about radiation or your patient does ask you regarding that, if they take a flight once in 3 or 6 months, it is literally the same or even lesser than getting a CBCT, a limited FOV CBCT. Coming to talking about CBCTs. Sorry. By simply having a CBCT is not enough. The real value is when you are able to know and how to interpret your CBCTs. At the later part of my presentation, I will be discussing my cases, and in most of them, you will see that I did not see a definite canal in my CBCT. But the anatomy around it is what I paid more attention to know that there is something else going on. So you could have an extra canal, or you could definitely have a canal in that tooth. So that is what you need to ace as a dentist when it comes to calcifications and interpreting them in a CBCT. So every calcified canal is not equally calcified, or it's not equally difficult, and the CBCT allows us to grade that difficulty level, so we know exactly what we are dealing with. So there was an article that is published in 2019 in IEJ, wherein they used CBCT and they assessed the calcification, the level of difficulty, and it also gave us a way of how dentists would communicate if they had a CBCT, and I had to tell you at what level is the calcification, is there a periapical lesion or not. So this is just about that. They basically divided the diagnosis into 3 parts, which is on the leftmost corner. They check the coronal to apical level at which the canal is evident radiographically in the CBCT. Okay. The second is they check the length of the patency of that existing canal in millimeters. And the last is they check the apical patency. Was the canal patent or was it not patent? So these 3 factors is how they communicated, and they judged the level of difficulty. So if you see grade 1, you can see that the canal is visible throughout entire length. So the case difficulty is quite easy. So you'll do your standard RCT protocol under the microscope instrumentation, everything's good. Grade 2 is moderate calcification. This is where you can partially see the canal, or there is a discontinuity, mainly in the middle third, and you are able to interpret where exactly the canals are. So this is a moderate level. Over here, if you use the techniques that we will be discussing later, it should be quite an okay case. Now comes in grade 3, which is severe calcification. You cannot see, or you can very minimally see the canal, and in majority of the root, it is not available. It's not clear. So there's no clear lumen to begin with. So here it becomes a little difficult, wherein here you would need an advanced technique. You would need ultrasonic troughing, CBCT-guided approach also, static that is, and the other principles of minimum invasive endodontics and BRAT technique and all of that, because it has a higher chance of perforation. Grade 4 is where nothing is visible. This usually happens in anterior teeth where you see a full obliteration and you will see a radiolucency at the end. Or in MB2s, most of the times in MB2s is what I have noticed. So this level is the highest level of difficulty, where there is no radiograph helping you, no clinical variations to help you. And here you have to consider guided endodontics. It becomes mandatory for you to take up guided endodontics, or you do a surgical approach on this type of a variant. So I'll give you an example of how they had graded. So the first is the level at which the canal is present. If you see the picture, is it in the coronal, middle, or apical? So you can see that you can see a faint canal that's present in the middle. So it's M. Then the length. So when you measured it in your CBCT, it was 16 mm, and the apex was patent. So this is how they had classified it. So the main key point to understand is higher the level of apical calcification and the shorter the patency, or you can see the canal, and if it is a non-patent apex, that is the highest level of difficulty in a calcification. And from this you have to understand, I'm again repeating, that even though the canal is not visible, the canal does not mean that the canal is absent. So absence on a radiograph or a CBCT is just a limitation of that armamentarium. That doesn't mean that the canal is absent. All right. Now, before we begin to my next part, I would just probably do a little bit of an interaction with the audience, if I may. What can we appreciate from this picture? Can we see anything, even if you all are close to your screen? So most of us are still guessing. We are not able to appreciate what I am displaying. What about this? How about now? This is 10x. So this is 25x of what I'm seeing under the microscope, right? So this was just a slide to explain how even loupes are not sufficient now or forever. It was always there. And the microscope is becoming more and more an essential armamentarium, especially when you're dealing with calcified canals and complex cases. So here you can clearly see a separated DB orifice. You can see the mesiocervical furcation that has happened, which you couldn't appreciate. That's the missed MB2. That's the separated file in the orifice. So here I would like to say that the pathology was always there. The magnification simply revealed it. So that is why modern endodontics cannot do with just your naked eye. So these are all my cases, complicated cases that I have dealt with. And I really truly believe that you cannot treat what you cannot see. And visibility in dealing with calcified cases changes everything. And it is not just me, these are proven by systematic reviews, by AE statements. And they have said that you have a higher chance of success in your cases when you do use and do cases under the microscope. This is how well we can appreciate everything. Now, the microscope tells us where, and the armamentarium tells us how, right? And let's look at the essential armamentarium for safe access into the calcified pulp chambers and to find those hidden orifices. Again, before starting, we have our pre-op assessment with the CBCT and our IOPA. In this I'm just going to be giving one case as an example, and I'll take you all along how do I deal with a calcified case that I've got. Now in this is the 2D. It's not telling me too much. The first thing I do is I will take a limited FOV CBCT once I see that my IOPA is a little obscured. So in this, you can clearly first measure your occlusal reference point to the furcation. That is your first point where you want to know, okay, this is my limit. And the next important reference is from the occlusal reference, which should always be reproducible to the floor. Rest from your CBCT, you will understand at what level is your roof, at what level is your floor, and what level is your furcation. And because there is a calcification, we know that everything narrows down. So you will also measure the level from the floor to the roof, which is very important. And that's how now, before you begin, you know your boundaries, you know all your measurements. So you're going to have your explorer or your burr. I like to place a stopper and I keep checking it in between. So that's for someone who's undergrads, this is a very good point. The second is your access. Now you'll notice in my access, I have long shank round burr, I have the Endo Z burr, I have the Mueller burr, the Munz Discovery burr, and the front surface mirror. Now all these burrs have one thing in common, that their neck is very long. And if you see the picture below, it is able to very clearly show you that when you use your normal burrs, everything is hidden. You cannot see anything, even if you are working under the microscope. So that is where, number one, you need to see where you are troughing. What are you troughing? You're going to see the color change. You want to see your orientation, right? So for that, you will always try to look and get this armamentarium of long shank burrs. And the Mueller and the Munz burr, they are basically carbide burrs, but they have a very small head. Okay. So you can really see, and you don't cut a lot. You cut even lesser than ultrasonics, except for the ET, but you do cut lesser. When I come to the mirrors, you cannot use normal mirrors because you get a lot of reflection. So you see double images. So I don't remember the last time when I did use a normal mirror, even for a normal diagnosis. So front surface mirrors are very, very important, which are highly basically you are able to see much clearly because you don't get a reflection. And I like this brand from Cart. They're really good. It makes my tooth look very bright under indirect vision. Okay, so all of this, basically the purpose of this armamentarium is you have a conservative penetration into the pulpal orifice. You can unroof the pulpal flow, and you have smooth chamber walls. So basically these are only to unroof the pulp chamber. That's it. Once you've reached the roof, you stop. You get away from this armamentarium. So that is number one. So this is the same thing. I have preoperatively measured, and you can see the calcification. I've taken my long shank burr. I can easily see where I'm drilling, even though there is water, and my assistant keeps air drying the tooth for me. Now I can identify a calcified mass in the center and a chamber parameters. Then I'll keep drying and I'm checking for a darker color of the floor. Okay. And you can easily distinguish that from the walls of the tooth. So that is one thing that is a telltale sign when it starts, when the floor gets darker, right? So you stop at this point. This is when you have reached the roof. So now I'm at the roof. The next armamentarium is my ultrasonics, which is the most important. I usually shuffle between ET18D, ETBD, and ET20, and each of them have their own speciality. The 1880D is a diamond burr, so it helps me cut the walls very precisely, and I don't cut down, so it doesn't cut my floor. I have that much, I can just cut my walls around laterally. The BD is once I have punched into my pulpal stone, it's very easy for me to only now remove that roof or that stone, and I don't cut anything laterally. So they both have an opposite thing. The 18D is for lateral and the BD is for pulpal, okay, or the floor. ET20 is basically when you're trying to remove an isthmus calcification, or you very specifically want to remove something very narrow, which is adhered to the chamber flow. So the purpose of ultrasonics is basically to remove calcification and trough the developmental grooves and preserve anatomy. Now, below is your third important armamentarium, which is the microsuction. Why? Because every time I'm working, I want, number one, the debris to be removed, and I want to see my pulpal chamber. And there are very easy ways of making a microsuction. This is one of the DIYs that I have put up. It is very, very easy. You can look up on YouTube, on Instagram. You can easily just put a DIY and you get a lot of videos. So this is just one of them, how you make an endo aspirator, which is very, very important when you're dealing with a calcified pulp chamber. Now, when you have reached the roof, you are now looking for a good starting location where your ultrasonic is going to basically drill in order to reveal the interface between the floor, okay, and the lateral wall. So if I want to tell you about the good starting points, in maxillary molars, always aim for the biggest canal, that is the palatal. Once you've hit the palatal, you kind of understand where you are, even though you don't have developmental grooves or any anatomy. In mandibular molars, aim for the distal canal region. In premolars, use your buccolingual and keep going in the center. And for anterior teeth, it is always the long axis of the root, not the crown, because the crown can be rotated. So you will go along the long axis, and you need to be very careful of label perforations. So now this is the next step. You can see we identify the safe starting spot. This is the upper 2-7, so I'm identifying the palatal. And then when I switch and I get the area where it is distinguishing, I peripherally trough. This is known as a moat technique. I'm trying to create a shallow circumferential groove at this junction between the stone and my pulpal chamber wall. The next is the micro explorers. Now, once you have removed and you've got a moat and you have a groove, you're never going back to burrs now. Now you're only going to be dealing with needle-like, very narrow armamentarium. So you have DG16. Now DG16s are also of different types. There is a normal one which is as thick as an explorer, and there's another one which is thinner. Okay. So you always get the one that is thinner because calcified orifices are very, very thin. So if you have a big explorer, you're never going to get the catch. So you will feel, I didn't get the catch. Oh, so the canal is not there. So you need very fine instruments now at this level as you're going deeper into the calcification. And there are something known as micro explorers. Basically, you can just take any of your files, your K files. I like to take the 10, 15. You place it in this handle and you're able to bend it. So exactly how your ultrasonics is, you get the same level of dexterity, so you can see. Because if you go in with your files with your hand completely covers the area. So again, you've lost your visibility. And this is even though you are working under the microscope. So that is why you can nicely feel the catch of the orifices, and you can confirm the orifice locations. So this is exactly what I'm showing you. The palatal shallow circumferential groove is explored. You can see a little bit of a bleeding point there. Now I'm aiming for the MB since I understood where my palatal is. And then I'm aiming for my DB. So I've got a catch even though I had no orifice exposed. Now I'm going to cut in a controlled moat around this calcification. I know my boundaries only laterally in order to try to get the exit or the last interface where my calcification is meeting my lateral floors or my lateral walls. Now comes in the micro instrument, which is my micro spoon excavator, the smallest one, because my axis is extremely small. So I need all the armamentarium to be microscopic level, right? So in this, the main purpose of my spoon excavator is now to remove this calcification or try to separate it from that interface or that groove that I have made. Okay, so there's a controlled removal of the adherent pulp stone. So I'm first testing, is it moving? And barely a little bit came out. So I continue taking my ultrasonics. I'm trying to join this color change that you can see. I can see a very chalky translucent area. And now this is the stone that is attached to the palatal canal. So once I removed everything, this is what I had. All right, you can clearly see a bleeding point of the distobuccal. This is the distobuccal. We are seeing an MB2 here, which later we'll see if it was really an MB2 or what was it. That's the MB and that's your palate. Now, the next most important thing is you've got visualization and you have reached at this level. But now every time you're not going to get the same type of stone in every patient, right? It is different. So in this scenario, this is a nice guide to tell you that when you are encountering different types of pulp stones, how are you going to deal with it? All of them do not come out at the same in the same manner. So if you have a mobile stone, okay, and there is a clear interface, you can see very clearly in the case. The main thing your approach is going to be, you will progressively release it more and you'll remove it with the spoon excavator. If it is partly fused, okay, wherein it is sometimes partly only fused to the floor and a little bit on the lateral walls, then your approach is you will section this without touching the floor. At any point you are not touching the floor. Every time if you're cutting either at the interface here or you're cutting laterally or you're just thinning this out. But you never apply force because you can easily perforate. So when it is partly fused, you're going to section it and remove it. When it is completely fused or you're not seeing any clear interface, like the case that we were discussing, first I kind of thinned it out at the end. And then when I saw that it was just a bridge that was there, then I removed it with my Explorer. Okay. Again, so I internally thinned it and reduced it and then I could take it out. The last is the most difficult type, that is it is continuous with denti. All right. You cannot distinguish between it. In this case, you are going to treat this calcification as your floor. So when you will treat this as your floor, you know that the floor is dome shaped. You are going to follow that. You're not going to cut too much over here because you will see this. You're going to go thin out and you're going to try to be in your premises and you try to find the biggest canal first. Okay. So you're just going to trough anatomically. Like if that was your floor, how would you do an access opening? That is your thing. So far we focused on posterior teeth. And the goal in posterior teeth calcification is only to find the orifice. All right. Now we move on to seeing what is the difference of posterior calcifications with anterior teeth. Now, posterior and anterior teeth, they definitely calcify differently. Posterior teeth usually they calcify in a slow, progressive manner. Okay, that we've discussed. And mainly the calcification is on the pulp chamber and you'll have a few blocked canals. But in contrast, anterior teeth, they undergo something known as calcific metamorphosis, or you can also call it as partial pulp obliteration or complete pulp obliteration. And this usually occurs after trauma and you will see a discoloration in the patient's teeth. So these are few of my cases that I've dealt with, different types. Some of them are infected, some we are monitoring. Okay. Now here the challenge is very different. Okay. The chamber is absolutely not present. So you cannot follow any of the guidelines that I told you. You can use the same armamentarium, but in a little different way, but the guidelines are different. All right. Here the canal in total or partially is obliterated. Now the goal shifts from finding the chamber to basically you're going to recreate a trajectory or a canal path using mainly the CBCT and the long axis of your tooth. Okay, and you're basically not just simply uncovering orifice. So these, I feel these are more tougher because again, you can perforate very easily, especially on the labial aspect. So when we come to anterior teeth pulp canal obliteration, again, you are first going to confirm clinically and radiographically, okay? Because you want to confirm that is there really a disease process that is happening. The tooth might be discolored, but you have to confirm if you're dealing with a disease, okay? Or if the patient is asymptomatic, or simply it is a restorative need for the patient, he's bruxing that much, or there is a progressive pathology that you have monitored and you can see the differences. Now, there is this pulp canal obliteration diagnosis and treatment flowchart that was given in IEJ in 2011. It's very simple. When there is an obliteration at any age for the child or for the adult, your first important thing to note is the symptoms and the radiographic signs. If both are present, you will do a root canal because obviously there is an infection. And then you will decide how does the discoloration have to be tackled. Are you going to do non-vital bleaching or you're going to give a definite restoration? And if non-vital bleaching is satisfactory, you monitor. If it's not, then you go in for a coverage restoration. Now, when there are no symptoms, you are first going to see is there discoloration or is there no discoloration? Does the patient have an aesthetic concern or not? So if there is discoloration, but he's asymptomatic, you will first either see you want to do vital bleach, and if you get a satisfactory result, you monitor, or it is discolored and for aesthetic reasons, you have to do a root canal. Then you go back to option one of doing the root canal, you do non-vital bleaching. If it's satisfactory, you monitor. But after the non-vital bleaching, also the discoloration is not gone, then you again come back to the partial coverage crown and you monitor. All right. The second is, again, you will plan with your CBCT. Now, in the posterior teeth, you had the roof, floor, CEJ, furcation. Over here, you are mainly dealing with the CEJ level and the axis of the tooth or of the root, to be more clear. And here you are simply dividing the tooth into these levels. The occlusal point, the pulp horn, if it is possibly visible, even a little bit in your CBCT, the CEJ, coronal, middle, and apical third. Okay. What are you determining with the CBCT? You're going to check the axis depth, the canal trajectory, the root angulations, and how much of remaining dentin is there. Because sometimes you do get cases which are already been opened up, like this one, it was already opened and they had put GIC probably 2 years back. So I already didn't have a straightforward way, how do I go in? And you can clearly see in the CBCT that I'm seeing the canal only faintly in the middle third or more towards 16 mm from my tooth. So now you have to decide when it comes to the axis opening for anterior teeth, whether you want to have a palatal approach or you want to have an incisal approach. Now, for me, a lot of my patients don't want the tooth to be cut from the incisal edge unless I have to go in for guided. So I try, I mean, my experience is such that now I mostly still go for the traditional way, but I'm still very conservative. Okay. And here, in compared to the posterior teeth, you're going to again start with the long shank a little bit till you reach the roof. And then it's all about the Muntz burrs, which are the carbide burrs, long shank. All right. Now I'm going to follow the root axis. I'm only going to drill according to what my CBCT had defined as my trajectory and what I'm seeing on the patient according to the root axis. And I'm always going to be staying centered. Okay. So if I view my tooth like this, that is how I will have a clue. So I go in with my Mansper and I control the depth. Okay. And I advance very incrementally and I frequently keep reassessing. So if you can see here, you will see clues where you can clearly see this transparent area and you can see a dark shadow. Because this is the microscope, you're able to see this punch as a very big hole, but it was barely seen to me that even my 10 size file is what this is actually the size of my 10 size file that I have pricked into the orifice. Now here you will switch to ultrasonics much early compared to the posterior teeth. Again, the same ultrasonics, but right now I like to focus more on the BD, which is the rounded tip, and the ET20, which is needle-like. All right. And I keep following my root axis. Now I'm going to look for the canal clues. All right. You will see a darker central dentine and you will see the translucent calcification. Okay. And here I'm trying to see if I get a catch with my TG16. I've put it in slow motion so you can actually see that it kind of catches onto my Explorer. Mostly in these cases, I really haven't seen a bleeding point, to be honest, because they are necrosed for most of the times. Next is I will negotiate the lumen. Here again, if you notice, we barely use the long shank burr also just to make a dimple in the tooth. That's all. So now I'm going to negotiate the lumen. I'm going to flood it with EDTA. And I'm going to I like using D-finders compared to C+ files for a lot of reasons. If you can see the video below, they have very long flutes, right? So they don't really engage too much, okay? And they let me go deeper without a lot of engaging, and it has a D cross section, unlike the K files, which has a square cross section. So it's going to be cutting more. So if I just want to check, am I really in the correct spot? I think this is better than an Explorer. And here the main thing is it will resist at first and then it will nicely penetrate and it will kind of go through my calcifications inside the chamber, which look like this. All right. So you can see the D-finder because of the long tooths. First it will resist and then it goes in very nicely and gives you a drop into the radicular pulp. Not only big canals, but even MV2s, MV1s. And the good part here is you also have a size 12. This is very important in calcified canal negotiation, even when you're finding the canals. When you go jump from 10 to 15, it's a huge jump. So Mani D-finders has the size 12, which is like an intermediate. So you can still have a nice glide from a 10 to a 15. Now with the D-finder, you basically have what type of a motion? A quarter turn, then you have a gentle apical pressure, and then you peck. When you peck, what you're basically looking for, you're looking for this sticky feeling. Okay? If it is sticky, means you are correct. It's the calcification that you are feeling. Okay? But if it is hard and you're not getting this bowing motion, if you can see this video, usually when you are actually inside a canal and you do this motion, that means you are into the canal. But if you do this and you don't get any vibrating bowing effect, you're probably in the wrong place and you're just drilling probably towards either the furcation or laterally towards the marginal ridges. Then you confirm the canal with your apex locator, okay, and your angle radiographs, and you still don't enlarge the pathway until you have confirmed its position. So you can clearly see now how conservatively we have gone into this, even though we have taken the palatal approach and not the incisal approach. Now we are done with the posterior and the anterior pulp chamber access opening part. And I'm just going to discuss a few newer technologies that have come in this area. This is an interesting negotiator. It basically acts like your apex locator, but for your orifice. I mean, for your orifices and for the pulp chamber. Okay. So, one of the latest developments, it is known as the micro hole negotiator. It is basically based on a novel impedance guided concept, which is designed to aid the detection of your pulp chamber and the hidden canal pathways. Although it is still emerging, it is worth knowing where a future with endodontics can be heading if we are going to now have apex locators just for the orifices. So you've not found the orifice. You have the type 4 scenario where there is no distinguishing between the floor or the walls. This is helpful. But again, every technology has its advantage, disadvantage, or limitation. So let's just look a little bit into that. So how does it basically work? There will be an explorer. I'll show you a video. That is, you'll have a normal DG16 explorer, okay? And you will dry the pulpal flow. And when you place it in the areas where you suspect the orifices can be according to the laws of pulp chamber anatomy, you place them there. Now it will detect a high sensitivity between the microcapacitance and the impedance changes between the orifice and the dentine, okay, or the radicular dentine. So you will get a real-time audio-visual cue and the signal of the target canal entrances where it could possibly be. All right. Now, the working principle here is that sclerotic dentine has a higher impedance and low capacitance, and the micro canals inside, okay, they have a little bit of trace moisture, obviously. So they have a low impedance and different capacitance. Now, this distinguishing factor between both of them is what is on what basis this device works. Okay. It's very important to know that here the pulp chamber has to be absolutely dry. So where you can go wrong could be if you have a crack in a tooth and there is moisture coming in, or you're not able to dry the tooth, or there's a perforation. Then this becomes a little misleading. Okay. But you can definitely use it in severe calcifications, hidden orifices, disc-like or reduced pulp chambers like the type 4. Okay. And difficult retreat. And I told you the limitation is it only detects at the point of the probe where it touches. Okay. And imagine the orifice is here, it does not. So you have to literally be running along that area till you start seeing the difference. Okay. And the key to success here is, again, you need to still have your CBCT, still have your microscope. You need to have the anatomical knowledge to even still think where the orifices can be. And you need a dry chamber. This is the workflow.
Following cautious ultrasonic removal of the pulp chamber roof, selective dentin was removed from the suspected areas where canal orifices were most likely to be located. Using the micro hole negotiator while maintaining a completely dry cavity, readings higher than 3 confirmed the successful identification of 3 orifices: the palatal canal, mesiobuccal canal, and distobuccal canal.
So this is actually co-designed with Professor Nekofer, who's very, very famous. I'm sure you all know him. And I happened to meet him in Dubai during a conference, and that's how I know much about this device. All right. So now we are going into the next advancement. I don't think it's an advancement anymore because it's almost been 10 years since guided endodontics has come in. So another major technological advance is guided endodontics. It's mainly derived from the principle of guided implantology, okay? And it is a reliable and predictable technique for managing teeth with obliteration. I have done a few cases with this, but I still see a few drawbacks because I feel like the tactile benefit of us as endodontists is taken away. But even though you do have the stent, I feel like you still need to know where you're going, because if you've not taken the scan properly or the bite properly of the patient, and the CBCT is also not taken very well, you can still go wrong. Just like even in implantology, it can be misleading. So this was the earliest study that was published, wherein they had tried guided endodontics. But over here, mainly when they made the stent, they needed the support of the adjacent teeth. So it was very bulky, and if you're using a rubber dam, it was a little challenging to be used. However, we had published this article. It's a case series, and we had evaluated this simplified single tooth template. This is when I was doing my undergrad, so this is quite old. But it was very interesting to see. Then we had also done on guided stent or a template when you're doing micro surgeries. So this is a very nice case series. If whoever's interested can have a read. So the evolution of guided endodontics, it just does not stop at static guides. Now, the latest is what we're dealing with is something known as dynamic guided endodontics, wherein you have real-time navigation for the calcified canals. All right. Down is a video. Basically, in this, you need the registration, the bite registration of the patient, and there are certain jaw positions that they will register. And you have optical tracking, that are these cameras which have reflective markers, which do scan, and they work on a certain principle, and then they navigate the software, and you are drilling. As you are drilling, it is telling you exactly where you are, considering the CBCT and the optical tracking. So this is very interesting that we have come up with. I could not find the videos before, but I finally have a video of how it works. So it's something to look forward to. But the limitations are still that it still has a higher cost. It's not very accepted still. Okay, it is bulky, so they are working on it. So I'm sure this is going to be the next thing that we would be using as our armamentarium. Now the next slide is, we have finished about the pulp chamber and whatever is the latest, how you can find a calcified canal. Now we're going to deal with the negotiation part of it. So from orifice to root down. Okay. Before I even get into this topic, I really want to tell you that you need a lot of patience with these cases. You cannot force the file. Okay. And your tactile dexterity is the most important. All right. There are certain principles and certain motions with which you have to maneuver your file into the canal. This is what I'm going to try to really make you understand, because I really enjoy working with calcified canals, because if you understand the principle, I don't think it's a difficult case to deal with. It would be like any other case. All right. And you need to concentrate on your glide path creation. These are your three most important: patience, pre-curving the hand files, and the glide path. Okay. Personally, for me, again, I love the D finders compared to C+, and my pre-curved hand files are normal K files. So I always use the D finder first, then I switch to K files, because I feel K files, even the 6 number file, can still cause a ledge for me. But D finders till date, I haven't seen any ledges caused because of this. Okay. And after this, you make a glide path, and there is EndoStart. I love the easy path file. I would consider it to be the rotary version of DFinders, to be very honest. So it really breaks through the calcifications and it really opens up the canal very fast, in my experience. But as a rule, never start with rotary unless you're very experienced, and there's always a learning curve with such cases. Now I'm going to talk about the 4 pillars of the 4 principles or the 4 techniques, what makes or breaks negotiating calcified canals. Okay. First and foremost is continuous chelation theory. The second is tactile controlled activation. Next is the BRAT technique, which is known as buckling resistance activation technique. And last, you have the dynamic tactile navigation. So what is this continuous chelation technique? Basically, here you are combining sodium hypochlorite with a very weak chelator, okay, or a chelator, such as HEDP, and you are basically creating a single irrigant, okay, so it saves your time. You don't have to keep using saline in between, so you're saving a lot of time. At the same time, you are maintaining a disinfection because of the hypo, and at the same time, you are chelating the smear layer because of the low level of the chelator that is in this irrigant. So you have a continuous conditioning of this dentine. So you have safer canal negotiation. Now, how do you have a safer canal negotiation? When you use this irrigant, it's continuously chelating, right? So what actually happens is your dentine becomes a little more soft, okay? So your dexterity and the stickiness that you want when you know that you're inside a canal is enhanced with this. So this is very, very important. When I was doing my postgrad and undergrad, we always knew about root canal prep, RC prep or EDTA prep. It's been years, more than 10 years when I have used EDTA prep, the gel. Why? Because when you use the gel and you're trying to now go into a calcified canal, or even how we saw the obliteration in the anterior tooth, there will be some amount of debris which you had seen microscopically that is produced. When you use the gel, you're just making it more stuffy over there. So even if you irrigate, there is still some gel sticking around. So that again misleads you into, now, are you feeling the stickiness from the debris and the gel that is made? Or are you actually feeling the stickiness from that calcification and the dentine over there? So whoever would like to give it a try, start using the EDTA solution and you'll see the difference. It also chelates much faster. All right. So this is the main concept about the continuous chelating concept. The next is TCA. We call it TCA. This is the video on the side. Once I explain what it is, the video will make a lot of sense. So this is known as tactile controlled activation. Basically, it's a single stroke activation for safe instrumentation in curved canals. Now you will be wondering, why am I talking about curved canals? Very honestly, probably only in 5% cases is where I haven't seen a curved canal associated with a calcified canal. So I feel like that is rare. Okay, they say calcified canals are rare or curved canals are no. Those are the norms. Those are the daily cases that you will deal with. What you will barely deal with are straight calcified cases. Okay, so take this as one of the principles that you have to work with. That is the tactile control activation. Basically, in this, when you're dealing with a curve and a calcification, what is safer? Will you start drilling? Usually we are asked to drill outside and then we're looking at the tooth and we're going in, right? Now, this is a different concept. Here, you will activate your rotary or even your hand motion only after you have got the tactile feel of passing the curve, okay? So now, if you see the video, okay, they have inserted the file and this is an S-shaped canal. Now, once he is past the curve, now he activates the rotary. When you activate the rotary now, just a peck and you've gone a little bit like 1 mm or 0.5 mm and he has withdrawn it while the rotary is running. So this is very important. The sequence is very important. So if you look down at the three phases, first is the stationary phase, where you will just feel the canal. Okay, it's like a glide path. You place it in. Then you have an in stroke, okay, which is where you will slightly push it and you will switch on the rotary. Once you've gone 1 to 2 mm or you feel like you've got the slide, you will withdraw the rotary file or your hand file. All right, and that's the movement, that's the motion that you'll be doing 0.5 or 1 millimeter by millimeter in cases where you have curved or aberrant curvatures or a double S curve like that. So now this video will make a lot of sense. Okay. And when you're dealing with such a technique, I would use a flexible martensite night file. All right. The examples are high flex. Again, EndoStar is especially the easy path. That is exactly why I love the easy path. It doesn't engage and it is like a definder that will go in, it'll open enough, and it's a 1503 or a 1504 taper. So it really gives me the best glide path. And I can just start using my 2004 after that. I don't really even need to use hand files. But this is because I'm experienced with the file. So give it a try and then it's a learning curve. I would avoid austenitic files. Why? Because I will ledge. If in this I'm going to use a stiff file and expect to do the TCA, I will definitely ledge. So you're going to look for a flexible martensitic file. The third is the BRAT technique, which is buckling resistance activation test. Okay, here when you're negotiating a calcified canal, you are again going to either use HiFlex or EndoStar or any other martensitic file. You're going to do the continuous chelation, which is very, very important. Before anything, you're going to do your patency check. Now, the principle here is again very simple. You will activate the engine-driven file. So you can do this again with your hand and with your rotary. If you're doing it with an engine-driven file, let's say HiFlex, because they have done more studies on HiFlex, and HiFlex has certain properties in the file which kind of sparks the tip. So it kind of breaks the calcification when you do this motion. So what we were doing in the posterior teeth at the pulp chamber level, breaking the pulp stone, you're doing this at a root canal level. Okay. So you're going to activate the engine-driven file with an active cutting tip against the calcification, and you're going to carve a pilot pathway, not the actual, the pilot pathway without buckling. Now, what is buckling? When you try to put the file in and you see that it bends, right? Because of the axial pressure, that is called buckling. So you want to do this technique to resist this buckling effect when you're trying to open a calcification. Okay. So how do you do it? Instead of continuously putting an axial pressure and trying to put pressure, you're just going in again 0.5 millimeter per minute in intermittent activation, and you're increasing the buckling resistance of whatever file you're using, whether it's hand or rotary. So let's see the workflow step by step. First, you will obviously condition the canal. When I say condition, I'm talking about the continuous chelating theory, so that it softens the calcification. Then you will position the file. It is EDM specifically mentioned here because they came out with this technique because of the EDM file. And you will take the EDM file tip and you will place it against the calcified blockage without any rotation. So what you were doing with TCA, you're doing that here. Now you've gone in and you're placing the first resistance that you got, you'll stop there. You've not activated it. Now you will go ahead and you will activate and you will advance barely 0.5, okay? And then you'll apply a little bit of axial pressure, but a long press. In TCA, when you went in, you just went in and you were out. Again, you went inside the S shape and then you withdrew, right? So in this, you're going to have a little more of a long resisting action, and then you will remove and then you will check. Okay, you're going to check the patency of the file and you're also going to check your file. Do you have any of the fluids being disoriented or anything, you have to check that. And you keep repeating this, okay, till you slowly start getting or you start breaking the calcification inside the root canal. The last is the dynamic tactile navigation. Don't get it confused with the dynamic guided endodontics. Okay, a lot of people, a lot of my colleagues did think that they are the same thing, but they are different. We are talking that is at the pulp chamber level, right? Here we are dealing with inside the canal. Basically, it is very simple. It is just a direction finder. Again, you're talking about curved canals because you know curved canals are the normal cases that you get. So the concept is very easy. You use a tactile feedback to dynamically change the direction and locate the true residual canal path. Now let's say you have, this is the curve and you have opened up till a certain level, till the straight part of it. All right. This technique is very useful when you have deep splits and you cannot see them. If either you don't have a microscope or you don't even have the tactile sensation that that there is an extra split. Okay. I do this as the last step every time after I have kind of got the main canal. Whether any canal, I always go ahead and do this DTN method. Basically, what is the purpose? You're going to find any other path that is of least resistance, okay, in order to avoid making a ledge or zip or perforation inside. All right. So you will pre-curve your file, whether it's rotary or it is hand, it doesn't matter. And these are the positions where you're going to clock and you're going to find the direction where that small pre-bend is opening into. All right. So it's 12, 2, 4, 6, 8, 10. All right. So you will go, and then once you place or you feel resistance, you've reached the calcification. Now, when you go in 12 o'clock, you see, no, you're not getting any sticky tactile sensation. You're not going any further. You change, you go to 2. Then you again have the same thing, you change. Till you will finally get a spot where you will get that sticky tactile feedback. And that's when you will go back to your TCA and to the Brad technique. And you will start opening up the canal. And this is very useful in sclerosed split canal cases, all right? Or sometimes you just have a last delta or an accessory canal, okay? And you know you cannot obturate there with a GP, but at least your sealant, your bioceramic sealer will go in. And you know that your irrigation will go in because at least you've opened that portal, okay? So this is very useful. So this is the 360-degree search, what you do. 12, 2, 4, 6, 8, 10. Now that we have discussed so much about how do you deal with the pulp chamber stone in an anterior, posterior, how do you negotiate, what is the armamentarium, we are going to put all these principles to practice. Okay. Now I'm going to be discussing my clinical cases, and I mostly 98% of the times I use bioceramic sealers and putties in my cases. So we're going to see how all of these strategies come together and how do you make a successful case out of it. Before we go into that, I want to discuss this biology-driven strategy. Okay. Now we all know that when you're dealing with a calcified canal, you will end up either ledging or transporting, or you've got a case which is ledge transported or perforated, right? So you have to understand that these are very high risk cases. And here, the normal, like how in your pulp chamber, you don't have the developmental grooves and all the anatomies and the laws that we had studied of the pulp chamber. Similarly, in the root canal, you also lose those pointers. And what are those pointers? You have the apical constriction. You basically lose that, right? So you're nowhere. So you are mainly, most of the times, you either, if you have a resorption, you are dealing with a blunderbuss canal, okay? Or you have a very wide foramina, okay? Or you don't have any resistance form and the infection is persisting. That is when I like to go in for this biological driven strategy wherein I use bioceramic putty and I obturate. It's not just limited to the anterior teeth, it is also very well used for posterior teeth. Okay, and it's not, again, not just limited to the bigger canals. I have obturated MB1, MB2 together on retreatment cases. I don't have the case here, but I didn't have time to really put in a lot of my cases because I was limited by time. So how do you do this biological driven? How do you get back this seal, right? First of all, you need to understand and know that the seal is lost, and how you have the importance of the working length, the vertical working length in a root canal, the horizontal working length, which is your apical gauging, apical gauging, is extremely important as well. Okay, it is not just about the vertical working length. The horizontal working length is very, very, very important, especially in retreatment cases, because when you start, you already know that it's been cleaned to a 3004 or a 3504 anyway. And now that you have the bacteria there and the biofilm, so many times now I can't go beyond and turn my file and remove the extra radicular biofilm, right? So you need to now make sure that your seal is really, really, really good. So you have to understand how the tactile is you need to understand the tactile part of it, and you need a microscopic confirmation to understand that, yes, I'm not dealing with a closed apical constriction. So my go-to rule is, when I do my apical gauging, I'll actually tell you how do you do an apical gauging if there are any beginners. When you have a file and let's say the length, you know that the working length is, let's say, 20, and you started with a 15K file and you got 20 as your working length. So usually, according to the rules, they say 2 to 3 times you go higher and you do the BMP. Now, let's say you've done that, and I'm talking about an anterior tooth. You can have this on any canal. Now, I've reached a final of, let's say, 40, 45. Now, I will take this 40 O2 hand file. You've done a rotary, which may be 0.4, 0.6, it doesn't matter. You'll go back to your 2% hand file and you will take it to the working length. And then you will tap. Okay. When you tap and you feel that the same master file is going a little below, okay, below the level of the working length, that means it is loose. That means your apical diameter there is not 4004 or 4006 or an F3 or an F2 that you had made. You have to design it. You have to customize your cone now, even though you have done a crown down with certain dimensions. Okay. So now you move up at that working length, and you keep going down, and that's your apical gauge. All right. So that becomes your width, working width. And with this, you will go and you will then use, I like to obturate with the bioceramic putty now, like an MTA Apexification. So the first case of PCO, what we had dealt with. Sorry, there's a little bit of a glitch. Okay. Coming back to the pulp canal obliteration case, this is the same case. And that is exactly what I did. Even though this was calcified, you had a blunderbuss opening, which was almost a 60 or 70K file. So I decided to do a putty, bioceramic putty. And you can see the healing of the fistula as well. And I nicely activated it, and that is the bioceramic plug. And back to the same posterior tooth that we were discussing. All right. I troughed and they did look like an MB2 to be present, but this was just an isthmus, a very thin isthmus, which I kept tracing. And that is the post-op. The next case that I'm discussing is a very rare mid-mesial in the mandibular second molars, which is quite rare. So It's only present less than 1% worldwide. We had a retreatment, he had a swelling, and then there was pus discharge, and then I found the mid-mesial there. And then we obturated it. And again, this is my bioceramic plug. Then we're dealing with in 3 mid-mesials. You can see that the tooth is absolutely calcified. We followed the same rules, laws, and we were able to find all of them. By the way, this case was not done under the microscope. I only had loupes, but because of the principles, I could use them. The next case is one of my most cherished cases. This was basically a lower premolar, which had a missed lingual canal, which you can see in the CBCT. Again, I told you the CBCT will not tell you that the canal is missing, but you will have clues based on your laws. And you can see that that is the missed canal. The funny thing about this case is it was in totally obturated with composite. You can see the composite. So we had to remove that. There was a broken file and then find the obliterated canal. Then this is another interesting case of an upper canine. It was already root canal treated, but she would have a little bit of a vague pain. So when we took the CBCT, I didn't find any canal or anything because CBCT will never tell you that. But if you see exactly where it is located, it's located lingually for no reason, and the obturation is more buccal. So either the previous dentist has over instrumented there and transported the canal, or we had 2 canals or a split. So you can see that the deep split has been obturated. This is again a case of a ledged and under-obturated sharp curve. You can see where we began and how did we end. You can see the hook curve that we were dealing with. And this is another case of a ledged sclerosed root. This is where we were. There was a post, there was a perf, we sealed the perf, we re-established. There was a perforation here done also by them, and case is doing quite well. And this is my last case. This case basically was of an upper premolar. There were 2 broken files, there were 2 posts, you can see that here, and barely any tooth structure. I removed this. In this, what I did is instead of troughing here, I removed the isthmus. So I could then not cut any more dentine, which I had. And then I happened to see and negotiate that it was again splitting into 2. So it was 2, 1, 2. And this case, why I will always remember is because when I sent it back after the referral, they perforated the case. I think it's missing that slide. So at the end, the take-home strategy is basically you do rely on your diagnostic exercise, and magnification and CBCT is very important. They're essential. They're not optional. You need to have an endodontic calcification rhythm that you can transform repeatedly. And the high-risk cases, you do demand more strategy than heroics. And the goal is not to save every tooth, but to save the right tooth predictably. Thank you.
Thank you so much, ma'am, for such wonderful and amazing lecture on
Thank
calcified
you
canals.
for bearing with me.
Thank you, ma'am. We'll proceed with our next lecture. Next up, we have with us Dr. Sahil Chaudhary. He is a restorative dentist and microendodontist. Sir is going to take the lecture on aesthetics, trauma and interdisciplinary care, coronal discoloration and internal bleaching, endoaesthetic synergy. We welcome you, sir.
A very good evening. So I'll be sharing my screen for the presentation. Just give me a moment.
Yes, surely.
Yeah. Is my screen visible? If someone can confirm that, please.
Yes, sir, it's visible. We can start with the lecture.
Thank you. Good evening, everyone. So, today's topic is on coronal discoloration and internal bleaching. Uh, so, for those of you who do not know me, I'm Dr. Sahil. I'm a restorative dentist and a microendodontist practicing in Chennai at my private practice. I'm also a co-founder of a brand called the Dental Box, where we deal with certain dental products which are not easily available in India. So, coming to coronal discoloration, which is the topic for today. So, the most common cause of this is basically non-vital teeth that we as endodontists see in our day-to-day practice. So this is the most common cause of discoloration. That is, whenever a patient comes to you after a trauma, not immediately, but a delayed effect of that is internal discoloration. And to treat this, there is a nice approach. Instead of going with crowns, veneers, you go in for a more conservative option, which is non-vital bleaching. And this is done when there is any sort of internal discoloration. You can get rid of that discoloration using a very simple approach, which is non-vital bleaching. So before moving on, we'll just look at the etiology of the various, reasons why teeth get discolored. So I've broken this down into three parts. There are reasons which can happen before treatment, during treatment, and after the endodontic restoration. So before treatment, any patient who has come up with trauma, this is the most common cause. Then there is pulpal hemorrhage. For some reason, if the pulp gets hemorrhage shocked due to any sort of trauma, the pulp eventually starts getting necrosed or partially necrosed, and this discolors the tooth internally. Calcific metamorphosis, again, one more sequelae of post trauma on of a anterior tooth. During endodontic treatment, if there is incomplete pulp removal and if you've obturated after that, you will see that tooth might turn discolored after a while. Some intracanal medicaments are a little too harsh on the inner dentine, and that also causes discoloration. Some sealers, and also if the GP is not sheared off at the cemento-enamel junction, if you have your GP extending into the coronal portion of your tooth, then there will be discoloration again. And after restoration, earlier there used to be a lot of amalgam restorations or metallic posts done in the anterior teeth as well. So all these caused teeth to get discolored internally. Coming to the pathogenesis of coronal discoloration, so what happens after a tooth undergoes trauma? So basically, a tooth will undergo trauma, the pulp will get shocked, hemorrhaged. There will be breakdown of the RBCs. The hemoglobin is released from those RBCs, and the because hemoglobin contains the iron sulfide pigments, these pigments enter the dentinal tubules and they penetrate and they cause the discoloration. So it is a very common, a finding that is noted in anterior teeth. Whenever a patient undergoes trauma, you will have a lot of these cases coming to your practice on a routine basis. Uh, so why do we do internal bleaching? So the most important thing is it preserves your natural tooth. You don't have to do a crown cutting, reduce 2 millimeters all across and give a crown, and that weakens the, tooth. Apart from that, you cannot matching the shade of a single anterior tooth is very, very difficult. It's very challenging. So, you do not want all of that, to be a part of your treatment. Then getting just a simple procedure, getting a nice shade reduction after just your non-metal bleaching is very good. It is a very cost-effective procedure. It does not involve any labs. You do not have to pay the lab for your ceramic crown. You do not have to communicate with the lab. There will be multiple appointments, in both the cases. But coming to internal bleaching, it becomes a little too easy to do the procedure, as it's just your patient visiting you for like 5 to 10 minutes for the follow-up visits to get the bleaching agent revised or changed. There is again high patient acceptance because you're going to tell the patient the treatment is going to be cheaper and also it's going to preserve the natural tooth. So any patient will opt for that before moving on to crowns or veneers. It will give you excellent aesthetics if you do it the right way. And all internal discolorations, once treated, they usually do not come back because you have removed the main etiology of the the reason why the tooth got discolored. So in case of trauma, if the pulp is necrosed, you will do a root canal treatment, so there's no more pulp left in the canal. So once, the tooth is gotten back its natural color, it generally does not go back. So the least invasive treatment which is capable of achieving the desired result should always be considered first. So before an endodontist, I'm a restorative dentist, a conservative dentist. So my goal is always to preserve the natural tooth as much as possible. So if you look at that example on the right side of your screen, we had a patient who had undergone trauma about 10 years back, and she had this, the cervical third to the middle third of the tooth discolored. So when we did the vitality, the pulp sensibility testing, we found that it was non-vital. So we immediately, advocated the use of, we first did a root canal treatment, followed by that we did a internal bleaching. And just after 5 days, when the patient returned back, the tooth was back to its normal color. So this is what you can achieve. The tooth is fully there in place. The only concern is discoloration. You cannot, be aggressively cutting this down into a crown and, giving the patient a crown, because it's just too much of a treatment for this kind of a case. Now, there are some common bleaching agents that you need to know for internal discoloration. So, hydrogen peroxide or sodium perborate is most commonly used. Hydrogen peroxide is available in gel form, whereas sodium perborate is used as a powder. So, earlier, sodium perborate was used a lot before hydrogen peroxide was available in the gel form. But nowadays, the use of sodium perborate is not that much. It's reducing. So even if sodium perborate is used, it is always mixed with saline or hydrogen peroxide liquid itself and placed into the access cavity. The main goal of non-vital bleaching is you will have to recall the patient every, like, say 3 to 5 days, and evaluate the shade and keep changing the bleaching agent inside the access cavity. So that replenishes the amount of hydrogen peroxide or the sodium perborate that is available for the whitening effect to last. And also the results keep coming back quicker, and you do not want to over whiten the teeth. Sometimes what happens is, if you leave the bleaching agent into the tooth for too long, it will whiten it beyond the adjacent tooth, and it will look a little like an over treatment, and it won't look aesthetically pleasing. So you have to recall your patient every 5 days and evaluate the shade, and then decide whether you want to go in for another 5 days of bleaching, or just conclude the treatment. Now, coming to the mechanism of bleaching, so what the bleaching products that we use, the main ingredient is hydrogen peroxide. So basically, it decomposes into free oxygen radicals. Now, what this does is, the chromogenic molecules, the colored molecules inside the tooth, they get oxidized, and they are broken down into smaller colorless compounds. So the amount of light reflecting off the enamel, or the appearance of light reflecting off the enamel, becomes much brighter and whiter. So per se, the discoloration is not getting removed, but it is only getting broken down into smaller bits and pieces. So the way the light reflects of the enamel improves, so your tooth appears whiter. So it is a very simple procedure. All you need to know is how to do it stepwise. Before that, you need to arrange the shade tab in a certain way whenever you're doing whitening procedures. So this is the Vita Classical Shade Guide, but it is arranged in terms of value. So it is arranged in terms of the whitest to the darkest shade, not in terms of the chroma or the hue as it comes in the packaging. You have to arrange it in terms of value. So B1 is the whitest, and C4 is the yellowest or the darkest shade that is there in the shade tab. So whenever you're doing bleaching procedures, always arrange your shade tab this way, so that you are certain of your preoperative shade, and then decide, or you check with the adjacent tooth the natural shade, and you show the patient that currently we are at this shade and we have to improve 7 to 8 shades brighter. So even the patient is aware, you take good photographs, and you can document your cases. Now, this is a very, a common product used for non-vital bleaching. It is very easily available. It's by a good brand called Ultradent. So Opalescence Endo, it is a 35% hydrogen peroxide gel, which is designed only for internal bleaching. You cannot use this for external bleaching. It will not work. It is only for non-vital bleaching or internal bleaching. Now, there are certain conditions where you have to avoid using this. One thing is whenever you're using any form of bleaching product, be it vital, non-vital, you cannot use it on patients with compromised gingival health. Just avoid it in patients with basically any gum issues or periodontitis. And any tooth with inflammatory resorption, any existing root resorption, we generally avoid non-vital bleaching because one of the common complications of non-vital bleaching is cervical resorption. So we do not want an existing resorption to get accelerated by doing non-vital bleaching. Now, whenever we apply this gel, we apply it or inject it into the access cavity. We do not contact this with the gums. And whenever you do any form of bleaching or whitening, you cannot do any adhesive procedure for about 1 week because the free oxygen radicals would have interacted with the tooth, the enamel, or the dentine. Your bonding will get compromised, so we let the natural saliva flow, remove of all the remnant peroxides on the tooth surface, and we then do any form of bonding only after 7 weeks, after 7 days, which is 1 week. And do not etch the internal dentine.
Nada. She works like a boxer. Me? No, of course not. Papa, mummy का
So we do not etch the internal dentine before whitening because it will not enhance the results. So do not do that as well. Now I will just break this down step by step on how to do it. So you will generally have patients coming in like this with a single discolored tooth. It will either be root canal treated or you will have to do the root canal treatment simply because it is non-vital. So that's the way you proceed with the treatment. Now, this patient came with a root canal treatment done about 3 months back. The tooth was asymptomatic, although there is a large periapical lesion, but since it was recently done and patient does not have any symptoms, we then went on to address the discoloration. So you will have a classical radiograph like this. Either it will be root canal treated. If not, you can do the root canal treatment, and after that, it will look like this. Now, what we do is we remove any restorative material and the root filling 2 millimeters beyond the cemento enamel junction. Now, what we do is we first take a periodontal probe. You measure the clinical crown height. So in this case, say it is about 8 millimeters. So now we know that the tooth height, that is from incisal edge to the gingival margin, is 8 millimeters. Now we have to reach the cement enamel junction and remove 2 millimeters beyond that. So usually in a healthy tooth, the cement enamel junction is about 2 millimeters from the gingival margin, and we need to remove 2 more millimeters of material above that. So in this case, the crown length was 8 millimeters. The cement to enamel junction will be at about 10 millimeters, and we need to remove the material 2 millimeters beyond that, so it becomes 12 millimeters. So now what we do is we take our piezo reamers. This is what we use for GP removal when you're doing post cases, like a fiber post or a metal post. So you will take this piezo reamer. I generally start with size 2 because usually upper anteriors, the canals are wide. So you can skip the size 1. You start with size 2. You place your rubber stopper at 12 millimeters and you remove the material. Now, when you remove the material, you can see the radiograph that we have removed, about 2 to 3 millimeters beyond the CEJ, which is good enough. After you remove it, just plug it and flatten it with your plugger. So after that, when you take the radiograph, it looks like this. Now you have to place a barrier of about 2 to 3 millimeters using either GIC, RNGIC, or a bonded flowable composite. Now it is very simple. You just have to, if you're using magnification, it becomes easy. You place the material and you let it set, or if you're using a composite, you can light cure it and then retake a radiograph to make sure that you are well within the cement to enamel junction. You do not have to overfill it into the tooth because your bleaching agent has to act until the gingival margin for the until the cement to enamel junction for the color to get a little better in your post-op. So what we generally do is we place this barrier. This barrier is basically placed to protect your GP from the bleaching agent. Otherwise, the bleaching agent might leak into your root dentin and beyond your root, and it might cause resorption. Or the most common cause or the effect is cervical root resorption. So we do not want all of that. That's why the placement of barrier becomes a very critical step. To place the barrier, remove the GP, and then you place the barrier. Next, we will fill up the chamber with the opalescence endo, and then you just put in a cotton separator and fill it with a temporary filling. You have to repeat this every 5 days until the desired shade is achieved. So today I will do this procedure. I'll put the bleaching agent, recall the patient after 5 days. I will see the improvement in the shade, and then based on that, I will decide whether to go in for one more cycle. So this is how it looks. It is a translucent gel that you place it into the pulp chamber, and then you just place a cotton separator and temporary cement and recall after 5 days. Next, say your treatment is done, you have done about 2 to 3 cycles, you're happy with the shade. You remove all the whitening and the temporary material, you rinse and clean the access opening. Now I will seal this with a cotton pellet and a temporary restoration for 7 days. And then 7 days later, I will recall the patient and change it to a permanent restoration, either with GIC or composite. So this is how the treatment looks like.
Lights, camera, action, that's it.
So this is how it looks like on day 10. So I basically did 2 cycles in this case. So that's the pre-op. On day 5, when the patient came back, there was a drastic improvement in the shade. And we then, changed the bleaching agent. And on day 10, when the patient came, it almost was like the adjacent tooth. Now in this case, the tooth was fractured, so I didn't want to go in for a crown. I wanted to go in for a more conservative treatment option. So we did a single unit Emax veneer, and we were able to achieve a good bonding and shade matching as well. Because whenever you do veneers, it's going to be like a thin shell, so your underneath tooth color will be seen through. So if I would have done a veneer on the pre-op tooth, I wouldn't have it wouldn't have been possible to do a veneer there. So that's why you need to reduce or brighten up the tooth and then do a veneer. Now, this was another case. This female came in with, this complaint of discoloration, and then we found out the tooth was non-vital. The root canal was not done, so we did a root canal, and then we did one round of opalescence and So, so this is how the tooth looks before and after the treatment. So we did the root canal treatment and then just one cycle of opalescence endo, and you can see a drastic improvement in the shade. One more cycle would have been better, but patient, wasn't willing for one more cycle of bleaching. So we just left it at this, but there was a good drastic improvement in the shade after the whitening. Now this is another case. This is a lateral incisor, fully in shape. There's no other issue. It's just non-vital, root canal treated. So we did 3 cycles of opalescence endo in this case. So you can see how the shade has improved from where it was before. Uh, it was way darker than what we see now. And this is almost matching the adjacent tooth, so you don't have to give a crown or veneer to such patients. They'll be very happy with what you have done because you have preserved the natural tooth, and also the shade has improved drastically. This was just a 3 cycles, so patient had to come in 3 times, and 15 days later, when you look at the tooth, it's completely of a different color. So this is how we do the non-vital bleaching. Very easy to do, very conservative, and at the same time you get good aesthetic results. This is another case where patient had a discolored 2-1, again non-vital. Root canal treatment was done, and then we did 2 cycles of opalescence endo, and it almost merged or matched with the adjacent tooth. Again, such cases, the tooth is entirely in shape. There's no fracture whatsoever, so you do not have to, go in for an aggressive treatment and give crowns for such cases. Uh, Basically an opalescence endo whitening, or just a composite touch up after that would just be a good enough treatment for such a case. This is another case. You can see how dark the tooth is. So we did 3 cycles of opalescence endo. We got down the shade because the treatment plan in this case was to go with veneers. So instead of ceramic veneers, since we got a good change in the tooth 1-1, like you can see, it's almost matching the adjacent tooth color. We didn't then go in for veneers or crowns. We plan to do composite veneering. So I cannot do a composite veneering on the pre-op color because it wouldn't, there's no way possible with the best of the hands that you can get a good, masking of the discoloration. So we reduced the tooth shade by doing 3 cycles of non-vital bleaching, and then we got the mock-up done, and then we did injection molding with direct composite, which was a composite by GC, which is made for injectable, which is injectable composites made for this kind of a procedure. So it's directly transferring the mock-up into the patient's mouth with a transparent, it's an extra clear material that we use, and then we inject it using a flowable composite. So we do alternating teeth by placing Teflon on every adjacent tooth. So we restore 1-3, 1-1, and 2-2 at once, and then 1-2, 2-1, and 2-3 in the second cycle. So we do 2 cycles of injection molding, and this is what we get. So, there was no way possible that on the pre-op tooth I would get such a good outcome. So you have to brighten up or lighten up the shade of the tooth and then do this procedure. So thank you so much for your patient listening. I restricted my lecture to a very clinically oriented, session so that you can directly transfer this into your practice tomorrow, and you'll be able to achieve good results if you do it the right way. Thank you.
Thank you so much, sir. We have a question for you, that flowable composite use, then we have to etch, or can we do simply composite in that case, or veneers needed? There is a
Uh,
question from the student.
Yeah, so we don't have to etch the inner dentine because the composite there, you do not really want it to bond. It's mainly to create a barrier. So I just apply a bonding agent, that also very close to the GP, only in that 2 millimeter part. You cannot apply a bonding agent throughout the, access cavity or the pulp chamber. Just very close to the GP, I place the bonding agent, I light cure it, and then I put a 2 mm flowable composite. But if you're starting with, I would suggest go in for GIC or RMGIC, mix it in a nice dough consistency, and just transfer it with your plastic instrument into the access cavity and just plug it in. That will be much easier way to start with. Composite, I would suggest you to do it only if you're using magnification. Again, you can just do a composite restoration as well after the result. It is not always necessary to do a veneer, but the only thing is you have to be confident enough with your composite work if you can match the shade and merge the shade after the result that you get with bleaching.
Thank you, sir. Thank you so much for such wonderful lecture.
Thank you.
Moving on to the last lecture of the day, we have with us Dr. Abik Mukherjee. Sir is Associate Professor in Department of Conservative Dentistry and Endodontics, ITS Dental College, Muradnagar. Today, sir will be sharing the insights about traumatology in endo, concussion, luxation, avulsion, and follow-up protocols. We welcome you, sir.
Thank you.
Can you hear me?
Yes, sir, you are audible. You
I'm
can share
audible.
the screen and we can start with the lecture.
Okay. Is my screen visible to you?
No, sir, not yet.
Okay. Wait. Is it visible now?
Sir, yes, sir, it's visible. We can have the slideshow view now.
Okay.
Yes, sir, it's visible and fine. We can start.
Okay. Good afternoon, everyone. So today's lecture is on traumatology and endo, and we will see about the follow-up protocols. So basically, these are the contents under which I will cover this lecture. We will see the classification about the history and how to diagnose. I think over the period of time, I think trauma and endo, I think the endodontic part has changed drastically. There is International Association of Dental Traumatology which has given several uh, other new classifications as well that we have to take into consideration while we mitigate with the treatment protocols. We will learn about the type of dental traumatic injuries, and one of the basic things that we make mistake as endodontists is splinting. I think what kind of splints we should use, whether flexible or rigid or semi-rigid. I think that we will also discuss. So coming to the introduction part, traumatic dental injuries, they represents as acute transmission of kinetic energy to the tooth, soft tissues and supporting structure, which results in fracture or displacement of tooth and separation or crushing of the supporting gingival tissue and alveolar. So when we see the incidence, it has more of a male prediction of about 2:1. It commonly occurs in the anterior region as it is more prone to accidents or any kind of sports injuries. Now, the maxillary, they are affected more as compared to mandible. So, what are the common causes? Common causes are sports accident, automobile accidents, fights and assault, domestic violence, biting, hard items. Now, there are certain key disposing factors as well. Increase overjet, if you have an increase overjet and if there is an trauma or an accident, it will have a more impact as compared to a normal overjet. Next is protrusion of the maxillary anterior teeth, same, and insufficient lip closure. Now this is where trauma and endo becomes very interesting with the classification. In 1956, trauma, I think, is classified by Robinovich in 1956. Ellis and Davis classification in 1970, we already know, and which we have already read in our BDS or to certain extent and extensively in our MDS program as well. Then Hargreaves and Craig in 1970. Then WHO also gave a classification in 1978, followed by Anderson in 1981. This Anderson classification actually covers all the dental trauma. Now, Garcia and Godoy in 1981, they also gave a classification. Then Hersey and Moral in 1982. Then this Ellis and Davis classification were modified by MacDonald, AV, and Lynch in 1983. And in the 2000 spinals at Atlanta, they gave a classification. Now, coming to the classic classification by Ellis and Davy in 1970, first comes the class 1, where there is a simple fracture of the crown which involves the enamel. In class 2, this is extensive fracture of the crown where only enamel and dentine are involved. In class 3, it involves enamel, dentine, and pulp. In class 4, this point is very important that a tooth
that becomes non-vital with or without the loss of crown. So the tooth has already become non-vital. Class 5, the tooth lost as a result of trauma. In class 6, there is a fracture of root with or without loss of crown. Class 7, there is a displacement of tooth without fracture of crown on root. And class 8, there is a fracture in mass and its replacement. Now, WHO also gave a classification in 1978. As you can see, there is a number 873. So what it denotes the open trauma of head. This number denotes the open trauma of head, under which there are subsequent classification. So basically from 870 to 879, these are the actually fractures or the trauma of the head, neck and the trunk. So 873 is specified for the head part. So 873.60, it tells about the enamel fracture. Now after that, there is a 61 is your crown fracture involving enamel dentin without any pulp involvement. 62 is your crown fracture with pulpal exposure. Then comes your root fracture. 64 becomes your crown root fracture. 66 becomes your luxation. 67 becomes your intrusion and extrusion. 68 becomes avulsion. 69 becomes any injury to your soft tissues. Now, these terms like luxation, avulsion, intrusion, extrusion, I think it is given nicely in the next classification by Anderson. So, in first, he has introduced injury to any hard tissue. So, I will give you a gist, because when we will discuss this heading separately, it will be easier to you to understand what it actually means. So crown infraction means basically there will be any kind of crack line on the enamel surface. That's it. Don't complicate it. So that there is no term associated like complicated or uncomplicated associated with crown infraction. So there will be only a demarcation, only a crack line on the enamel surface. Now coming to uncomplicated crown fracture, so it will only involve the enamel and dentine. So there will be no communication with the pulse space. Communication with the pulse space will happen in complicated crown fracture, which will involve enamel, dentine and pulp. Now coming to, and same goes for the uncomplicated crown root fracture, which will only involve your either your enamel, dentine and cementum. When it involves the pulse space, it becomes complicated crown root fracture. Now coming to injury to periodontal tissue, first is concussion. So concussion basically means when you are hit by a blunt object, but the tooth remains on its position, but when you just tap it, you will feel that the tooth is tender on percussion. So this is called as concussion in layman term. And luxation is something that you have to extensively know, because if the tooth is coming out from the socket, means that there is a luxative movement. This is how you luxate the tooth. Same goes for the luxative injuries. So the subluxation means that it has come out some part, but still it is intact in the alveolar socket. So it is mobile, but it is still in the alveolar socket. Now intrusive luxation means that the tooth has gone inside. Extrusive luxation means the tooth has come outside, so it is mobile in nature. Lateral luxation means the tooth has displaced its position from its initial position. And X articulation, so this is another term for a term called as avulsion. Avulsion can also be called as X articulation. So avulsion means that the tooth has completely been knocked out or displaced from the socket. Now coming to injury to the supporting bone. So here it becomes very interesting. Comminution of alveolar socket. So comminution of alveolar socket means there is a crushing of the alveolar socket. Now comes the fracture of the alveolar socket wall. So the socket wall, it holds the tooth. Now fracture of the alveolar process from the tooth, a fracture line has progressed into the main bone, maybe your maxilla or the mandible. Next is fracture of the mandible and maxilla, and how to differentiate it. This is a very interesting thing. When you will have a fracture of mandible and maxilla, 3-4 units of the tooth will move together. It's not will be a single tooth that will move. You will have 3-4 tooth. When you move, it will move together. Now, injury to any gingiva or oral mucosa, there is laceration, contusion, and abrasion. These are, you can say, similar almost. uh, any kind of bruising to your gingiva will cause this kind of problems. So Anderson, he has given a very good classification in 1981 itself. So the main thing with traumatic injury is that you should be able to diagnose it properly. If because if you diagnose it properly, treatment protocols differ, whether the tooth is vital, tooth is non-vital, there is avulsion, or any kind of laxative movements are there, or their kind of intrusive movements are there. When you have to do a orthodontic extrusion to pull out the tooth, or a surgical extrusion, so there are treatment protocols change. So you have to diagnose traumatic injuries properly. So these are the various methods. First, you have to record the case history. You have to see for the clinical examination. Then this is very important, pulp vitality test. So you will have, the traditional methods, but we will discuss about the latest advancements. And the most important tool that you have with you is your RVGs. So the radiographic examination, they become paramount in diagnosis of your traumatic injuries. Now coming to what you will do, first you have to do the physical examination, check for consciousness, potential for aspiration, whether it has gone inside, any two pieces have gone inside or not. You have to see whether the airways compromised or not. Now you have to know the age of the patient, and you have to know the three aspects, that when, where, and how the accident occurred. So this 3 4 5 points, number points, are very important. Why? Because when the accident happened, it influenced the decision that need to be made, the treatment, and it signifies the condition of the pulp as well. Now how it happens, you will know the idea whether it's a direct or indirect trauma. And where, because there are places where there can be iron rods and iron rods as well. So there are chances that a patient needs to have a tetanus toxoid as well. Now coming to the clinical examination, so there are, as we already know, there are external examination and internal examination. For us, internal examination becomes very critical, but you can't just concentrate on the internal examination and exclude the external examination, but you have to do it. For head, first we have to see for the head and neck findings, so that we have to see for the neck pain or any kind of nasal hemorrhage is there or not. Now you have to see for any kind of laceration or any kind of hemorrhage in the head and neck region. Also, you have to see whether there is a deviation of the TMJ or not. You have to see for the bilateral palpation. You have to see for any kind of soilings or tenderness uh, in your mandible or your zygomatic arch as well. You have to see, you have to palpate and see. Now, coming to the internal examination, there are two sets that you have to do. First is your soft tissue examination, and next is your hard tissue examination. So coming to the soft tissue examination, you have to inspect your tongue, oral mucosa, or palate to see whether any kind of laceration is there or not. Similarly, you have to see for any kind of hematomas are there, or any kind of, you have to palpate and see whether any kind of tenderness or swelling or bruises are there or not. Coming to hard tissue examination, you have to see whether teeth alignment is correct or any kind of displacement has occurred. You have to check for the occlusion or any kind of bone fractures, or the tooth has become mobile or not. In long-standing cases, what you can see that the tooth will become discolored. So this is a sign that the tooth have become necrosed. Then you have to see for any kind of fracture lines and as well. Now, this test is very important, the percussion test. So, always remember when you are seeing, when you are clinically checking traumatic patient, always remember that when you check from the side which is not impacted by the injury, because it gives a patient a certain kind of assurance that okay ठीक है मैं ठीक हूँ ठीक है. Now what happens that you can make a analyze itself with the percussion test, that if you see a intrusion or if you are doubt whether the tooth is positioned here or not, if it has gone into the bone, then you just tap it and you will see a metallic space because it is already embedded into the bone. Now in subluxative or extrusion, in extrusion cases, there will be space between the tooth and the bone, so you will always feel a dull sound. So there are two kinds of sound, the metallic and the dull sound. Now pulpal diagnosis is a challenge in traumatized tooth, because I will give you a brief idea before I tell you what is the reason. In layman term, I will say that when a tooth is get impacted, uh, there are certain fibers. I think you people have heard about A delta or C fibers. So when there is a trauma, always remember these fibers, they either die or go into a resting phase. Okay, so any kind of pulp vitality that you do at that time, whether it's your heat test, cold test, or pulpal test, electric pulp test, the tooth won't respond to any of this pulp vitality test, because the fibers are already in a resting phase, or they are almost dying. So what happens that you have to, when a trauma patient comes, you have to at least give these fibers time to regenerate or revive. You have seen patient going into coma, but if things are okay, then you see the patient gets revived. So same goes with the fibers, you have to give them time. So the thing that you have to remember with trauma is that you have to wait and watch. Patience is the key here. Patience is the key to know about the pulse vitality here. So there are vitality tests which you people already know are the thermal test with your heated gutta percha or a heated ball burnisher that you can take. Then your cold test, you can do it with the dry ice, or then comes the electric pulp test. Pulp tester is there, so patient will elicit a kind of response. Now apart from uh, this test, there are certain tests, because this heat test, cold test, or electric pulp test, they tell about the uh, health of the fibers. They are related, as you can see, they are the sensitivity test for the nerve endings. They do not tell about the presence of absence of blood circulation. So this presence or absence of blood circulation are told by some tests known as laser doppler flowmetry or pulse oximeter. So this pulp sensitivity test at the time of injury is important for establishing a point of reference for evaluating the pulpal status in later, followed by examination. Now this becomes very important, because if this is turned to due to injured nerve fibers, it will give you a, initially it will give you a false negative or false positive test. Actually what happens, neural generation of traumatized tooth is slower than the vascular generation and sometimes even lacking. So what happens, the vascular is the blood circulation. These devices are actually helpful in detecting the pulse vitality in trauma cases, as compared with your traditional methods like your heat test or electric pulse test or the cold test. And you have to recall the patient, like for example, a trauma has happened, patient has come to you, electric pulse test or any kind of pulse sensibility test won't give you any result. You have to recall the patient after, for example, 21 days. So according to American Association of Endodontics, you have to keep on repeating the test at 2 to 4 weeks, 6 to 8 weeks, 3 months, 6 months, 12 months. But in between, if you see any kind of color change, that means that the pulp is getting necrode. So you have to initiate with the root canal. Now this is a very interesting to know about what has happened to the tooth. So it is called as trauma pathfinder. So first and foremost, as you can see, a total displacement out of socket. As I've mentioned, if the tooth is out of socket, it is called as something called as avulsion. Now there are two phenomena that can happen. There can be no displacement or a certain kind of displacement. So when there is no displacement, there can be two things. Either there is no loosening or loosening. That I have told you, if there is a loosening and there is no displacement, but the tooth is mobile, but it is still in the socket, it is called as subluxation. When there is no loosening, but it is tender on percussion, I have told you, when you are hit by a blunt object, but the tooth itself is in the position, right position, but it is tender on percussion, then it is called as concussion. Now, if there is no tender on percussion, then there are two things that can happen. There will be no fracture. It means that nothing has happened to you. The tooth is all right. But if there is a fracture, then two things can happen. Either it can be a crown fracture or it can be a crown root fracture. If the fracture is above the gingival margin, it is your crown fracture. If it is below the gingival margin, it becomes your crown root fracture. Now, in the displacement, if I see any kind of mobility, so you can see a several tooth move as a unit on palpation. It means there is a alveolar fracture that I have discussed earlier. Now, if there is a mobility on single tooth and you see no X-ray signs of root fracture, it means that tooth has come out a little bit, known as the extrusion. Now, if X-ray signs show signs of root fracture, it means it can be a root fracture. Now, according to International Association of Dental Traumatology, there are three recommended radiographic angulations. First is the 90-degree horizontal angle with central beam through to tooth, occlusal view, and lateral view from mesial and distal aspect that we already take in our routine endodontic practice with mesial or distal shape. So you have to take these three radiographs. First, a normal 90-degree horizontal angle. Next is your occlusal view. Next is your lateral view. This will show about the periapical status. Now, coming to the first form of dental trauma is your enamel infraction. What I have told you, that there will be only a crack sign on the enamel surface. So how you analyze it? You can analyze it clinically through certain dyes like your methylene dyes, or you can use your curing light to see the extent or the crack. Now, radiographically, there are no abnormalities. Now, what you can do, you can seal it with a resin. So, and in these cases, there is no follow-up needed. Now, coming to enamel fractures, where there is a complete fracture of enamel, there will be loss of enamel, but there will be no exposure of dentin. So I have already told you there are three angulations, radiographic angulation. One is your periapical, occlusion, and eccentric. These three radiographic angulations are paramount when you are dealing with traumatic injuries. Now, why these radiographs are taken, whether it's a minor enamel fractures or not, to see that any kind of subluxative injuries have occurred or not, because we have to rule out that, because if it is luxative injuries, when you have to, the treatment protocol also changes. Now, in terms of enamel fracture, you have to smooth or the roughen margins, that is called your enameloplasty with the finishing bud, or you can do your normal composite restoration, aesthetic composite restorations. And if the patient comes with the fracture fragment, you can reposition or bond that to the tooth surface using a flowable composite. Now, you have to evaluate for the vitality, and for that you have to evaluate at the 6 to 8 weeks or 1 year. Now, till now we have now there is an enamel or dentin fracture. Now, condition happens that there is an enamel and dentin fracture without any pulp exposure. Now, according to Anderson, this is an uncomplicated crown fracture. Now we have to see whether the first and foremost whether the pulp is vital or not, and our aim should be restore the crown if it is present. And how to restore it? First we have to see for any kind of mobility whether the tooth is mobile or not. Now we have to see for the pulp test and see whether any no tenderness is there or not. Now another thing that is very important is the radiographic method, that the three angulations you have to take to rule out any kind of displacement or not. Now, the treatment in enamel dentine fractures is that you have to see with the RDT. You have to see how much of remaining dentin thickness is there. If it is more than 0.5 mm, then you can restore without any pulp protection. And if it is less than 0.5, you can use your Dicel followed by a light cure GIC followed by your composite resin. So basically, if the RDT is good about 2 mm, the prognosis itself is good. Now, patient sometimes can come with the fracture segments. So if you can attach the fragment or rebond it, then it is also good. Now, the follow-up protocol here is that you have to see in 6 to 8 weeks. So it becomes that you have to give a follow-up in 2 months and 1 year, and you have to periodically do the pulp testing, like six to like from it starts from 2 to 4, 6 to 8, 3 to 6, then it becomes to 1 year. Like this, you have to keep on doing the pulp testing, because in case any kind of discoloration happens, then it means the pulp has become necrotic. Then you have to, there is only one option, then you have to go for the endodontic part. Now comes the complicated crown fractures, where along with the enamel and dentin fracture there is exposure of the pulp. So what we will do, we will take one radiograph. Always remember, you have to take radiograph in various angulation to see any luxative movement is there, whether the tooth has displaced or not. So in such kind of cases, when you see the tooth structure is in its position but there is a slight exposure of the pulp, then the choice of treatment actually depends upon the age of the patient. Because for example, if a 7-year-old or an 8-year-old kid comes to you with his broken maxillary central incisor, so what will be your treatment of choice? You have to look that, you have to know that the stages of root development. Because if the crown erupts at around 7 years, you have to add plus 3, that is 7 plus 3, that is at almost 9.5 to 10 years, the complete root formation will happen. So majority of the time, you will, what kind of things you will get? You will get a open apex. So these are the kind of things that you have to get from the patient. The information needs to be taken from the patient. And also the thing that is very important, you have to see the exposure of your pulp. I think it determines whether you are going with a pulpotomy or a vital pulp therapy, because nowadays this vital pulp therapy is everywhere. I think gone are those days where clinicians used to say, okay, go for a root canal. I think you have to give chance to the tooth to survive. So vital pulp therapy has become very important. So you have to see for the diameter of the pulp exposure as well. Now, I have told you, I think the treatment protocol has drastically changed over the period of time. Maybe for someone who has uh, practicing for 20 years, I think for them trauma and endo will be different from what I have learned, what the new generation will be learned, because it is constantly changing. So here you can see the first point, the primary aim is to maintain the vitality of the tooth. Because nowadays what we are doing, we are giving a tooth a chance to survive, because the kind of biocompatible materials we are having, for example your MTA or the biodentine, these things are possible. So coming to the vital pulp, if the pulp is vital and the apex is open, so what you can do, you can do a pulp capping, a partial pulpotomy, or a full pulpotomy. In case of closed apex, you can do a partial pulpotomy if you feel that radicular pulp is vital, and if pulp necrosis happen, then you have to do a root canal. There is no other option. Now, in case of non-vital, if the tooth is non-vital with an open apex, so what you can do, you can do a apexification. I think in our endo practice, we come across this kind of cases with open apex cases, that the tooth that has become non-vital. So you make a MTA barrier, and after that you wait for some time and you backfill it. So that is in case of apexification. Now, regenerative endodontics are also in use. If it is closed, then you have to do a normal root canal. There is no other option. Now, what are the various pulp dressing material? Are your calcium hydroxide, your MTA, and biodentine. Calcium hydroxide, for example, in direct pulp capping, what theories are saying that calcium hydroxide and MTA, they work almost similar, around 90 to 95% of in cases of indirect pulp capping. But when there is an exposure uh, of your pulp space, exposure of your pulp, calcium hydroxide should be avoided for me, because there's a concept called as tunneling effect, whereas these things are not seen in MTA and biodentine. So the MTA and biodentine should be the choice of material here. Now, civics pulpotomy, also known as partial pulpotomy. So it's a very interesting concept. I think uh, this is something that we do, but we don't recognize it. We do direct pulp capping, but we don't know the beauty that we are doing a partial pulpotomy sometimes. So sometimes what happens, there can be a crown fracture which exposes the pulp. So what you can do, you can use your round burr and you go to a depth of around 2 mm to actually remove the pulp. So what you can use a 1% of hypo and in your dip into your cotton and place it for 2 minutes, for 5 minutes. If the bleeding stops, then you can use your ca- they have used a calcium hydroxide liner, because that time that was only available. Over that you can place your GIC followed by your composite resin. So why this method is effective, why this method is still in place, because the superficial inflamed pulp you are removing, because underneath the radicular pulp is vital. And also calcium hydroxide, they some to some extent they disinfect the pulp, and coronal pulp remains, which allows, because you are only taking the superficial pulp. So the coronal pulp to some extent is still there, so the tooth will have a sensitivity test that can be carried out on subsequent visit. For example, 6 7 months later, when you perform a sensitivity test, the tooth can elicit a form of response, maybe a delayed response, but some kind of response. Now, coming to full pulpotomy, the full pulpotomy you have to do under the application of rubber dam. So the indication is that the pulp is inflamed to a deeper layer. Here, there is a superficial exposure of the pulp in civic pulpotomy, but here you have to remove the whole of the coronal pulp. So indications, pulp inflamed to deeper layers and traumatic exposure after 72 hours. Now what happens that after you administer your LA, then you have to eliminate the coronal pulp. Now once you eliminate the coronal pulp, it's like you have to you make the excess cavity, like you make the excess cavity for a molars, for a mandibular molars, so you have to make a small excess cavity like this, and you have to remove the coronal pulp using a spoon excavator, or you can dip your cotton in 1% hypo and place it into the canal. Now you have to wait for around 2 to 5 minutes. If the bleeding stops, then you can place your MTA followed by your GIC followed by your composite. But in case if the bleeding doesn't stop, it means that you have to go for a root canal. Now, another set of fractures is your crown root fractures, without exposing the pulp. Now, according to definition, it involves enamel dentin cementum but not exposing the pulp. For anterior tooth, it can be due to direct trauma. Posterior teeth, it can be due to indirect trauma. It can be due to, if you are biting something hard, it can also make fracture. Now what we have to do, we have to see for the clinical features. Now what you can see an oblique line that can run from incisor to the marginal gingiva, and it can go beyond it. Now you can see a mobile coronal fragment, but it will not be displaced. Now for this kind of fractures where there is a crown root fractures without root canal exposure, you have to know certain there it depends upon certain factors. First, you have to localize the fracture length, whether it has gone below the CJ. Now you have to see for the emergency treatment what you can do. You can actually temporarily stabilize the tooth using a splint, or you can go for a definitive treatment where you have to remove the fragment, or if the fragment is already removed, then you can reattach it. Now another set of fractures is your crown root fractures with pulp exposure. Till now what we have discussed is your crown root fractures without any kind of pulp exposure. Now what happens, the tooth will be tender on percussion. The symptoms will be mild, but there can be pain when you just move the fragment. So there can be chance that the apical extension of fracture line is not visible, so you have to take x-rays. Now what happens when such kind of cases comes to you, you have to always see, you have to ask the patient about the age of the patient, because if there is a pulp exposure with an immature root, you have to do a partial pulpotomy, and uh, partial pulpotomy where you remove the coronal pulp and preserve the pulp vitality. But if it comes with a mature root, then you have to do a endodontic treatment. But sometimes what can happen, the crown height will be very minimum. For you, it will be difficult for you to place the crown. In such kind of cases, either you can go for your post and core if you are able to achieve a ferrule of 2 mm. But if you are not able to achieve a ferrule of 2 mm, then you have to start with your orthodontic treatment to take out the tooth outside, then you place with the post and core. But if the fracture line is too deep, uh, if you can't place a crown, there's no point of restoring the tooth. Better you take it out, place an implant later. If the patient is age is compatible with the implants, you can go with the implants. Now this is very interesting. First is the root fractures. The root fracture means there will be fracture in the cementum and the pulp. So as I have told, always take 3 radiographs, 3 angulation. For root fractures, you have to take the x-rays at 45, 90 and 110 degrees. You have to take IOPS, and you have to take one CBCT to know about the location of the fractures and to be confirmed whether a root fracture has happened or not. Because based on that, we classify the root fractures. First, we tell about the coronal third, middle third fracture, apical third fracture. Coronal third fracture we divide into subcrestal coronal third, supracrestal coronal third fracture, and subcrestal coronal third fracture. Now comes a middle fracture and apical fracture. Now in coronal one third root fracture, the prognosis is less favorable. Always remember, the apical root fractures, the prognosis is favorable, followed by middle fracture, and the least favorable is your coronal one third of the root fractures. So the treatment here is you have to extract the tooth. But sometimes a patient is very adamant that I want to save the tooth. You extract the coronal segment, then perform a root canal, then with an orthodontic extrusion or surgical extrusion, you pull out the tooth to certain to achieve a 2 ferrule. Then you can place or go with your post and core. But this is you have to tell the patient that the prognosis is not good. You have to tell that patient directly. Now, in terms of mid-root fractures, the mid-root fractures actually depends upon the degree of dislocation. If it is the fracture length is continuous, if there is no displacement, then we can think about saving the tooth. Also, you have to think about the status of the pulp or the position of the fracture line. If it is only incomplete fracture line, then you can still uh, save the tooth. Now, the most important is your apical one-third root fracture, where I have told earlier that the prognosis is very favorable, because here you can do a root canal from here to here, but this you can leave it out because here the pulp will remain vital. So in such kind of cases, or in cases where I always feel that patient, I think you people have done root canals, proper BMP, proper irrigation, everything, but still patient they elicit a kind of pain on biting or continuous pain. Then you go for a CBCT, and in CBCT what you see that there is an apical fracture. In such kind of cases, always remember you can place your GP above this fracture line, and you can do it, and you can see the result that patient won't have that kind of pain. The moment you place your gutta percha beyond it, sometimes pain can occur. I think these are the clinical pointers that you can take up. Now, for root fractures, first we have to check the position. I think there are three rules of radiograph that I have already discussed. Then if there is a kind of mobility, then you have to stabilize with the splint, preferably the flexible sprints. Always remember that in endo part, when you are doing a patient, trauma patient, unless and until there is an alveolar fracture, flexible splint works. It works wonder. I think gone are those days where we used to have a rigid or a semi-rigid kind of splints we use. I think they are only used for meant for the alveolar fractures. Now, if you see that there is a pulp necrosis or a discoloration that happens, then you have to do the root canal. Now, healing of the root fractures, it depends upon various factors, and the healing patterns are several types, like the healing with calcified tissue. I think this we have learned in first or second year of our BDS. Now, healing by connective tissue or bone. Now, there can be chances that there will be no healing of the inflammatory tissue. Now, when you see a root fracture, you have to remove the splints after 4 weeks, and you have to clinically and radiographically you have to see. Now, what happens in case when you see the root fracture is near the cervical area, then you have to remove the splint after 4 months, and you have to do a follow-up in 6 to 1 years. Always remember, in normal kind of cases where you are placing a splint, for example in root fractures where there is a slight mobility, place it for 4 weeks. But if it is more towards cervically, then you have to replace the splint after 4 months. Then you have to recall the patient in 1 year. You have to keep on follow up clinically and radiographically. Now, coming to luxative injuries. So, luxative injuries, I have already discussed about the concussion, subluxation, your lateral extrusion, intrusion, and avulsion. Avulsion is completely your uh, knocking or displacement of the tooth. I think for that, you people already know. I think that I will discuss that depends upon the extra oral time the tooth is outside the mouth, and what are the medium where you can store it, that we will discuss. Now, coming to concussion, I have discussed when you are hit by a blunt object, but the tooth is not displaced, but only you will have a slight tender on percussion. So, actually, no treatment is required. You have to see only monitor the pulp condition for almost 1 year to see whether any kind of pulp necrosis is there or not. If pulp necrosis happens, means you have to go with the root canal. Now, in subluxative kind of injuries, you have to sometimes it respond normally. You have to see it respond normally to the sensitivity test or not. You have to see whether any kind of hemorrhage at the gingival margin is there, or you have to see radiographically whether there is any pedial widening or there. If there is a subluxative injury, just you have to adjust the tooth, place it into its position, and splint it for 2 weeks. In case of intrusive luxation, where there is a intrusive movement where the tooth has gone into the alveolar bone, so here you have to see, what you will see, that the crown will always appear shorter than rest of the is adjacent crown. So, and also one of the clinical aspect that you have to see here is the metallic sound on percussion. And always remember, in intrusive luxation there will be, the tooth will be immobile. Now, when you take the radiograph, you will see there will be obliteration of the apical pedial space because the tooth has gone inside the bone, crushing of the lamina dura. Now, for treatment, always remember you have to give the tooth a chance to re-erupt without any intervention. Now, if there is an incomplete root fracture, first you allow it to re-erupt. If there is no movement, then you have to do with the orthodontic extrusion within the 3 weeks. If you are able to achieve a satisfactory, for example, 7 mm, then you can continue with the orthodontic. If it is not, then you have to go with the surgical extrusion. Now, with complete root fractures, same goes, like if you have to allow the tooth to re-erupt. If it doesn't, go for the orthodontic extrusion. If the results are okay, then stop it. If it is not, you have to do the surgical extrusion. Now, in extrusive luxation, it means that the tooth has moved out from the socket, but what you can see over here clinically, there will be, the tooth will be mobile, and it will be respond negatively to the sensitivity or the vitality test, and the tooth will be tender on percussion. So in such kind of cases, radiographically, what you can see, you will see here, you can see a widening of the pedial space apically. Now, what you can see over here, what the treatment protocol should be, that you have to rinse affected area with the saline. You have to reposition tooth back into the socket as soon as possibly using a digital pressure, or wooden, use your finger to place back the tooth. Now, splinting is done with a flexible splint for 2 weeks, and you have to make sure that you uh, deocclude the tooth out of occlusion so that any additional trauma doesn't occur to the tooth. So what you have to do, you have to clean the area, you have to clean it with the saline, you have to place the tooth back, you have to place a splint for 2 weeks, and you have to remove it from the occlusion. Now, coming to the lateral extrusion, where the tooth has displaced in another direction, not in its, in the eccentric displacement, we also can tell. Now, clinically, what we will see, it will be out of its position as compared to the other tooth. There will be pain on percussion, since it can embed into the bone. There can be metallic sound, and always remember, with luxative injuries there will be gingival bleeding. So you will see a widening of the PDL, and here also what happens, that you have to place the tooth back into its normal position, splint for 2 weeks. Now, in intrusive, you splint for 2 weeks, but here you splint for 4 weeks with passive and flexible splint. Means it is the only time when you can use a semi-rigid kind of splint here. Now, follow-ups, how you do the follow-ups in such kind of cases? You follow up after 2 weeks, 4 weeks, 8 weeks, 12 weeks, 6 months, 1 year. So when a patient with luxative any kind of trauma, this should be the follow-up for the patients. Now coming to avulsion. Avulsions means the tooth has completely gone out of the socket. So in kind of cases where the most important, the most critical tooth that happens with avulsion is your central incisor. Now the prognosis, it depends upon the what happens, what the patient or his accompany, maybe his parents or friends do at the site of incidents. It has to do a lot with the treatment planning for avulsion. Now there can be chances that we have to do a reimplantation because the tooth is already knocked out, so we have to reimplant the tooth. So the most important aspect that you have to know with avulsion, that about the pedial fibers. So if the pedial fibers are most viable within maximum 15 minutes, so when a patient comes to you within 5 to 10 minutes of the accident, you can place the tooth directly, so the pedial cells will be the most viable at that time. So once pedial cells may be viable or compromised when the tooth is kept in a storage medium, but with external time less than 60 minutes. If a sometimes if a child falls, a tooth is knocked out and it is stored, for example, in his own mouth, and it comes to the doctor within 30 minutes or before 1 hour. So the pedial cells will be still viable, but to some extent it will be compromised, but still you can work with that. But if it is more than 60 minutes, then the pedial cells are non-viable. They have all gone, so you can't do anything. Now, it depends upon the extraoral time. When avulsion, I think in BDS, this is a very common question. What should be your treatment protocol for avulsion? So always remember, first we have to write with the pedial cells. We always used to write with the pedial cells viability, whether the patient comes in uh, immediately 15 minutes or 30 to 60 minutes or beyond 60 minutes is the extraoral time. So based on that, we determine what kind of treatment protocol needs to be done. Now, first, the tooth has already been reimplanted at the site of avulsion. Now, there may be some parents who might be knowing that if the tooth comes out, you can place it back. So there may be some parents who can do that themselves to their child, and later they can bring to the dentist. So in such kind of cases, carefully hold the tooth by crown and gently wash under the running water. Avoid touching and scraping of root surface. Have the patient rinse his or mouth. Replace tooth in socket using gentle steady finger pressure. Take the patient to dentist. This is something at the site of incidents, where the incidents occur. As a general information, if you want to give to the patient, you can give like this. Now for close apex, immediate treatment, leave the tooth in place, clean the affected area with water and saline, then suture the gingival laceration. Now you have to verify the normal position radiographically. Now you have to apply both the passive and flexible fluid for 2 weeks, and after 2 weeks of the reimplantation, then you have to go for the RCT. Now few of them will be telling that why are not doing the RCT externally. I think these are the new guidelines by American Association of Endodontics in Traumatology. I am just elaborating on that because in India still there are people who are doing extraordinary root canal and then placing, I think I don't know, I think reimplantations they are doing, but these are the protocols that are American Association of Endodontics they are also following. For open apex, the immediate treatment now, previously it was for the close apex. Now for the open apex, you have to leave the tooth in place, clean the affected area with saline and water. Any kind of gingival laceration, you have to suture it. Radiograph you have to take to verify the normal position. Apply your splints for 2 weeks. Now You have to take from two angulations like your mesial and distal shift. Now, for open apex, our aim should be for the reimplanting is developing an immature teeth is to allow possible revascularization. So the root canal treatment should be avoided unless the signs of pulp necrosis it occurs. Now, if the patient or the parent cannot place the tooth, then it should be carry in transport media. So various kind of transport medias are there, like your Hank's balanced salt solution, patient's own saliva, propolis and Viaspan, milk, water, coconut water. So these are the storage medias for storing the tooth. Now, if the extraoral dry time is less than 60 minutes, now if the extraoral dry is 60 minutes, first you have to administer the local anesthesia and you have to irrigate the socket with saline, or you have to irrigate with a 0.2% of a chlorhexidine. You have to examine the socket as well, whether any kind of fracture has occurred or not. Then you have to take x-rays from two angulation, two shifts, mesial and distal, and have to confirm the position of the tooth to rule out any kind of alveolar fracture. Now here also, like I have discussed, for tooth with less than 15 minutes, you if for close apex, you are placing the tooth, splinting it, calling the patient after 2 weeks, then starting with the root canal. If it is open apex, you are placing the tooth, uh, putting splint for 2 weeks, wait if root canal is required or not, or any kind of revasculation occurs or not. Okay, but if external time is less than 60 minutes, treatment protocol changes. So what you are seeing here, you are drying the socket. Now you have to see whether it is a closed apex or an open apex. When it is a closed apex, you have to remove the necrotic tissue, irrigate the socket with saline, and you have to implant the tooth gently with the digital pressure. And here also you have to apply passive and flexible spin for 2 weeks, but here you can have to give a systemic antibiotics to the patient, and you have to initiate RCT for the patient after 2 weeks of the reimplantation. This is same as the treatment we are doing for less than 15 minutes as well. Okay. Now for open apex, same, you have to remove the necrotic, irrigate the socket, reimplant using gentle pressure. You have to apply sprint for 2 weeks. You have to apply systemic antibiotics. Now, previously also I have told that in case of open apex, your primary goal should see any kind of revasculation happens. But if it doesn't happens, then you have to go for the root canal. Now, what happens if it is more than 60 minutes? So now if it is more than 60 minutes, you have to administer the LA. Same, you have to irrigate the socket, chlorhexidine. Same radiograph you have to take. And for close apex, you remove the necrotic, reimplant with digital pressure. Again, you do the splint, systemic antibiotic, and you go with the root canal after 2 weeks. Same goes with the open apex as well, but you have to see whether revasculation happens or not. Now, follow-ups, how you determine the follow-ups, I have, or you have already seen the follow-ups is after 2 weeks. The follow-it after 2 weeks, and clinically and radiographically, you have to recall the patient at the 4 weeks, 3 months, 6 months, 1 year, and thereafter, if possible. I don't know patient will come after 5 years, after 5 years or not. Now, this is very important. According to International Association on Dental Traumatology, what you can see over here in subluxation, extrusion, lateral luxation, intrusion, root fractures in the cervical third, avulsion, they have all recommended a flexible type of splint. The only area where a rigid splint is used is your alveolar fracture. Now, this type of splints, there comes as a rigid splint or non-rigid splint. So, ribbon, is a mesh fibers, they are used with your flowable composites. So these are kind of your flexible splints. Now you have a wire splint, a suture splint can be placed, a composite splint can also be placed. Now a rigid arch bar splints are only applied when you see a kind of alveolar fracture. That time you use a arch bar splint. Now, response of pulpal trauma, we have to see when a tooth is hit by a object and you don't do a treatment for a longer period of time. So the three things that can happen. So what one is that the pulp will heal on its own. Second, there can be a pulp necrosis. If a pulp necrosis happens, then it means that the pulp is non-vital. You have to go with the root canal. Third is a pulp canal obliteration. I think this is why I always tell, when you see a discolored tooth, don't jump with the root canal without taking a pre-op radiograph. You have to see whether pulp is obliterated or not. It means that pulp is calcified or not. Now, pulp healing, it depends upon pulp, when the pulp is exposed or the damage to the pulp or age of the patient. So in case of older patient, they may be actually symptomless, because what happens, with age, your pulp horns are actually, they recede. But for younger patients, pulp horns are actually in their perfect position. So the patient will have a more sensitivity to the temperature changes. Now, in case of pulp necrosis in fully formed tooth, you have to go with the endodontic treatment. In developing tooth, actually, if pulp survives, if pulp necrosis itself means that pulp is not surviving, then you have to go for the other modalities like apexification. Now, you can see a pulp canal obliteration. You can see here, you can see the canal over here, but here you can see a canal. So it means that it has become calcified, it has become obliterated. There is no pulse space here, so where you can initiate a root canal. So in such kind of cases, you can't do anything. You can't do initiate with the root canal. Patient for long term, long for many years, they remain symptomless. Now, what happens, what are the consequences of this tooth avulsion? When the PDL remains hydrated and cell viability is maintained, it will repair in implantation. So, what is the procedure? How to hold a tooth in case when the tooth is out of the socket? You should always hold from the crown portion. Put a saline on the root surface so that the PDL are hydrated. So when the PDL are hydrated, cell viability is maintained, and you do the reimplantation, you will get a good positive result. But if dry occurs, then what can happen? So the root will be replaced by bone, causing osseous replacement or replacement resorption. So always remember that you have to hydrate the tooth. If you don't hydrate the tooth in case of your reimplantation for your avulsed tooth, then there is no point of doing the treatment. Now, coming to the conclusion, most traumatic dental injuries constitutes of two dental emergencies. In comparison to bodily injuries, dental trauma may not be serious. However, teeth has the lowest potential of any tissue returning to the normal healthy states after injury. So, rational therapy and accurate diagnosis must be instituted. Treatment modalities in modern world are very effective provided that management is done on time. Patient compliances and follow-up visits and home care contributes to better healing. Thank you.
Thank you so much, sir. I hope everyone will practically use these tips told by you in their clinical practice. Is there any question, participants? You can ask in the chat box. So there is a question. We
Okay.
have That in the next visit, do we have to wash it?
Chat box, no? Wait.
Yes, sir.
Chat box. I'm not. What's the question, by the way?
Sir, in next visit, we have to wash question mark. This is the question, sir.
No, no. This is actually you don't have to wash on the next visit. You have to wash on the first day itself. When the patient comes to you, for example, what to wash when the tooth is avulsed or it is knocked out from the socket. So the patient will come with the tooth. You have to clean the socket that time. Got it? That time only you can do. But once you place the tooth, there is no point of cleaning again. It is already splinted. So why you which number of wires should be used and which material? I think I have shown you a very interesting table of the recent International Association of Dental Traumatology regarding the splinting, regarding what kind of splints are usually used. So basically, what you can do, you can use a ribond instead of your normal wires, because these are more flexible. And if you want to use a orthodontic wires, you can use, generally you can, what you can bend, and you can do it with the composite, but it's better to use the ribond because these are more flexible, and these are much better nowadays. This should be used. I think traditional methods, what traditional practitioners were using 25, 30 years down the line, I think that needs to be changed. Any other question?
There is no such question, sir. I think so. Thank you so much, sir.
Okay. Thank you, everyone.
Thank you, everyone, for joining us in the Endo Mastery Summit. With this, we come to the end of the online conference. Hope you all learned something and taken some valuable knowledge from these 2 days of lectures. And thank you to all the speakers. Thank you so much, everyone.
Thank you.